Very good morning. I am audible and visible. Swati Kannan, Amrit Sam, Dr. Demon. So welcome to INI-CET Marathon session Forensic Medicine. So we are going to discuss some very important concepts very commonly asked in our INI-CET exam. I am audible and visible. Yes, Demon, Swati Kannan, Amrit Sam. Yeah. Okay. So as you know, forensic medicine is one of the very scoring subject and very easy subject. Usually there will be 8 to 10 questions in your INI-CET exam. Let's start with the marathon session with a few important MCQs. You can interact with me. You can answer in between. Okay. Yes, Amit, fine. That's okay. The first question, the very commonly asked, update the criminal codes, BNS, BNSS and BSA. Bharatiya Nyaya Sanhita, Bharatiya Sakshya Adhiniyama. Okay. Which of the following define offenses and punishment? Define offenses. Like example, rape is a heinous crime defined under section 63, punishable under 64. Which of the following define offenses and punishment? BNS, BNSS, BSA, TOTA. So TOTA is basically Organ Transplantation Act. It is not the answer. BSA basically Bharatiya Sakshya Adhiniyama, that is related to evidence, like section 26(1) dying declaration. BNSS basically related to investigation, the procedure to be followed in case of crime, like example 194 BNSS police inquest, 196 BNSS magistrate inquest. So the best answer is BNS is the correct answer. Good. So many answered. Amit, Swati Kannan, great. So what you need to understand, so Bharatiya Nyaya Sanhita 2023, so this is a new code replacing your IPC. Bharatiya Nagarika Suraksha Samhita, that is BNSS, that is replacing CRPC. BSA, that is replacing Indian Evidence Act. Okay, so this can be asked in your exam. So try to understand all these are very commonly asked BNS. Like 63 BNS, definition of rape. (64) punishment for rape. Again, 64 divided into 64 1 and 2. 64 2, that is custodial rape. 66 rape and murder. 67 sexual intercourse by husband with the wife during separation without her consent. So 67 basically between wife and husband. 68, that is sexual intercourse in authority by using his power, that is sexual intercourse by abuse of power, by authority. You can remember 68, 8 authority, authority. 70, that is gang rape. 71 repeat offenders. 88, 89, 90. Can anyone answer? 88, 89, 90. Yes, Somu. Can you try? 88, 88, 89, 90 criminal abortion, 88 criminal abortion with consent, 89 criminal abortion without consent, 90 criminal abortion leading to death of the mother. So in simple word, it is criminal abortion. 22 BNS, very commonly asked, that is McNaughton's rule, criminal responsibility of insane. McNaughton's rule. 116 grievous hurt. As you know, grievous hurt, there are 8 subclauses that is commonly asked in INI-CET. The last class that includes inability to do ordinary pursuit for about 15 days. Previously it was 21 days, now it is 15 days. So all these are commonly asked. Abortion, correct. Now, some more BNSS commonly asked in the exam. 194 BNSS. Police inquest. 196 magistrate inquest. 184 BNSS. So can anyone try? What is 184? 184 BNSS. So let's see who is going to answer. What is 184? Gaurav? 184 is the medical examination of victim of rape. With the consent. The 52 BNSS accused of rape. So this is commonly asked in the exam. One more, try to remember BSA. In BSA, the very important is 26(1), that is dying declaration. So this is very, very important topic, commonly asked in the exam. चल ठीक है, fine. Is it clear? Any doubt in this? Yeah, Gaurav, good answer. Good answer, Gaurav. Yeah, 26 is dying declaration. So the question again can be asked, difference between dying declaration, dying deposition. Dying declaration is followed in India. Dying declaration can be recorded by any person. So like magistrate, police, but the role of doctor is to give an opinion about compos mentis. Even doctor can record dying declaration. So dying deposition is not followed in India, it is followed in US. So where the statement is taken in presence of the magistrate, the accused and the accused advocate. That's fine. Chal, theek hai. Now, look at this question and try to answer. Husband having intercourse with wife of age is less than 18 years amounts to rape if case is filed within 1 year. True or false? Good answer. Acid attack 124. Husband intercourse with wife age less than 18 year. Remember, juvenile means male or female less than 18 year. So answer is true. It is true statement. So because statutory rape. The statutory rape is having sexual intercourse with female of age less than 18 year with or without consent is considered as rape. Okay? Yes, true it is. Fine. Chal. The next question, very commonly asked in INI-CET from the asphyxia. In asphyxia, important topics are hanging, strangulation, suffocation, and drowning. So after the class, go through these 4 topics frequently asked in the exam. Following is surest sign of antemortem hanging. Antemortem, as you know, the person was alive at the time of hanging. Hard bone fracture. Hard bone fracture is non-specific. It can be seen in throttling. So inward fracture is seen in case of throttling. Outward fracture seen in case of hanging. It is non-specific. Left face is sympathetic. Again, very commonly asked. The one eye is open, other is closed because of the compression of cervical sympathetic chain. Ligature mark, oblique ligature mark in case of hanging, transverse ligature mark in case of ligature strangulation. The transverse ligature mark can be seen in partial hanging also. So dribbling of saliva is the correct answer. So good dribbling of the saliva. So this is the dribbling of the saliva. One of the surest sign of antemortem hanging. 3 important questions. The surest sign of drowning, cadaveric spasm. Surest sign of burn injury, antemortem burn injury, that is soot particles in the respiratory tract, that is alveoli, trachea, bronchi, and the lungs. Very commonly asked in the exam. Okay? Okay. Now look at this. This is favorite of examiner, especially in case of hanging. The one eye is open, other eye is closed. On the same side of knot. So same side of knot. So what is the best answer? Try to answer. What is this? So there are many MCQ can be framed from this. So this finding is lay face is sympathetic. Because of compression of cervical sympathetic chain, CSC. It is seen on the same side of the knot. And try to remember oblique ligature mark, hanging, transverse ligature mark in case of strangulation. And the ligature mark is a type of pressure abrasion. When the pressure is applied to the body, which is perpendicular to the body for a long time, so there can be dry hard parchmentization, that we call it as pressure abrasion. That is a ligature mark. The ligature mark, one of the very important finding in case of hanging. Okay? Yes. Same side. Good. That's great answer. The next question, one frequently asked, can be image based question or some sentence based question. The manner of death in autoerotic hanging. Autoerotic hanging known as sexual hanging. Codes varism. It is associated with masochism, transvestism, and all. So there are different criteria to diagnose autoerotic hanging. It's basically associated with sexual perversion. The manner of death in autoerotic hanging, that is very simple. That is accidental. Very good. Suicide is the most common one. The commonest method of suicide in India, as per the record, that is hanging. Hanging causes painless sudden death in 3 to 5 minutes. Homicidal hanging, known as lynching. In lynching, we normally see abrasion, bruise, and lacerations. Judicial hanging, the cause of death is the fracture between C2, C3. We call it as hangman fracture. So this is classical case of autoerotic hanging, and the classical feature is rescue mechanism. Rescue mechanism. It can be seen in females also, but very common in males. Commonly associated with masochism, transvestism, Yes, fine. चलो हो गया. So very important topic in INI-CET, drowning. So can anyone tell me what are the biochemical abnormalities in freshwater drowning? Frequently asked. Freshwater drowning में biochemical findings क्या है? Fresh water. Try, all of you, just listen to me. Yes. In fresh water, remember, one very common finding is hyperkalemia. Hyperkalemia. Point number one. The point number two, in case of freshwater drowning, lungs are emphysematous. Okay, lungs are emphysematous, and pleural effusions are very commonly seen. And there will be hyponatremia. Hyponatremia, hypomagnesemia, and rest all are hypo. So this is frequently asked. So this hyperkalemia that causes ventricular fibrillation or ventricular arrhythmia, death occurs in 5 to 6 minutes. In seawater, so there will be myocardial anoxia. Myocardial anoxia. So frequently asked. Yes, fine. That's great. One more favorite of examiner. In fact, it is my favorite question in my lectures. Cafe coronary due to banana. That is cafe coronary syndrome. What is the cause of death? Can anyone tell me? What is the cause of death in cafe coronary syndrome? Cause of death. And remember, cafe coronary syndrome, cause of death is vasovagal inhibition. It should be differentiated from choking. In choking, signs of asphyxia very common. Congestion, cyanosis, petechial hemorrhages. But these signs are not seen in case of cafe coronary syndrome. It mimics like a heart attack. So vasovagal inhibition because of the foreign body in the larynx, which stimulates recurrent laryngeal nerve, superior laryngeal nerve, causes myocardial arrest. So associated with alcoholism. Frequently asked. Signs of asphyxia very minimal. Very minimal. Okay? Yes, vasovagal inhibition, that's great. Fine, that's okay. So now mechanical injuries. See, mechanical injuries are classified into blunt force injury, sharp force injury. Injuries are caused by blunt force. So what is the answer? Very simple question. Abrasion is a superficial mechanical injury caused by the blunt force. Bruise is also known as contusion. Laceration caused by blunt force. Stab wound that is caused by the sharp force. Right? Look at this. So this is what given in the workbook. This I'll share after the class in the telegram. You don't worry. So blunt force injuries are abrasion, contusion, laceration. Sharp force injuries are incised wound, stab wound, and chop wound. Firearm injuries are classified into a rifled wound and a smoothbore weapon. So abrasion again of 4 types. Scratch abrasion, graze abrasion, pressure abrasion, and imprint abrasion. So most common abrasion is graze abrasion. It is also known as brush burn. In road traffic accident, one of the commonest finding is graze abrasion. Pressure abrasion seen in case of hanging and strangulation. Imprint abrasion, example tire mark, radiator grill mark and all. Scratch abrasion commonly seen in case of throttling, in case of sexual offenses like rape. Contusion, again contusions are classified into superficial contusion, deep contusion, delayed contusion, tram track contusion, migratory bruise and all. Frequently asked in the exam. And one more frequently asked question after the class, go through artificial bruise. Artificial bruise. This is INI-CET favorite. So artificial bruise, it's the false or feigned bruise produced by the organic irritants, like example calotropes, semicarpus anacardium, plumbago rosae and all. It has a regular margin. So it's because of the serum exudation. It is seen usually over the accessible body parts. Then laceration, again there are 4 types of laceration: split laceration, stretch laceration, cut laceration, Owl's laceration and all. One frequently asked in exam is Owl's laceration. Owl's laceration characterized by detachment, fleeing, amputation, deglowing and all. So incised wound, again there are different types are there. Stab wound, different types. So chop wound caused by the sharp force. Good. So this you can just go through after the class, don't worry. Now here comes is rifled weapon. What do you mean by caliber in case of rifled weapon? Frequently asked. Can anyone tell me? What do you mean by caliber in rifled weapon? So rifling means presence of lance and grooves. When lance and grooves are there, increases velocity, increases speed, penetration power. The distance between the 2 opposite lines is known as caliber. So caliber is distance between 2 opposite lines. Distance between 2 opposite lines. Yes, very good. Good answer. चल आगे देखते हैं. Now identify the type of abrasion. Image based question, frequently asked in INI-CET. Now look at this A and B. Try yourself. So in A you can see the parallel lines. So in B you can see the tire mark. What are these 2 types? Try. Yes, Devank is selling, sir. It is a graze abrasion. So it's a graze abrasion, and this is imprint abrasion. Imprint abrasion. Okay, good. Pattern abrasion. So pattern abrasion is of 2 types: imprint abrasion and pressure abrasion. Even pressure abrasion also a subtype of pattern abrasion, because in some cases of hanging, by looking at the ligature mark, you can tell about the pattern of the ligature material that is used. So pattern abrasion is of 2 types: imprint abrasion and pressure abrasion. Okay, that's great. Many answer. So I think first to answer by, I think Sanjeev, very good Sanjeev, and Swati Kannan. Swati Kannan. Now one question about incised wound. All are features of incised wound except margins are clean cut, averted. Yes, that is true. Incised wound caused by the sharp weapon, true. Caused by sharp weapon, definitely true. Spindle shaped, that is also true. Presence of tissue bridging. Tissue bridging is commonly seen in case of laceration. Tissue bridges, muscle bridges, blood vessel bridges, skin bridges. Classical feature of laceration. Laceration caused by blunt force. So the answer is D is the correct answer. It is a repeat question in your INI-CET exam. Okay, D is the best answer. Good. So look at this. So this is the image. You can see here, this image is basically tissue bridging. The tissue bridging is a feature of laceration. It is commonly seen in case of split laceration. The split laceration commonly seen over bony prominences, so between the 2 hard objects. It is also known as incised looking laceration. Inside looking laceration. Can anyone tell me laceration looking incised wound? What are the sites of laceration looking incised wound? So incised wound looks like laceration because of the presence of the superficial muscle. What are the sites? चलो देखते हैं. Open to all. Very good, very good. Scrotum, good answer. Scrotum, axilla, the neck. So 3 regions where incised wound looks like a lacerated wound. Okay? Fine. Commonly asked in the exam. So that's great. आगे देखते हैं. Now cutthroat injury. Favorite of INI-CET. All are features of suicidal cutthroat injury. Suicidal cutthroat injury, except presence of tentative cuts. Tentative cuts are also known as suicidal cuts. They are commonly seen in case of suicide, attempt to suicide. Only one wound is deep. Yes, one wound is deep, like this. This is a major wound surrounded by tentative cuts like this. So this is a major wound. And all these are minor. Presence of cadaveric spasm. Yes, cadaveric spasm is antemortem. Cadaveric spasm is antemortem. It is one of the very important finding in case of suicidal cutthroat injury. Like firearm in the hand, knife in the hand, cadaveric spasm. Presence of defense wound? No. So answer is defense wound. So defense wounds basically seen in case of homicide. Again, INI-CET favorite, active defense wound and passive defense wound. Active and passive. Okay? Now look at this. Is it active wound or passive wound? Yes, guys. Is it active defense wound or passive defense wound? So here injury is there over the palm, in between the web fingers, between the web space. So here the person is trying to grab the weapon. So is it active defense wound or passive defense wound? The passive defense wound commonly seen over the dorsum of the hand, the back of the forearm or front of the forearm, when victim tries to escape from the injury. So what is this basically, active or passive? So very good, many answered. Sir, a active injury hai. So this is very good answer. Active defense wound hai. Very good. Chal, next firearm injury. Firearm is favorite of INI-CET. Especially difference between entry wound and exit wound. All are features of firearm entry wound except abrasion collar. Abrasion collar is because of the spinning movement of the bullet. Spin. Averted margin. What happens in entry wound? Inverted margin, not the averted margin. Presence of blackening. Yes, blackening because of soot particles. Presence of tattooing. Tattooing is because of the gunpowder. GP. So the answer is B. Averted margin. And try to memorize simple funda. When there is a tattooing, it is a near shot. When there is a blackening, it must be close shot. When you see stellate wound, that is contact entry wound, muzzle imprint, stellate wound, inverted margin, all these are features of contact entry wound, frequently asked in INI-CET. Okay? Yes. Chalo. Now, after the class, go through the notes. Entrance wounds are small, inverted margin, abrasion collar present, blackening present, tattooing present, fat protrusion is not seen except in contact shot, tissue may be cherry red, fibers of clothing may be turned in, lead ring can be seen on the radiological examination. So, and look at this differences between entry exit wound frequently asked in the exam. Go through this after the class. Good. And beveling of the skull. Remember, inner table beveling, entry wound. Outer table beveling, exit wound. Inner table, entry wound है. Outer table होगा तो exit wound है. Frequently asked है. बहुत बढ़िया, ठीक है. Now blast injury. Blast. Secondary blast injury is caused by. So there are different types of blast injury. We call it as primary, secondary, tertiary, quaternary, and quinary. 5 types are there. In simple word, primary caused by the blast wave. So the primary blast injuries are common over the tympanic membrane, lung and intestine. Lung, intestine, tympanic membrane, primary blast wave. So blast wave can be unidirectional, bidirectional, multidirectional, any direction. Secondary is because of the flying missiles. Flying missiles. Tertiary because of victim displacement. Quaternary is because of structural damage. And quinary is because of the radiation. Okay. So the answer is secondary missile, that is a flying missile, is the correct answer. The most common blast injury, secondary blast injury. Most common blast injury leading to mortality and morbidity, your answer should be secondary blast injury, especially in air blast injury. Okay, frequently asked in the exam. Yes, martial triad. I think one student answered Dhanu Gowda. Yes, Dhanu Gowda answered, sir, martial triad is seen in. So martial triad is seen in case of secondary blast injury characterized by punctate abrasion, punctate bruise, and punctate laceration. So frequently asked in the exam. Now torture method. Identify the torture method. So beating on the palm and sole, what is that known as? Okay, very simple question it is. It is basically phalanga. है ना? Try. Yes, phalanga, correct answer. Now this is the phalanga. Phalanga. Fine. Now there are 6 torture methods are there, you need to identify. So this is A, B, C, D, and E. So try this methods, image based questions. So NEET PG and INI-CET commonly asked. Torture methods. So B is very easy, that is phalanga. What is A? Parrot perch. Parrot perch. What is C? What is C and what is D and what is E? So D, very simple, dry submarine. This is wet submarine. So this is La Bandera. La Bandera. Suspension at the level of wrist is La Bandera. Suspension at the level of ankles is known as D. Murcielago. So frequently asked in the exam. Okay. So parrot perch, good. Many answered. Gaurav answered. That's great. That's great. So this is parrot perch. So try to memorize. It causes positional asphyxia and death. So after the class, go through all these torture methods. एक phalanga known as bastinado, telephono. So this is telephono. Wet submarine, dry submarine, parrot perch, cattle prod. Cattle prod basically electric shock, especially over the genitals. Chapua. Chapua, legs and thighs are tied very tightly with the bamboo sticks to induce severe pain. Gotna. Gotna is similar to Chapua. Okay. So 2 policemen standing on the wooden leg over the thighs. then sham execution, dunking, and declaration of Tokyo. So declaration of Tokyo by World Medical Association is related to torture methods, and also Istanbul Protocol, frequently asked in the exam. Yes, Danish Gowda, is it okay? Are you getting my point? This is very important topic. Go through this after the class. I will provide you the notes, all the topics, don't worry. So shall I move ahead? Are you okay? Yes, Danish Gowda, Amit, Somsu, Gaurav, Sanjeev, Ankit, Devank, Demon, are you there? Swati Kannan, yes, chal, theek hai. Now frequently asked, the injuries caused by increased heat. So nowadays, the temperature, environment temperature is very high. So the common complication is heat syncope and heat stroke, heat exhaustion and all. So true about heat stroke or sunstroke. So very simple question. Impaired consciousness, yes. Cerebral dysfunction, yes. Core temperature more than 41, yes. Sweating. So sweating is absent. The sweating is controlled by autonomic nervous system, basically hypothalamus. So hypothalamus is damaged in case of heat stroke. So the answer is loss of sweating, no sweating at all. This is about heat stroke. And in case of hypothermia, generalized hypothermia, so there are two conditions commonly asked in INI-CET. One is hide and seek syndrome, or terminal burrowing, and the second one is paradoxical undressing. So this can be commonly asked in your exam. Generalized hypothermia. Sometimes this paradoxical undressing mimic like sexual assault, especially in case of females. Okay? Hide and seek syndrome can lead to asphyxia and death. So because of the impairment of the higher centers of the brain because of extreme cold. Okay, good answer. Chal. Then the favorite question of the examiner, rule of 9. There will be one question in exam. Either rule of 9, Palmer rule, Browder formula, Parkland formula. So very frequently asked. So rule of 9 is given by Wallace. So entire body is divided into 11 quadrants. So 9 into 11, 99, Pudendal area 1. So it's one of the very commonly used method in forensic medicine, usually in postmortem, usually in prognosis, and also in the treatment also. IV fluid administration by using Parkland formula. 30-year-old female presented with burn injuries involving entire abdomen. So entire abdomen means 18%, front and back. Both the lower limbs. So both the lower limbs means 18 plus 18. What is the percentage of burn? So percentage of burn is basically 54. So the answer is 54. Yes, so answer is 10. 54 is the correct answer. Great. That's okay. So go through this. Head and neck area 9%, trunk, front, back 18%, genital area 1%, arm is equal to 9%, leg is equal to 18%. Okay, one Palmer rule, one palm of the one patient palm is equal to 1%. In children's we use Browder formula. Parkland formula, you know, that is commonly asked. Okay, okay. Chal. Next comes is bone injuries, whether antemortem or postmortem. Very specific finding in antemortem bones. So there are many findings: carboxyhemoglobin, line of redness, presence of inflammation, presence of pus formation, crow feet sign. There are many signs. Heat hematoma, heat fracture, pugilistic attitude, line of redness. Heat hematoma, heat fractures, so all these are post-mortem artifacts. So they can be post-mortem artifacts. They can be ante-mortem also. They can be post-mortem also. So that's why no medico-legal significance. So line of redness is a feature of ante-mortem burn. Not only line of redness, but also soot particles in the trachea, bronchus and the lungs. So answer is basically 11. Good, 11. Pugilistic attitude is no. Answer is D. Line of redness. So line of redness is a sign of inflammation. So that means it is ante-mortem. Okay, so this is pugilistic attitude. Also known as boxing attitude. It is because of the coagulation of muscle protein because of the extreme heat more than 70 degrees Celsius. Elbow are flexed, wrist are flexed. So hands are extended. So like a boxing appearance. Okay. Okay. Yes. Pugilistic attitude can be ante-mortem beta. It can be ante-mortem. So it can be post-mortem. That's why. Non-specific hai. That's why. Yes, so Somu Subhadra, Somu Barras, so it can be ante-mortem or post-mortem, इसलिए non-specific है, so answer है line of redness. So आपको पता होना चाहिए what are the signs of ante-mortem burn. Now look at this, guys. What is the finding here of ante-mortem burn? So this is ante-mortem burn. So what is the finding? So here is one finding. Here is one more finding. What are these two findings? So finding is blisters with line of redness along with the proteins, albumin inside it, line of redness. And you can see the tattoo here, Om tattoo. So tattoo is also a very important component of identification. By looking at the tattoo, you can identify the age, you can identify the personality and all. When tattoo is not visible, you can dissect the lymph nodes. Okay? Yes. So answer is blisters hai. Good. Now look at this. This is lung. Lung of ante-mortem bone injury. So what you can see here, black dots. So there are many black dotted appearance. ये क्या है बताओ? जल्दी बताओ ये क्या है? So these are basically soot particles. So one of the surest sign of ante-mortem burn. So one more, remember, crowfeet sign. Crowfeet sign. So frequently asked in the exam. So that's great. चलो आगे देखते हैं. Cause of death in below case of postmortem staining. The postmortem staining, as you know, collection of blood in the dependent area which has a regular margin. The normal color is purplish red or purplish blue. It's because of the gravity. The fixation occurs in 6 to 12 hours. By looking at the color of the postmortem staining, we can identify the cause of death. So look at the postmortem staining here. The color is cherry red. Whenever question cherry red, carboxyhemoglobin. Whenever carboxyhemoglobin, your answer must be one of the asphyxiant, which causes silent death when the level is more than 70% each. So, what is the classical answer? The opium है ना, black color, yellow phosphorus, yellow color, hydrogen sulfide, green color or bluish green color. So, answer है carbon monoxide. Carbon monoxide is the correct answer. ठीक है? A is the correct answer. A, good. Now, after the class, go through this. Phosphorus, carbon monoxide, nitrate, chocolate color. Hydrogen cyanide, bright red or pink color. So when I talk about hydrogen cyanide, I remember very famous case of Jolly Joseph. Curry and murder case. Okay? Curry and murder, hydrogen cyanide. Refrigerated body, bright pink. Opium, black. Hydrogen sulfide, bluish green. Clostridium perfringens, bronze, greenish brown. Very, very important. Color. So the fixation occurs in 6 to 12 hours. The fixation means extravasation of blood from the blood vessel into the tissues. Once they are fixed, there is no color change on compression. That is fixation. And in case of hanging, in upright position, it is commonly seen in the lower limbs and upper limbs. That is known as glow and stalking hypostasis. In case of drowning, normally in case of drowning, it is usually on the front of the face, front of the body, and front of the leg and all, and lower part of the lower limbs. So that is head down and buttock up position in case of drowning. Okay? Good answer. Rape is defined under which of the following section? You know, rape is a heinous crime. Rape defined under. Rape is a legal term. It includes 4 keywords: penetration, insertion, manipulation, and application. Even application of mouth into genitals, or even partial penetration, even labia majora, so that can be rape. The legal age for consent is 18 years. Otherwise, it is known as statutory rape. So, what is the best answer? 116, no doubt BNS, grievous hurt hai. 80, dowry death. 64, punishment. 63, definition है. So answer क्या है? So answer is 63. Many answered. That's great. Okay. So the sexual offences are classified into natural, unnatural, sexual perversion, sex-linked offences. In natural, we have rape, incest, and adultery. Unnatural, sodomy, buccal coitus, bestiality, lesbianism. Sexual perversion, we have many: sadism, masochism, necrophilia, fetichism, transvestism, exhibitionism, masturbation, proterism, andinism, and all. Sex-linked offences: stalking, voyeurism, sexual harassment, trafficking, indecent assault, and all. So rape is no more natural sexual assault, even it can be unnatural also. Yes. So anyway, so this is the classification, old classification given in the most of the textbook. That's okay. Now याद रखना पड़ेगा आपको, घोर आघात करना. घोर आघात करना मतलब serious injury, मतलब not a simple hurt. That is grievous hurt. Section 116 BNS. याद रखना पड़ेगा, in 116 we have 8 sub clauses. 8 clauses are there. So clause 1 क्या है? Emasculation. Clause 2, permanent privation of sight of either eye, permanent privation of hearing of either ear, deprivation of memory member or joint, destruction of permanent impairing of power of memory member or joint, permanent disfiguration of face, fracture dislocation of bone or tooth, any hurt which endangers life, which causes sufferer to be during the space of 15 days in severe bodily pain, unable to follow ordinary pursuit. So all of you write in the chat box, 116 is equal to 15 days. So write this in chat box. So previously it was 20 days, now it is 15 days. Please write 116 BNS is equal to 15 days in the YouTube comment section. Yes, Swati Kandan, that's great. Identify the sexual perversion given below. So there is a sexual perversion given below. So probably a male and a female, self-defeating condition. Self-defeat, humiliation by the partner or pain by the partner, pain from the partner, sometimes associated with autoerotic hanging, abnormal sexual behavior. What is that known as? Is it sadism? So it is masochism, self-defeating condition, and opposite is sadism, the combination known as bondage. So transvestism is known as eonism. Fetichism is basically inanimate objects. Okay. So after the class, go through this. Sadism, masochism, bondage, fetichism, proteurism, exhibitionism, transvestism, uranism, buccal coitus, sin of Gomorrah. This is frequently asked. Fellatio, cunnilingus, anilingus, voyeurism, scoptophilia, trollism, triolism. Very, very important. Is it okay? It's fine. Now look at this and identify what are these two, A and B. A and B. So in A, man wearing female dress, behaving like a female. In B, a man collecting some inanimate objects of feminine, nature, like a bra, petticoat, sari, and all. So by collecting that, he gets the sexual pleasure. So what is that known as? A and B. Simple word, but it's very simple actually. And just remember, necrophilia is punishable under 301 BNS. 301 BNS. ओके, ए क्या है, बी क्या है, बताओ जल्दी. हाँ, ए है इयोनिज्म, बी है पेटिकिज्म. So A and B, fetichism. Good. Sure. Now this is very interesting question. So this is very interesting scenario. Why secretly installed a hidden camera in the bathroom of a female tenant X without her knowledge? The camera captured images of X while she was using bathroom, a place where she had a reasonable expectation of privacy. Why then shared these images with his friends through messaging app like WhatsApp? It is punishable under. It is the main theme of the movie, Drishyam movie. one of the super hit movie. What is this known as, and what is the punishment? So this is classical case of voyeurism. Voyeurism. So voyeurism is basically 77. The stalking is 78. Disrobing, that is 76. Sexual harassment at working place. Sexual demand in working place, that is 75. Indecent assault 74. So याद रखना पड़ेगा 74, 75, 76, 77 and 78. 78 stalking, 77 voyeurism, 76 that is disrobing, 75 sexual harassment at working place, 74 indecent assault. So very, very important. 64 that is rape, 64 punishment, 301 is necrophilia. So necrophagia, extreme degree of sadism, having intercourse with dead, sexual gratification by eating dead body pieces. Okay, that is basically 77. Good, many answering, that's great. Now this is one more interesting question. A 29-year-old female brings her boyfriend to a couple therapist because she is uncomfortable with his behavior. She found him clutching her feet during intercourse. Notice that he insists on being able to see her feet while they engage in sexual act. So his area of focus is her feet, not the usual sexual focus. This is known as transvestism, fetichism, masochism, exhibitionism. It is not exhibitionism. Exhibitionism is of different types, like mooning, streaking. Mooning means showing buttocks, streaking, running naked in the public place, or flashing, anarisma. So anarisma is lifting skirt in public place. That is exhibitionism. That is basically a nuisance in public place. Masochism, I said already. Fetichism, I said already. Transvestism, okay. So what is the best answer then? So the answer is fetichism is the correct answer. This is fetichism. Fine, many answered. That's great. Now, frequently asked question, INI-CET favorite. Seminal stain and blood stain. Remember Takayama test and Teichmann test. Teichmann test, brown rhombic crystals. Brown rhombic crystals of hemine crystals, blood stain. So basically blood stain, blood. This is also blood. So Teichmann brown, Takayama pink feathery crystals. In Takayama hemochromogen crystals, in Teichmann hemine crystals, both are confirmatory test for blood stain. So one more test done is spectroscopic examination. So best is spectroscopic examination. Takayama and Teichmann, blood stain. Then seminal stain, yellow needle-shaped crystals, that is Barberio test. Barberio test, there is a formation of spermine picrate that is normally present in the seminal vesicles. Florence test, that is choline iodide crystals, they are also dark brown rhombic crystals. They are basically prostatic secretions. The choline present in the prostatic secretion. Spermine present in the seminal vesicles. Very, very important. So can you able to write in exam? Is it clear, guys? So go through this image. So pakka question in exam. Pakka question. Say yes or no. Guys, say yes or no. Every word is important. Brown rhombic, Teichmann hemin, pink feathery, hemochromosome Takayama, yellow needle supercrystals, barbario, picric acid, Florence choline iodide, we use potassium iodide, dark brown rhombic crystals. For old blood stain, we use luminol test. Luminol test. So I hope it is clear. I think this is very, very useful. This slide basically many questions, many questions asked in your exam. Chal, ho gaya. Next. Ossification center appear at 7 months. 7 months means viability. So in viability, your answer should be TALS. So the answer is TALS. That is 28 weeks. In 28 weeks, normally the weight of the fetus is 1 kg. The pupillary membrane disappears at 28 weeks. So calcaneum, not the answer. Lower end of femur, that is usually 9th month. Upper end of tibia, usually 10th month. So the answer is TALS is the correct answer. Viability. You can see here calcaneum and manubrium sternum 5th week, TALS 7th week, femur 36th week, tibia 38, cuboid 10th week, 10th week of gestation. And sternum is very commonly asked. Sternum has 3 parts. So this is manubrium sternum, body of sternum, and xiphoid process. Sternum. Can anyone tell me what is the age of ossification of sternum? So this is the one age of ossification A, that is between manubrium and body. What is the age of ossification? And B, the age of ossification or age of fusion between body and the xiphoid process. Can anyone tell me what is the probable age? Try this. Amit, when body is going to fuse with manubrium, what age? Xiphoid process fused with the body, what is the age? Remember, body is formed completely at the age of 25 years. Okay? Xiphoid process around 40 years. Manubrium at the age of 60 years. Okay? So frequently asked in the exam. So yes, 40, 60, you are right. And one more commonly asked in the exam about the sternum is Astley's rule and Hirtel's rule. Astley means more than 149 millimeter, that is male. When length of the sternum is more than 149 millimeter, it is always male. Less than 149, always female. इसको बोलते हैं Astley's rule. Hitler's rule somewhat related to that. Again, male and female differentiation. So the body is more than twice the length of manubrium in case of male. So Hittel's rule is body is more than twice the length of manubrium in case of males. Astley and Hittel याद रखना पड़ेगा. Astley's rule 149. Okay. Chalo, next question, very simple question from forensic psychiatry. Anyway, you are expert in psychiatry. Features of true insanity. True insanity matlab true illness. Gradual onset, schizophrenia, delusion, hallucination, disorganized speech, disorganized behavior, negative symptoms. So true insanity, all are the features except. Remember, insanity, insight is absent. Feigned insanity, insight is present. Insight means awareness. Gradual onset, yes, true hai. Delusions, true hai. So delusion means abnormal thought. There are different types of delusion. The common delusion is delusion of persecution. Hallucination, there are different types. First person, second person, third person. Third person auditory hallucination is very common in case of schizophrenia. Fear of detection, no, false. Insight is impaired, that is true. So answer hai C. C is the correct answer. What is insight? Insight means awareness. Awareness about one's own illness. So one classical example is schizophrenia. So schizophrenia means split personality. So there are 5 diagnostic criteria as per DSM-5. Delusion, hallucination, disorganized speech, disorganized behavior, negative symptoms. याद रखना पड़ेगा. ठीक है, चलो हो गया. चलो ठीक है. True insanity, feigned insanity. True insanity, gradual, motive absent, predisposing factors like genetic factors, family history present, presence of signs and symptoms, they are uniform and they are present all the time, whether the patient is being observed or not. Facial expression is peculiarly vacant, worried look because of the delusion of persecution. Insomnia, that is present because of hallucination, delusion. Exertion, he can persist extreme hunger, fatigue, sleep for days. But feigned insanity, sudden onset, motive present, predisposing factor absent, present only when he is observed. And facial expression frequently changing, exaggerated and voluntary. Insomnia, it cannot persist. He cannot withstand exertion. So here the motive is escape from the law. Escape from the law as per 22 BNS. I said already 22 BNS is McNaughton's rule. There are many rules of insanity. Durham's rule, Curran's rule, American Law Institute test, so irresistible impulse test, American Law Institute test. So there are many rules are there, but in India we follow McNaughton's rule under the section 22 BNS or 84 IPC Indian Penal Code. Okay, fine. All are examples of psychosis except psychosis. Schizophrenia, bipolar disease, mania, obsessive compulsive disorder. So answer is very simple. You can try, guys. Try yourself. Very simple question. The question number 17, very simple. There are 30 questions. So we are going to complete in next 50 minutes. All are example of psychosis except schizophrenia, split personality. Bipolar, BPD, yes. Mania, yes. Answer is OCD. So OCD is not psychosis, it is a neurosis. Very simple. Good. Chal. Now very simple. Now what about this? So just to subject interesting, a simple question. Deepika Padukone is in deep love with me. The patient says that Deepika Padukone is in love with me though I never met her. दीपिका पादुकोणे मुझसे बहुत प्यार करती है, हालांकि मैं उनसे कभी नहीं मिला. यह किस प्रकार का भ्रम है? And it is very common in females. What is this known as? So this is basically known as erotomania, also known as de Clermont syndrome. Okay, de Clermont syndrome. Good answer. Swati Kandan, great. One more, just to make subject interesting. Unfamiliar people are mistaken for someone you know. A beggar is mistaken for your boss. A beggar is mistaken for Donald Trump. A schizophrenic patient, a beggar was mistaken for his boss. What is this known as? This is basically delusion of doubles. Unfamiliarity towards the familiar persons. What is this known as? So this is known as, yes, try. Frigoli syndrome, very good. Frigoli syndrome. That's great. One more. Someone you know pursued as imposter or duplicate. This is opposite to Frigoli. So this is known as Capgras syndrome. Delusion of doubles. Frigoli, many answered. Swati Kandan, many answered. That's great. Cephalic index of skull used to estimate. Cephalic index. Can anyone tell me what is cephalic index? Yes, cephalic index basically for race. Race. That is maximum breadth of the skull divided by maximum length of the skull. Dolichocephalic 70, 74.9, Aryans and blacks. Mesenterocephalic medium sized Europeans. Brachycephalic more than 80 Mongolians. Hyperbrachycephaly when it is more than 85. Okay. And remember, anterior-posterior diameter is maximum in dolichocephaly, minimum in brachycephaly. So frequently asked in the exam, the instrument used is spreading calipers. Spreading calipers. Okay, good. All are features of male skull except, can I try? All are features of male skull except rectangular orbit, prominent supraorbital margin, forehead is steeper, prominent parietal eminence. So rectangular orbit, true. Prominent supraorbital margin, true. Forehead is steeper, true. So this is false. So this is commonly seen in case of female. So what is the answer? So the answer is except hai. So answer is D. So let's discuss about the differences between male and female skull, because that's very commonly asked in the exam. Now look at this. Say hi to our Boni. So here is Boni. Let's discuss difference between male and female skull, or else I'll let you know what are the findings in this skull. You identify male or female. Okay? Say hi. Hi to our special guest, Boni. So are you there? Gaurav. Gaurav, look at this. Rectangular orbit. Prominent glabella. Steeper forehead. Muzzle markings are prominent. Okay? Look at the muzzle markings. They are very prominent. Occipital protuberance, prominent. Look at the eminences. This is frontal eminence and the parietal eminence. They are not prominent. Frontal and parietal eminences, they are very prominent in females. Okay? So this is male or female then. I'll repeat again. Rectangular orbit, prominent glabella, steeper forehead, muzzle markings, bony markings are prominent. Frontal parietal eminence is small or small. So male or female. Male or female. Yes, Ankit got the answer. Sir, male skull. That's great. Male skull. Now, look at this. There are some sutures are there. Sutures. So this is metopic suture. And this one is sagittal suture. Right? Sagittal suture. This is coronal suture. My question is, what is the best suture for estimation of age? Best suture for age estimation. Look at the suture. All the sutures are visible here. Metopic hai, coronal suture hai, sagittal hai, lambdate suture. You can see the lambdate suture on the back. The best suture for age estimation, your answer must be sagittal. Sagittal suture. Okay? Fine. Now look at this one more commonly asked question in exam. So this is, what is this known as? This one. This is the common site of extradural hemorrhage because of the bleeding from middle meningeal artery. What is this site known as? Where 4 bones meet. 4 bones. You can see here temporal bone, sphenoid bone, parietal bone. They meet at one point. This is the commonest site, the weakest site, which causes bleeding, extradural hemorrhage from middle meningeal artery. What is that site known as? Yes, good answer, pterion. So this basically, pterion is the correct answer. Pterion. Good answer, pterion. Now you can see here teeth. You can make out now teeth. Can you make out the teeth, right? You can estimate the age by looking at the teeth as well. Microscopic and macroscopic examination. That method is known as Gustafsson method. The Gustafsson method is a method of age estimation in a dead body by using teeth, usually after the age of 25 years. There are 6 criteria. My question is, what is the best criteria in Gustafsson method? So this is Gustafsson method, okay? By using teeth, you can make out. Come on, guys. Gustafsson method. So in Gustafsson method, the best criteria is transferency of root. The second best criteria, secondary dentin formation. Secondary dentin formation, frequently asked in INI-CET. Best criteria, transferency or translucency of the root cavity. Second best criteria, secondary dentin, not the primary dentin. So, I hope you got it. Okay, guys. Okay. Wear and tear. Yes, Swati Kandan. That's fine. Now look at this. The best bone for determination of gender is, that is basically pubic bone. Okay, pubic bone, right? So this is left pubic bone. Now, can anyone tell me what is the finding? What is this actually? What is this? This part. Yeah, now it is visible. So male or female? It's deep and narrow. It's deep and narrow. This is sciatic notch. The sciatic notch is deep and narrow. My question is male or female? One of the best finding in female child, that is sciatic notch. If it is deep and narrow, it is male. If it is shallow and wide, it is female. Okay, frequently asked in the exam. Okay. Yes, guys. Okay. I hope you understood a few important concepts with the skull and the pelvic bone. Yes, guys. Shall we move ahead? Now this image, look at this image. Identify male and female, A and B. So steeper forehead here, straight forehead. A rectangular orbit, a round orbit. U-shaped mandible, V-shaped mandible. Frontal eminence prominent, parietal eminence prominent. So male and female. Okay. All are features of female pelvis except. Next question is pelvis. Everted ischial tuberosity. Yes, that is a feature of female pelvis. Inlet is round. Inlet is heart-shaped in males. Suprapubic angle is 90 to 110. Greater sciatic notch is deep and narrow. So deep and narrow in males. So the answer is D. So it is less than 70 or it is 70 to 80 in males. Heart shaped in male. Inverted in male. So the answer is D. So after the class, go through differences between male and female pelvis. Okay, go through that. The next heading is basically medical jurisprudence, the infamous conduct, what is infamous conduct, and the punishment. The professional death sentence given by. So professional death sentence means removal of name of the doctor from the medical register in case of dishonorable, disgraceful conduct of a doctor. Like example, advertisement, abortion, adultery, association, dichotomy. There are many examples for professional misconduct. Professional death sentence given by. As per criminal code, no. So it is not defined in criminal code. Central Health Ministry, no. National Medical Council, partly okay. But the best answer is State Medical Council. So, in case of professional death sentence, the doctor can approach EMRB, Ethics and Medical Registration Board of NMC. So basically for the appeal. So this can be a question in your exam. EMRB, Ethics and Medical Registration Board. It's an appellate authority in case of professional death sentence. So the answer is basically A is the correct answer. Yes, Swati Kannan? Correct. Chal. And try to remember, there are 6 A's are there. A for association, dichotomy. Dichotomy means that is fee splitting. Advertisement, repeated advertisement using large signboard, advertisement about manufacturing firms. Adultery, that is the misconduct with the patients. Illegal abortion, addiction, and alcohol. The punishment is either warning, temporary suspension, again there are grading of temporary suspension, 1, 2, 3, 4, 5 like that, or it can be professional death sentence. Okay, professional misconduct. So EMRB, they inquire, it's an appeal basically. EMRB, they actually go through again the punishment and the conduct of the doctor, and appeal, like you know, High Court, Supreme Court is there, Session Court. It's appellate court like that, appellate body. Okay, doctor can appeal to the EMRB. So he can prove by producing some documents that he is innocent. EMRB is a board of NMC. NMC board. In the NMC has different boards. UG board, PG board, EMRB, and other boards actually. So EMRB is the appellate authority. Yes, Swati Kannan, that's okay. Chalo. Next comes is, all are true about civil negligence except. There are 2 types of negligence, civil negligence and criminal negligence. Civil negligence is non-gross negligence. Criminal negligence is very gross negligence, like leaving swab in the body, leaving instrument in the body, ration negligence while doing surgery leading to death of the patient. That is criminal negligence. About, all are true about civil negligence except. Simple absence of care and skill, yes, true. Patient consent is a good defense, that is true. The consent is very good defense in civil negligence. Examining patient without consent is assault. So consent matters a lot. One very famous judgment related to consent is Samira Kohli versus Dr. Prabha Manchanda. Okay, so true. Punishment is compensation, that is also true. So the answer is none. So remember, consent, one very famous judgment by Supreme Court is Samira Kohli versus Dr. Prabha Manchanda. The consenting age for medical examination 12 years, for surgery 18 years. Okay, so 12 for the medical examination, 18 is for surgical examination or surgery. Examining patient without consent is assault. Yes, okay. So this is about the 22. Fact speaks for themselves is very simple question. Fact speaks for themselves. So basically it is a doctrine of common knowledge as well. Like example, living swab, living instrument in abdomen speaks for negligence of the doctor. So there are 4 options are there. Gross negligence, that is known as criminal negligence. Negligence contributed by doctor and patient, known as contributed negligence. Contributory negligence. Novus actus intervenens, that's a new action between the 2 actions. It is known as act of God. So the answer is res ipsa loquitur. Res ipsa loquitur is the correct answer. A is the correct answer. Ankit Mahajan, Gaurav, Sanjeev, Swati Kannan, Devankit Das, very good, all answered. So the first answer by Devankit, correct answer. Medical negligence is punishable under. Simple question. 88, criminal abortion. Rape punishment, that is 64. 116, grievous hurt. So the answer is 106. The punishment is 2 years of imprisonment. Two years of jail. So answer is A. Most common inquest in India. Inquest means inquiry towards cause of death. Sometime manner of death, identity, time since death. Most common inquiry. There are 2 types of inquest in India. Police inquest, magistrate inquest. So police inquest as per 194. Magistrate 196. So magistrate inquest is done in case of dowry death, death in custody, death in psychiatric hospital, death in police custody, or death during police firing, lock-up death, exhumation. There are many indications. Medical examiner is followed in US. Medical examiner is a dual expert. Coroner, it was there in India. It was abolished in probably 1999. So the best answer is police inquest. The most common is police inquest. Magistrate is the best inquest. Medical examiner is bestest. The very good inquest is medical examiner. In India, the best is magistrate. Most common is police inquest in India. Okay, so answer is 194, exhumation. That's great. So this okay. Then 5 questions in toxicology, just to in 10-15 minutes. True about ideal homicidal. So there are many ideal homicidal. So like example, arsenic, thallium, insulin. Some books give cyanide also. So arsenic is known as king of all poison. Some books gives aconite also. Aconite is queen of all poison. So it can be mixed with any food and drink. So they have signs and symptoms resemble like natural disease. Costly vaporized? No, they are cheap. Pleasant taste? They are highly toxic. Like arsenic, fatal dosage is 100 to 200 milligram. Thallium even less. Insulin, cyanide, aconite is a cardiac poison. So the answer is C. So I'll have to write in the chat box, the king of all poison is arsenic, arsenic trioxide, queen of all poison, aconite, okay, king of all kings, king of kings, thallium. So write this in chat box. This is very interesting line. So arsenic trioxide, one very famous king, Napoleon Bonaparte, he was killed by his servant by mixing arsenic with his food and drink. And they preserved his hair and nail. They found very high amount of arsenic in his hair and nail. Okay, he died due to stomach cancer. So thallium is also ideal homicidal. Insulin also, cyanide, like cyanide Mohan Kumar, cyanide Mallika, Jali Joseph case. So there are many cases. Aconite is basically a cardiac poison, sweet poison. It can mix with any food and drink. It resembles like heart attack. Arsenic resembles like cholera. Okay. Good. Demon. Good. Mita, Jahar, thallium. That's great. So all are answering. That's great. Okay. Following is an example for organochlorines. Try to understand organophosphates are classified into alkyl phosphate, aryl phosphate. Alkyl phosphate is malathion. Aryl phosphate is parathion. Here question is organochlorine. Organochlorine, they cause nerve paralysis. No antidote. So what is that organochlorine? So organochlorine is basically DDT. D is the answer. Malathion is organophosphate. It's OP compound. It's basically alkyl phosphate. So all these are basically organophosphates. In organophosphates, we use atropine is a drug of choice. 2 to 4 milligram IV. Okay. So OP poison frequently asked in the exam. So try to memorize mnemonic sludge MTF. So onset occurs in 30 minutes to 2 hours. What are the clinical features? Salivation, seizure, sweating, lacrimation, urination, diarrhea, gastric upset, emesis, meiosis, muscle cramps, tachycardia, and fasciculation. Remember, mydriasis occurs in datura poison, in cocaine poison. Okay, but meiosis occur in OP poison, Pontine hemorrhage, opium poison, so many conditions. So OP poison, all these are clinical features. So drug of choice is atropine, I said. Atropine do not reverse muscle weakness. MCQ. Atropine do not reverse muscle weakness. The muscle weakness can be reversed by prolidoxime and diacetyl monoxime. They are cholinesterase reactivators. They are given within 48 hours before aging. They are contraindicated in carbamate poison. Then one more drug that is given is diazepam. Okay. Yes, so this is commonly asked in the exam. Now, then complications commonly asked in your exam: intermediate syndrome, to get paralysis, the muscle weakness and all commonly asked. And OP poison is commonly used as a agent of suicide in farmers. It can lead to accidental poison, rarely homicidal. Okay. Yes, this is very simple. Next question from the snakes. All are features of poisonous snakes except poisonous snakes. So poisonous snakes are classified into, where basically Elapidae, Viperidae, Hydropidae. Elapidae, they are neurotoxic. Here comes this common cobra, common krait, mamba, and coral. So viper, so we have many: saw-scaled viper, Russell's viper, pit-nosed viper, hump-nosed viper. Hump-nosed viper. Vipers are usually hemotoxic. Hydropidae, basically sea snakes. They are myotoxic. They cause a rhabdomyolysis. They commonly involve shoulder girdle muscle. Okay. So yes. Large belly scales. Yes, true. Triangular head, that is true. Natural habit, that is true. Always rounded tail. So this is false. So normally tail is somewhat pointed like this. This is tail, somewhat pointed. So answer is D. So D is the answer, many correctly answered. Now look at these 4 snakes and try to identify. So there are 4 snakes given to you. Identify. So what is this? A, B, C, and D. Come on guys, try this. A, B, C, D. The fatal dosage in A is 15 milligram, 30 minutes to 6 hours. In king cobra it is 12 milligram. And in A, which has a hood and spectacle mark, so this is naja naja. That is common cobra. In B, you can see the triangular head, constricted neck, broad body, and the dark brown spots. So this is Russell's viper, Dubai Russelli. In C, you can see the bird foot mark. This is known as Achis carinatus. Saw-scaled viper. And D is basically Bungarus ceruleus. So in simple word, the A is common cobra, B is Russell's viper. C is saw-scaled viper. The D is common krait. Common krait. A, B, C, D. Then treatment. As you know, cobra and krait, they are neurotoxic. They produce bungarotoxin. They cause respiratory paralysis and death. Russell's viper, they are hemotoxic. They cause increased clotting time, bleeding time, DIC, and death. The commonly used test is 20 minutes whole blood clotting test, single breath count test and all. The approach is right approach. Repeat question. Right approach. INI-CET question. Right approach. R means reassurance. Okay. Second, immobilization. Get to the hospital immediately, GH. Tell the symptoms to the doctor. So this is a right approach. So R for reassurance. I for immobilization. Get to the hospital, tell the doctor. The treatment of choice is ASV. Anti-snake venom. Most common side effect is anaphylaxis because it is of equine origin. The same dosage is given in children as well as in adults. Okay? So this is commonly asked in the exam. Good, Debank. That's great answer. Fine. Burnt rope smell is normally felt in poisoning with burnt rope. Burnt rope, cannabis, hydrogen sulfide, cyanide, arsenic. So arsenic is king of all poison. The smell of arsenic and phosphorus is garlic smell. Cyanide, bitter almond. Hydrogen sulfide, like somewhat fishy smell. No, fishy. Cannabis, burnt rope. So frequently asked in the exam. Look at this. Phosphide, garlic. Cannabis, burnt rope. Alcohol, fruity. Cyanide, bitter almond. Hydrogen sulfide, rotten egg. I said fishy, it is rotten egg. Chloral hydrate, acrid pure. Naphthalene, bath ball. Salicylate, menthol smell. Zinc phosphide, that is fishy. So this is very, very important. INI-CET question. INI-CET question. Okay. So garlic smell, just remember phosphorus and arsenic. Okay. Rotten egg smell. Rotten egg. Hydrogen sulfide. So remember these two. Hydrogen sulfide, arsenic, and yellow phosphorus. Yellow phosphorus causes smoking stool syndrome. It's one of the very poisonous substance. Even 500 milligram can lead to death, especially aluminum phosphide. Yellow phosphorus. And the last question. Speedball is speedball. Heroin plus cocaine, phencyclidine, chloral hydrate, MDMA. MDMA is known as ecstasy. It's a party drug. It can lead to schizophrenia as well, paranoid schizophrenia. Chloral hydrate is basically known as dry wine. It is mixed with the alcohol to increase the effectiveness. Phencyclidine is angel dust. Heroin plus cocaine is known as speedball. So remember cocaine. The commonly all questions are cocaine. Try to memorize. It is known as white lady. A white lady. It increases norepinephrine level. It causes mydriasis. It increases BP. It causes sweating. It also causes tremors. Then it causes one very important complication, Magnum symptom. The Magnum symptom is basically formication, tactile hallucination, characterized by scratch marks. Scratch marks. The treatment is amyl nitrate. Nasal septum perforation is very common in case of cocaine poison. So this is very, very important. So this is your brown sugar, heroin. So this is cocaine. It is punishable under NDPS Act. So Narcotic Drugs and Psychotropic Substances Act 1985. Okay. Now I have some 2-3 video based questions. So just wait for 5 minutes. Yes, guys, are ready for the video based questions? There are a few video based questions are there. You just try. Okay. This question. The classical feature of high voltage burn. Can anyone try? Repeatedly asked in exam. So high voltage burn, high voltage means more than 1000 volt. In high voltage flame burn, the classical finding is crocodile skin burn. So the answer is A. The joule burn or entry burn that is commonly seen in low voltage burn. Filigree burn that is commonly seen in case of lightning. So answer is A is the correct answer. Good. So this is one frequently asked question in your exam. Identify the snake, which has a triangular head, constricted neck, broad body, pointed tail, and which has dark brown spots over the body. It's hemotoxic. It causes increased clotting time, bleeding time, DIC, hematuria, hemoglobinuria, kidney failure, enlargement of parotid gland, and death. So what is this? Death occurs in 3 to 4 days, maybe in 1 week. So viper, very good. Many answered. Russell's viper is the correct answer. Correct. Yes. Now the third question. The best bone for gender determination in a skeleton. Best bone. It's a crime scene photo. The crime scene that is showing multiple bones. You can see here radius, ulna, and femur, and other bones. The best bone for determination of gender in a skeleton. So it's very simple actually, very simple question. So the answer is pelvis is the correct answer. Pelvis. Good. So this completes your session, guys. So wish you all the best for upcoming INI-CET exam. If you have any doubt, you can message me in Telegram. You can message me in WhatsApp group. You can message me in Instagram as well. So we completed almost all the important topics related to your INI-CET exam. So briefly and to the point. Any doubt? Ankit? Parul Patel? Ankit? Gaurav? Devang Das? Amit? Yes, any suggestion? Any feedback about the class?
Good afternoon. My name is Dr. Adapta. मैं आपकी psychiatry की mentor हूँ. I am MD Psychiatry, DND Psychiatry MBBS. Who all are interested in psychiatry? First of all, let's hear it for psychiatry enthusiasts before the INI-CET exam. Any psych takers? Any for fans of psychiatry? Students, any psychiatry fans? No, ma'am. चलो दिल तो तोड़ दिया तुमने स्टार्ट करने से पहले, but एटलीस्ट ऑनेस्टी है, दैट्स अ गुड पॉलिसी. साइकाइट्री मैराथन सीरीज रेडी है सब? इज एवरीबडी रेडी टू गो? I'm waiting for a few more of you to join in. INI-CET ग्रैंड टेस्ट जरूर करना है गाइस. मेडेड ऐप में जाके जीटी किस किसने ले लिया है? Who all have done the GT? जरूर करना है. ओके, इट्स अ वेरी बिग पार्ट ऑफ योर लर्निंग. जितने जीटी करोगे उतना अच्छा रहेगा. Okay, so let's get started with psychiatry. Psychiatry is always a fun subject. Psychiatry is always an interesting subject. Psychiatry is often asked in NICT. They seem to love it. So let's go. I'm glad that still I like it very much, but still confused. No problem. Confusion is a good thing to have. When we are very set in our ways, we often have more problem. When we are confused, we are still malleable and flexible. Chalo, shuru kare Antakshari. All right, let's go. Honestly, before I start, I want to say one thing. I want more answers from you guys. I want you to participate in a manner that I can keep on giving you the notes. Even in the end, I can write down everything and send it to you. In fact, put your pens down for a minute. Just interact with me. Just pick up your phones. Type as much as you can. I want to know how much you guys already know. See, we've already done the PYQ. We've already been doing a lot of revisions continuously. I'm sure that you're on the app as well. So a lot of this has already been studied. The idea of a marathon is to go through everything. And what is a marathon like? You start slow, you pace up, you maintain the momentum and you finish strong. जिसके लिए आपको बहुत 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 पार्टिसिपेट करना जरूरी है. रेडी फॉर पार्टिसिपेशन? लेट्स गो. सवाल मैं पूछूंगी. आई विल वेट फॉर यू ऑल. हो सकता है मैं अभी ना लिखूं. आई मे राइट लेटर एंड आई एम सिंपली सेइंग दिस बिकॉज जितना हम इंटरेक्ट कर पाएंगे इस टाइम में वो बेटर होगा. नोट्स तो आपको बाद में भी मिल जाएंगे मुझसे. ठीक है, let's go guys. Number 1, what is a delusion? MSc is a fairly important topic. Remember that MSc से कुछ ना कुछ जरूर पूछ लेते हैं वो लोग. Simply put, because MSc is a very wide topic, right? My choice of pen is always something that I struggle with. Okay, so MSc से ये जरूर कोई ना कोई सवाल जरूर उठा लेते हैं. What is a delusion? I want the answer from you guys. What is a delusion? What is a delusion? Delulu is the only Sululu. सुना है किसी ने? Delulu is the only Sululu. तो क्या है Delulu? What is delusion? Please define for me what is delusion. Not Delulu is the only Sululu. That I just said to wake you up because postprandial session ना सबसे ज़्यादा difficult होता है pull off करना आपके लिए. आप लोग खाना खा के बैठे होगे I'm sure. So it's my duty to wake you up. So tell me the definition of delusion. क्या होते हैं delusion? My job is to explain. I may write less, guys. Also my pen is charged poorly today. But I may write less. I may explain more. Disorder of thought. Good. But what disorder of thought? It's a problem in the way I think. Correct. What is the specific problem? So, we all think certain things we hold with conviction that I am 100% sure. Certain things we are flexible, malleable, maybe not. Correct. Now, delusion is a thought disorder. You're right. It's a form of disorder of thought which is a false, fixed, firm belief. False, fixed, firm belief which is irrefutable. Irrefutable का मतलब होता है कि हम नहीं मानने वाले अगर आप कुछ भी कह लो उसके बाद भी. Irrefutable in the face of truth. सच भी दिखाऊंगी तब भी आप नहीं बिलीव करोगे. मतलब मैं कह दूंगी कि अर्थ इज राउंड, इसका मेरे पास प्रूफ है, फोटो है फ्रॉम द यूनिवर्स, तब भी आप फ्रॉम द मून, फ्रॉम द स्पेस, तब भी आप बिलीव नहीं करेंगे. इररिफ्यूटेबल इन द फेस ऑफ ट्रूथ एंड कल्चरली नॉट एक्सेप्टेबल. मतलब कल्चरल नॉर्म्स में नहीं फिट इन करना चाहिए. अब एग्जाम्पल लेते हैं. मोस्ट कॉमन डिल्यूजन क्या है? डिल्यूजन of persecution and delusion of रेफरेंस. कोई मेरे बारे में बात कर रहा है और कोई मुझे मारना चाहता है. ये दोनों बहुत ही कॉमन डिल्यूजन्स हैं. हेल्यूसिनेशन सबसे ज्यादा कॉमन ऑडिटरी होती हैं. डिल्यूजन सबसे ज्यादा डिल्यूजन ऑफ रेफरेंस एंड डिल्यूजन ऑफ परसिक्यूशन होते हैं. कोई तो मुझे मार डालेगा या मेरे बारे में लोग बात कर रहे हैं मेरी पीठ के पीछे. ठीक है. और जैसे मैं रूम में जाता हूँ ना, वो मेरे बारे में बात करना बंद कर देते हैं. नाउ यू एंड आई ऑल्सो मे फील लाइक दैट, बट वी आर एबल टू अग्री दैट they're not always talking about us, correct? Whereas somebody with delusion will be very sure मेरे को ना मारने की कॉन्स्पिरेसी चल रही है, मेरे को ना फेल करने की कॉन्स्पिरेसी चल रही है टीचर की दूसरे टीचर के साथ. सो दिस इज द मोस्ट कॉमन डिल्यूजन दैट वी फाइंड. कहाँ दिखते हैं डिल्यूजन्स? ऑफ कोर्स स्किज़ोफ्रेनिया में दिखते हैं. वी कैन ऑल्सो फाइंड इट इन बाइपोलर अफेक्टिव डिसऑर्डर. कहाँ पे और देख सकते हैं? जहाँ पे सब्सटेंस यूज हो रहा हो वहां पे भी देख सकते हैं. कुछ ऑर्गेनिक सिंड्रोम्स में भी दिखते हैं. इन सब में हमें डिल्यूजन दिखते हैं. Now, what is Capgras? Capgras syndrome. Capgras क्या है? आप लोग मुझे बताएंगे कि कैपग्रास क्या है. साथ साथ फ्रिगोली भी बता दो, क्योंकि कैपग्रास और फ्रिगोली भाई बहन है, राइट? एंड फ्रिगोली ऑल्सो. कैपकास और फ्रिगोली भाई बहन है. भाई बहन क्या होते हैं? they're usually opposites, right? They usually like, no, I want this, no, I want that, I want this channel, I want that channel. So Capgras and Frigoli are brother sisters. So tell me, what is Capgras and what is Frigoli syndrome? Because I am not telling you, because honestly by now you must be knowing this. Familiar person is seen as imposter. Delusion of doubles. Okay, correct. But कौन सा क्या बता रहे हो ये भी बता दो. कैपग्रास बता रहे हो, ऑल राइट. परसिक्यूटर फ्रिगोली. वैसे कीवर्ड बोलते रहोगे ना तो वहां जाके बहुत ज्यादा कंफ्यूज हो जाओगे. आई पोस्टेड बाय फेमिलियर वन. थोड़ा कॉम्प्लिकेट किया हुआ है आप लोगों ने. मेरे ना कोई क्लोज है, वो क्लोज पर्सन को ना रिप्लेस कर दिया है एक फार पर्सन से. यानी फार पर्सन मतलब इम्पोस्टर. loved one, wait, let me move. loved one is a double or imposter. मेरा loved one क्या है? मेरे close होता है ना. loved one जो होता है वो close होता है. that has been replaced by a far person, that is by an imposter. Whereas Frigoli's, look at this is actually named behind this guy called Frigoli. He was a beherupia. What is a beherupia? Change costumes quickly like a magician. तो फ्रिगोली बार बार कपड़े बदलता रहता था. तो कभी ऐसे बन जाता था, कभी ऐसे बन जाता था, ऐसे बन जाता था, ऐसे बन जाता था, ऐसे बन जाता था. सो ही यूज्ड टू चेंज हिज आउटलुक फास्ट. सो ऑल द स्ट्रेंजर्स आर सीन एज अ क्लोज पर्सन. पर ये एक ही पर्सन है, ये बार कपड़े बदल रहा है. सो द फार पर्सन, अनफेमिलियर पीपल आर एक्चुअली द सेम क्लोज पर्सन. ये ना मुझे कहीं पे भी मिल जाता है, ये वही पर्सन है तो ये क्लोज पर्सन, पर ये प्रिटेंड करता है कि ये स्ट्रेंजर है, पर स्ट्रेंजर नहीं है. ठीक है. फ्रिगोली स्ट्रेंजर्स आर सीन एज क्लोज पर्सन. ऑल राइट, गुड. फार पर्सन इज सीन एज अ क्लोज पर्सन. एफ फॉर फ्रिगोली, एफ फॉर फार. फार आर स्ट्रेंजर. सी फॉर कैपग्रास, सी फॉर क्लोज. क्लोज इज familiar. Okay, और close मतलब my loved one. All right. Okay. Intermetamorphosis is again a delusional misidentification syndrome related to agnosia. Basically, inability to identify. This is finger agnosia, and then if I can't identify faces, that's prosopagnosia. Correct? यहाँ पे patient feels that people are changing, interchanging constantly, both in personality also and in identity also. All right. Can somebody tell me why do I have this strange picture in front of lycanthropy? What is lycanthropy? Lycanthropy. Why do I have this strange picture? Can someone tell me? I'll wait for you to tell me. Why do I have this strange picture of, I don't know what animal I've tried to show you. Maybe you can guess what is this strange picture in front of this. It is something that represents lycanthropy. Can somebody tell me? What is this picture depictive of? Why have I shown this picture to you? Frigoli, stranger is seen as close. Yes, stranger is far. F for far, F for stranger, right? S for stranger, but F for far. Can someone please tell me why have I made this weird looking picture in front of you all? Hair. Lycanthropy. This is like an example of lycanthropy. Wolfman. You are close. Anybody who has seen the movie Twilight? उसमें werewolves होते हैं, vampires होते हैं, right? So in lycanthropy, people believe that the person can become an animal. Most common, werewolf. अमावस्या की रात में इंसान में भेड़िया बन जाता है. That is werewolf. So this is called werewolf syndrome also, lycanthropy. Wednesday also. Good. All right. So understood? On the same page? So far on the same page? Give me a thumbs up only, then I'll move ahead. Once I get a thumbs up, I'll move ahead. We have a lot to cover, guys. Thumbs up, only then I'll move ahead. Please give me a thumbs up. All right, awesome. What is delusional perception? What is delusional perception? I'll wait for you to answer. Delusional perception. What is delusional perception? What is delusional perception? I'm waiting for delusional perception's definition from you guys. Thinking somebody's plotting him. No, that's just a delusional. That's a delusion of persecution. Persecution. Persecutory comes from the legal term अदालत में जैसे कहते हैं ना कि ये persecution है, तो मतलब बेसिक prosecution है, तो ये persecutory means कि कोई मेरे खिलाफ काम कर रहा है. That is different. Delusional perception क्या होता है guys? I'm first checking in the first few ones कि आप लोग को कितना आइडिया है और उसके अकॉर्डिंगली ही मैं आगे मूव करना चाहती हूँ. Thinking somebody's plotting against him? No, that's not delusional persecution. Anybody? Delusional persecution, delusional perception क्या होता है? Okay, एक example देके समझाती हूँ. Imagine that somebody sees you and does this, and you think this means something. Oh, they're trying to show that they actually know all my secrets. This action is showing me that they know my secrets. Now, there are two parts in the word delusional perception. Delusion, which as you know is a false fixed firm belief. Perception. How do we perceive things? The five senses are used to perceive things. So hearing, seeing, smelling, tasting and feeling. Now, if I see that the fan is moving and I say, oh, that fan is actually rotating because it is trying to tell me that my time is up. Or Dr. Datta is doing this because she's telling me that I know all your secrets. So this though I did normally, na, I didn't mean to tell you anything. My normal action was given a false fixed firm belief by you, a delusional meaning. My normal action was given a delusional meaning by you. So hence it is delusional perception. It is a first rank Schneiderian symptom. Yes, normal thought is attached with delusion. Correct. Normal thought नहीं, normal perception. ये perception है, देखा आपने मेरे को, पंखा चल रहा है, वो perception है. 5 senses are used for perception. Normal perception is attached with a delusional interpretation of meaning. That is called delusional perception. Did you understand this, guys? Did you understand this, guys? Okay, all right. Next is Othello syndrome. Have you seen the movie Omkara? What is Othello syndrome? What is Othello syndrome? What is Othello syndrome? Othello syndrome is also a type of delusion. Why did I show you this movie Omkara? Unfaithful partner, delusion of infidelity. My partner is cheating on me despite the evidence to contrary. Matlab, my partner is cheating on me even if my partner is in front of my eyes 24/7. Oh no, they find some way to cheat on me which I don't get to know. So that is delusion, and hence that is called delusion of infidelity. Lovely. Not delusion of persecution. Delusion that the spouse is cheating on them. Delusion that the partner is cheating on them. Yes. Morbid jealousy. Correct. Next is declarum bout. Here I have shown you this photo. Age is not the important factor here. Notice, imagine that she is the junior associate or secretary and he is the big boss. He has no idea she exists, but she thinks that he is in love with me. Even though he is not. He refuses flat out that no, I don't have anything to do with you. I've never spoken to you. So it is the delusion of being in love, especially with a person of higher stature, meaning way above them. They may not even know they exist. So for example, a celebrity that people get very obsessed with, start stalking them and all. And yes, it is also called erotomania. She thinks he loves her. Yes, they think celebrity loves them. Yes, not a crush. Celebrity के साथ एकदम obsess होके सोचना कि वो आपको indirectly messages भेज रहा है. All right. Next is Cotard syndrome, also called the walking corpse syndrome. So what is Cotard syndrome, guys? What is Cotard syndrome? ये वाला तो आपको आता होगा. Tell me, what is Cotard syndrome? What is Cotard syndrome? Nihilistic delusion का भी extreme version. Nihilistic is I am dead. ये उसका भी extreme version है. Walking corpse syndrome. Correct? Right. Not something is missing. It is I do not exist. I see myself in the mirror और मेरे को तो मैं दिखता ही नहीं हूँ. I can't even see myself in the mirror. मैं तो exist ही नहीं करता हूँ. So I am dead. So, you know, there are case files of patients who have gone and tried to bury themselves. Why? Because they say मैं तो मर गया हूँ, मैं तो dead हूँ. Okay. Next is delusion of parasite infestation. These patients are convinced that मेरी ना skin में या skin के under there are some parasites, there are some bugs or ants or other things which are there. So delusion of parasite infestation is also called Ekbom syndrome. Here the patient is convinced they may be having some tactile hallucinations also sometimes. All right. And they sometimes bring this imaginary insect in a matchbox. So it's also called matchbox sign. छोटे छोटे ना काले काले धब्बे से उठा के ले आते हैं मैचबॉक्स में और कहते हैं देखा ये बग मेरी बॉडी को काट रहा था. So this is delusion of parasite infestation. Delusional parasitosis, also called delusion parasitosis. ठीक है. Delusion of grandeur. I am the king of the universe. I know the prime minister or most important people directly, even though I don't, and I can make it rain. All of these are delusion of grandeur. So we have delusion of grandeur, ability and identity. Obviously, where is delusion of grandeur seen, guys? I am God. Where is delusion of grandeur seen? Of course, seen in mania. Right? Seen in mania. All right. Next, can you please match these for me? I want the answer written like this. 1 उसके सामने कौन सा, 2 उसके सामने कौन सा, 3 उसके सामने कौन सा, 4 उसके सामने कौन सा, 5 उसके सामने कौन सा. I want the लास्ट में मेरा स्किन केयर शेयर कर लेंगे. स्किन केयर रूटीन के बारे में जरूर डर्मैट वाले सर आपको जरूर सिखाएंगे. ऑलराइट. ओके, सो प्लीज टेल मी, मैच एवरीथिंग एंड आई वांट यू टू डेफिनेटली राइट ऐसे ऑर्डर में 1 डैश 2 डैश क्या क्या आपका आंसर है. ठीक है. स्मूथ स्किन स्पेशलिस्ट आपको बताना चाहिए स्किन केयर रूटीन. ओके. 1B. इससे हम सारी डेफिनेशन भी एक तरह से याद करने वाले हैं वापस. ठीक है. इस वाले इससे एमसीक्यू से. ओनली 1B बताया है. और बताओ गाइस. आई एम गोना हैव सम वाटर. Okay. Yeah, we have some answers coming in. Okay. Hallucination is when you perceive things. Remember, we perceive things through the 5 organs. So there are 5 kind of hallucination. Auditory, olfactory, gustatory, tactile, and visual, right? So these are the 5 hallucination. Where there is perception without stimulus. Where there's a pen but there is no pen, that is visual. Where there's sound but no sound, that is perception without stimulus. 1A. Sorry, 1B, correct. Illusion. Illusion is if you think that this is a sugarcane. Actually, it is a pen. But if you think it's a sugarcane, so there is a real object, but you have distorted. Your brain has distorted it, right? So 2A, correct, correct. All right, delusion. We just talked about it. False, fixed, firm belief. 3C. All right. Affect. Affect is what you can see. Observable emotion. 4D. And आपने अमित सैम आपने 3B लिखा और 5B लिखा है. How is that possible? And 5 is judgment, ability to make decision. क्या पेशेंट की जजमेंट इंटैक्ट है कि नहीं. मतलब अगर घर में आग लग जाए तो वो पेशेंट आग बुझाने के लिए फायर ब्रिगेड को कॉल करेगा कि नहीं. दैट इज द एबिलिटी टू मेक डिसीजन. ये सारे एमएससी के पार्ट्स हैं. ठीक है. होप ऑल ऑफ यू गॉट इट राइट. आई थिंक डॉक्टर स्वाति कनन गॉट इट राइट. ओके. Next, we are going to talk about the speech sample called circumstantiality versus tangentiality. So I say, hey, hi. So tell me about your skincare routine. And I say, you know what? When I woke up in the morning, I went and I gave plants some water, and I actually ended up listening to music, and then I decided that I want to brush my teeth, and I wanted to shower and wear my favorite color. And there was some kind of person that comes into my house who always brings in so much food. And what I realized, that food is so important, and I like to eat nuts sometimes, and those nuts are actually very rich in antioxidants, and I eat nuts every day for my skin. So what was the question and what was the answer? It took so long to get to the answer. That is circumstantiality. Understood, everybody? Right? Now, hey, tell me about your skincare routine. This is the question. Oh, you know what? All the same things that I said. And this person, he comes to my house and then he goes away and he gets nuts sometimes. And then, I just like to sleep at night. So just missed the point. This was the answer. Just missed the point. He had started talking about nuts. Nuts were the secret to the skincare routine. Didn't get along into the end of it. So beating around the bush didn't come to the point. That is tangentiality. And this is circumstantiality. Understood? Understood with the example? Touch, but no touch. I like it. I'll copy it. Thank you, Doctor. Dr. Jadav. Touch, but no touch. Okay. Loosening or derailment. This is my train track. My train is going on it and it goes off. Talking about something, but suddenly going so off tangent that it is hard to come back on the rail. That is loosening of association. An association between two consecutive sentences needs to be maintained. Notice when I say two sentences, they have some sense and logic between sentence 1 and sentence 2. If I talk about the moon and then I talk about circumstantiality, in the next line I talk about food, there is no association. That is derailment. Okay. Now comes autistic thinking. Here there is a lot of formal thought, a lot of concrete thought, meaning they take things very literally. So I say, then I started just sweating it was so bad that I started sweating. Now I didn't literally start sweating. It's a terminology. They will not understand it. They will essentially think, oh, they really started sweating. Oh, I literally could die there. They'll be like, oh, this person could die there. I couldn't die there. That's an autistic form of thinking. All right. That's a very concrete form of thinking. That's autistic thinking. All right. Sometimes seen in severe schizophrenia, also seen in autistic spectrum disorder. Neologism are new words. Kids love to make new words, but obviously we are talking about the more organic brain syndrome or severe form of schizophrenia format where neologism or new words are made for normal things. So I can call this the water holder or the water basin. Now this is the water basin. Why? Because I drink water from this, right? Or this is the coffee. This is the coffee vessel. Coffee vessel. That's a cup here, right? Yeah, Dr. Sean Murphy takes everything very literally. If you haven't seen the series, you must seen it. The Good Doctor, right? The Good Doctor. Exam के बाद देखना, अभी मत देखना, ठीक है? Exam के बाद, after exam. Okay, all right. Next, what is echolalia? What is echologia? So in bachpan, we used to tease our friends. If I would say something and somebody would repeat after me, hey, what's your name? Hey, what's your name? Hey, you're so silly, huh? Hey, you're so silly, huh? So, what did you eat? So, what did you eat? Listen, don't copy me. Listen, don't copy me. That is echolalia. So, repetition after someone. Similarly, copying someone's action. This is action. Copying action. This is echologia. Now, there are two words called verbigeration and perseveration. I want you to know the difference. Verbigeration is when somebody keeps saying the same word. I want, I want, I want, I want, I want it, I want it. Randomly, without any context, that is called verbigeration. Whereas perseveration is the persistent, inappropriate repetition of a specific response despite the cessation of original stimuli. Meaning, if I say, where are you from? And I say, I'm from Delhi. Okay. What did you eat? And I say, Delhi. I say, what is your favorite color? And I say, Delhi. This is called perseveration. I hope the difference between verbigeration and perseveration is understood. Please tell me if it isn't. I'll explain again. Difference between verbigeration and perseveration. Understood? Understood, guys? Otherwise, I'll explain again. All right, awesome. Okay. Next is transvestism. Transvestism. I am wearing somebody else's clothes like a vest. So, traditionally associated with the opposite gender role. What do men typically wear? More to do with pants and shirt, etc. What do women typically wear? More to do with lingerie, more to do with blouses, skirts, dresses, etc. But it is not always sexual arousal related. There is no sexual arousal. Whereas transvestic fetishism means when there's a sexual arousal, which is a type of paraphilia. So there is a sexual arousal with dressing in opposite gender clothes. That is the difference. What is Freudism? What is satyriasis? What is nymphomania? I want to know from you guys. I will not give the answer. Give definition of Freudism. Please give these differences. I was forced to wear girls' clothes, but well, that was not your choice. So none of those disorders fall. That's okay. Rubbing against a person in public places, rubbing private part against consent. For example, in a bus, it's called Freudism. Correct. Satyriasis is excessive desire in male. Correct. And in female, it's called nymphomania. Okay. Yes, satyriasis is excessive sexual desire in males, and that in females is called nymphomania. Correct. Exhibitionistic disorder means to show like an exhibition, right? Show private parts, again without consent of the other party. So they will be like flashers. They will flash the person without consent, right? Masochism and sadism. So to inflict pain for sexual arousal is sadism, and to have the pain inflicted on is called masochism. It is a part of sadism and masochism complex. Okay. All right. Yeah. Mooning as well. Flashing, mooning. Correct. Pedophilic disorder is to have sexual arousal from young, especially prepubescent children. Okay. Necrophilia is having sexual desire to have sexual encounter with dead bodies. Correct? Okay. Let's talk about the drug of choices. Now, I've curated like a sort of a table for you all. Of course, I'll add more notes to each point. I would like participation from you all. We'll start with bipolar mania acute phase. What is the drug of choice in bipolar disorder in acute phase? I want to know from you all. Okay. So, guys, this is a very common query. What is the drug of choice in acute phase of bipolar mania? While lithium is a very good answer, it takes a few days to weeks to build up in the system. Hence, in the acute phase, it may not do much, which is why second generation antipsychotics is a better answer. Next is sodium valproate, and third is lithium. Of course, you can also have lithium plus benzodiazepines as an option. Notice I have given you all the combination permutation of which answers can be there in your options. Choose wisely. If second generation antipsychotics like olanzapine, quetiapine are mentioned, choose it because this is acute phase. If only bipolar affective disorder is written or bipolar mania is written, acute is not mentioned categorically, you may want to choose lithium. And lithium plus benzodiazepine written, choose lithium plus benzodiazepine. Or lithium plus second generation antipsychotic written, choose this as the best response. Sodium valproate is also a great response, but lithium alone takes time to build an acute phase. Okay, got it? Common confusing part. A lot of you ask me this every time, which is why I'm mentioning. Understood? Good, good. Thumbs up, thumbs up, thumbs up, thumbs up, thumbs up. Guys, thumbs up. Give me a thumbs up. Not the real drinking one, but a virtual thumbs up. Samjha, 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 samjha. Cool. Okay. Drug of choice for bipolar depression is fairly easy. I want you guys to tell me. Drug of choice for bipolar depression is fairly easy. Tell me. Drug of choice for bipolar depression. बाइपोलर डिप्रेशन ड्रग ऑफ चॉइस तो एक ही होना चाहिए गाइस. एक ही ड्रग ऑफ चॉइस तो मतलब चॉइस होती है. Lamotrigine is the drug of choice. Lamotrigine. Now, those of you who have written lithium, it is not the drug of choice for bipolar depression. Lamotrigine is the drug of choice. Those of you who have written SSRI, we will not give SSRI without cover in bipolar depression, which is why Lamotrigine plus SSRI, I can still accept as an answer, but I will not accept SSRI on its own as an answer. Okay. So, no giving SSRI without cover. Cover means mood stabilizer. Mood stabilizer जरूर देना है. ठीक है? Okay? Alright. Next. What would you like to give as a drug of choice in generalized anxiety disorder? Generalized anxiety disorder. GAD or GAD. Generalized anxiety disorder. जल्दी जल्दी बताओ मुझे गाइस. सारे ड्रग्स ऑफ चॉइस चाहिए मुझको. ड्रग ऑफ चॉइस एक या दो ही होते हैं मैक्सिमम. ऐसे नहीं होता कि 15 ड्रग ऑफ चॉइस हो, या एक क्लास या एक ग्रुप होती है ड्रग ऑफ चॉइस, है ना. तो मुझे जीएडी, पैनिक, फोबिया के ड्रग ऑफ चॉइस बता दो. फेयरली सिंपल. गुड. एसएसआरआई सही है. नहीं नहीं, नॉट बीटा ब्लॉकर. सी गाइस, ड्रग ऑफ चॉइस मतलब होता है मेन स्टे. ये तुम जो ऐसे बता रहे हो ना बीटा ब्लॉकर, वो एक add-on होता है. Add-ons are not the mainstay drug of choice. Yes, SSRIs. Good. सही बोला है. एकदम SSRIs यहाँ पे सब में बीटा ब्लॉकर benzodiazepine will be add-ons for short period, not drug of choice. Okay. SSRIs. Now let's see. In panic, we prefer a drug called paroxetine. In GAD, we prefer drugs like escitalopram, fluoxetine, sertraline, all of these. Okay? SSRI is the main group. Absolutely right. Whoever said SSRI in the first place, you are absolutely right. SSRI is the main group. Okay? These are add-ons. Understood? Understood. Okay, next. PTSD, post-traumatic stress disorder. What happens in post-traumatic stress disorder? There's hypervigilance. A major stressor has happened, है ना? Catastrophic nature. Hypervigilance, there is nightmares, there's hyper arousal and flashbacks. What do you like to give in PTSD, guys? PTSD. No, not propranolol. I just told you, a drug like beta blocker or a drug like benzo, we will not be using as a mainstay drug, guys. I just explained to you that drugs like benzos and beta blockers will be add-ons, not the mainstay, not the drug of choice. SSRI, yes. Here, essentially, we use drugs like escitalopram, we use sertraline. There's another drug that we use here often that is called prazosin, especially for the nightmares. Okay, because of the hyperarousal and nightmares, we also use prazosin. ADHD, attention deficit hyperactive disorder. What is the time period for PTSD? We have a question on that later. We'll come to it. 30 days, 4 weeks, correct. Above. So we'll come to PTSD again. Okay, acute stress and post-traumatic stress we'll repeat. अभी हम सिर्फ ड्रग ऑफ चॉइस कर रहे हैं. I will not go into the details of the syndrome. We will talk about the details later. Drug of choice for ADHD. Drug of choice. Start with the number one drug of choice. Then move on to the second line drug. Then move on to the third line drug. Do not say beta blocker this time. Atomoxetine, second line. Okay, second line. Which is a non-stimulant. Atomoxetine, reboxetine, these will be second line, non-stimulant. Methylphenidate, thank you. Stimulants are the drug of choice, right? Modafinil, again, very weak line drugs, guys. No. Methylphenidate. Methylphenidate is the drug of choice, right? Stimulants, okay? Non-stimulant like atomoxetine, reboxetine can be second line. The third line can be drugs like bupropion, clonidine, etc. Okay? If there's ticks, yes, you can choose clonidine. Correct. Drug of choice, delirium, where there is disorientation in an acute form to time, place, and person, and it is reversible. What is the drug of choice in delirium? See, guys, we are doing all the drugs of choice, hai na? Because that will give us an edge. Typically, almost every question, if clinical, is around how do you treat it, and for that you need to know the diagnosis, which we'll come to a little in the second half. But at the same time, we also need to kind of know the drug of choice at the tip of our tongue. Drug of choice for delirium. Yes, haloperidol and benzodiazepines like diazepam, but haloperidol is a better drug of choice. Then comes benzodiazepine. Agreed. Both are correct answers, but haloperidol is the first line and then is benzodiazepine. Correct. We can also give second generation antipsychotics, but haloperidol or second. So depending, what are the options available? Open your eyes and see. If haloperidol is available, forget everything, right? Haloperidol. If haloperidol is not available in the options and a benzodiazepine is available for delirium, please select that. If a second generation antipsychotic and a benzodiazepine is available, second generation antipsychotic like olanzapine and quetiapine, which are actually sedating, if they are available in delirium, choose that. Not over haloperidol, but over benzodiazepine. Okay? All right? Great. Don't say beta blocker. I know many people are like, oh, maybe for the autonomic hyperactivity, I would like to give beta blocker. Not the drug of choice, right? Add-on drugs are add-on drugs. Next, dementia. If alcohol delirium is present, yes, then benzodiazepine plus. We'll come to that. We'll come to that. Shanti rakhiye, bilkul aayenge hum. Now tell me Alzheimer's ka drug. Why are we starting again with second line drug? Always start with first line drug. First line drug. Donepezil. Yes. Rivastigmine, galantamine, and memantine. Mild to moderate, even memantine plus donepezil can also be used. Memantine plus yes, absolutely right. Memantine plus donepezil can also be used. What is donepezil? It is cholinesterase inhibitors, but memantine works on the NMDA receptors. Okay, what if your patient, answer this for me guys, what if your patient cannot take oral drug and he has Alzheimer's dementia? What kind of drug can you give this patient? What if your patient can't take oral drug? Cannot tolerate oral drug? So what will you do for this patient? What will you give this patient? What if your patient cannot take oral drug? You still need to give him in Alzheimer's because they are often very reluctant. Rivastigmine, very good. Rivastigmine as patch. Let me ask you one more question. Can you tell me one more use of memantine? Yes, transdermal patch of rivastigmine. Good. Can someone tell me one more use of memantine? It is used in Alzheimer's dementia. Done. Where else can you use memantine? One more use of memantine, please. Guys, I keep saving my notes simultaneously. एक दो बारी क्या हुआ है मेरे सारे notes उड़ गए हैं. One more use of memantine, please. Lewy body dementia. Good answer. I like it. But one more use of memantine. Okay, what do we use in dementia of Lewy body? What do we use in Lewy body dementia? One more use of memantine is Riva. I think आप पिछले आंसर्स दे रहे हैं. Okay, I want you to find this out. One more use of memantine. I'll tell you in the end. If somebody will remind me in the end, I will tell you in the end. Dementia with Lewy body. Again, you can give them donepezil. You can give them... Acha, in Lewy body you're saying. Okay. You can give them rivastigmine. Yes. What should you not give? What should you not give in Lewy body? What should you avoid like the plague in Lewy body dementia? What should you avoid? Psychiatric diagnosis schizophrenia. No, not sedatives. What should you avoid in Lewy body dementia at all costs? Antipsychotics should be avoided in Lewy body dementia. Dopamine blockers. Good. Antipsychotics are dopamine blockers. Yes, you are right. In a way, you are right. Absolutely, you're right. Because in a way, you're telling me to not reduce the dopa there. It's fine. So don't give any first generation antipsychotics. Avoid them, otherwise the patient will worsen. You must give, then you give them second generation like clozapine and quetiapine, but avoid antipsychotics as much as possible. Good. What do you give as a drug of choice? DOC. We are still playing the drug of choice. Schizophrenia, acute phase. What would you like to give a patient in acute phase of schizophrenia? Quickly, guys. I want very quick answers from you. Acute schizophrenia. DOC. Acute schizophrenia. Drug of choice is? Haloperidol. Okay, so basically, first generation or second generation antipsychotics. We prefer second generation antipsychotics over first generation antipsychotics nowadays because of lesser extrapyramidal symptoms. So we can give drugs like olanzapine, we can give drugs like risperidone, quetiapine, we can give drugs like amisulpride, we can give drugs like haloperidol, right? Atypical antipsychotics, yes. Haloperidol is obviously a first generation antipsychotics. Okay. Treatment resistant schizophrenia, drug of choice. Treatment resistant schizophrenia. So basically, when the patient has failed to give response to at least 2 typical antipsychotics for adequate duration, अच्छे enough time के लिए दिया है, so we call it a treatment resistant schizophrenia. What is the drug of choice of treatment resistant schizophrenia? Absolutely right. Very important. Clozapine. We'll do the details a little bit later. Okay. Correct. Catatonia, drug of choice. Catatonia is what? Holding the posture in the same position or being very mute or akinetic for very, very long or having like a psychological pillow. That is catatonia. Position ko pakde rakhna is catatonia. What is the drug of choice for catatonia? Yes, very good answer, dear future. Lorazepam, benzodiazepine like lorazepam. And then ECT is also a very good treatment. So it's not the drug of choice, it's the treatment of choice for catatonia. Very nice. IV lorazepam or ECT. Very good. Next is neuroleptic malignant syndrome. Now what happens in certain patients? when we start them on antipsychotics, they can develop neuroleptic malignant syndrome. What will happen? Very high grade fever, lead pipe rigidity, the creatine kinase goes up. That means myoglobin nuria, that means the muscles are breaking down. Okay, and the patient is confused, disoriented, so his muscles are in spasm. What is the drug of choice that you would like to give? Drug of choice for NMS. Now, the question is dantrolene and bromocriptine. This combination is the best answer. Dantrolene is a muscular relaxant. Bromocriptine will increase the dopamine, because this happens because there's very rapid depletion of dopamine, right? Here, dantrolene plus bromocriptine is the best answer. If you only find dantrolene in the option, go for that as the first thing. Okay, dantrolene and bromocriptine. Good. Drug of choice of enuresis or bed wetting. Enuresis or bed wetting. Drug of choice. Yeah, drug of choice. Desmopressin and imipramine. Okay. OCD, the drug of choice are the two F's, that is fluoxetine, then comes fluvoxamine, and if there is no response, we can also go for clomipramine. Okay. What is the drug of choice for major depressive disorder? Drug of choice for major depressive disorder. Yes, I will share. Where will you find it? You will find it in the Telegram group, or you will find it in the MedEd app. Major depressive disorder, any of the SSRIs. Then you can also go for SNRIs. Then you can also go for other drugs, right? Like NDRI, etc. All right. Now, tell me melancholic depression drug of choice. Drug of choice for melancholic depression. Melancholic, some people call it. Melancholic depression is actually a previous old term, meaning we don't use it anymore. Essentially, it means when you wake up very early, when you are very somatic. Those are the features of melancholic depression. And the drug of choice there would be TCAs. What about atypical depression? What about atypical depression? In atypical depression, सब कुछ उल्टा है. Means the person sleeps too much, eats too much, gains weight too much, has something called leaden paralysis. मतलब ऐसा लगता है पैरों में ना बहुत पाइप डाली हुई है. The person has reactivity of mood. मतलब मूड रिएक्ट कर सकता है. अगर अच्छी खबर सुनी तो अच्छा लगता है. What is the drug of choice for atypical depression, guys? Atypical depression. Drug of choice for atypical depression, please. No, not SSRI, not SNRI. No. Atypical depression, please. I told you what is atypical depression. Now I expect you guys to tell me what is the drug of choice. Postpartum पे क्यों पहुंच गए? Drug of choice of atypical depression तो बताओ. You guys are going ahead. Please don't. Atypical depression का मेरे को please drug of choice बताओ. Come on. Somebody had answered correctly. इसने delete क्यों कर दिया? मिल ही नहीं रहा मुझे वो आंसर. Somebody had written, I think. They quickly deleted it. MAO inhibitors are used more than anything else in drug of choice. Sorry, where have I written this? MAO inhibitors are used as a drug of choice in atypical depression. Okay. Yes, now everybody's saying MAO. Dear future, you've written. Why did you retract it? Postpartum depression. Actually, we first prefer therapy or CBT or counseling, and if we must give, then SSRIs are considered safe, especially drugs like sertraline, escitalopram. Okay? All right. Next, serotonin syndrome. Again, there is excessive fever. There is deep tendon reflexes which become exaggerated, right? Postpartum depression, sertraline. Correct. In serotonin syndrome, there is too much serotonin. Now, how would that happen? When you combine too many serotoninergic drugs like SSRI plus SNRI or SSRI plus TCA or MAOs, or SSRIs plus something called triptans used for your headache, or SSRIs plus something called St. John's wort. So there is high fever, there is again there's confusion, deep tendon reflexes are exaggerated. What is the drug of choice for serotonin syndrome? Cyproheptadine, very correct. Cyproheptadine, very correct. What do you give for benzodiazepine overdose? Very good, Dr. Dear Future. What do you give for benzodiazepine overdose? The patient has taken too many Alpraxis or too many lorazepams. What is the drug of choice for benzodiazepine overdose? Good, you guys know quite a lot. I'm very impressed. What is the drug of choice? Also with tramadol, yes. Linezolide, yes. You're absolutely right. Also with tramadol, drugs like linezolide, yes. Correct. Very good. I like it when you guys add to my pointers. It's important. So, what is the drug of choice for benzodiazepine overdose? Perfect. Good. You guys know a lot, yaar. I'm impressed. Flumazenil. Very nice. Flumazenil. What is the drug of choice for alcohol withdrawal? Somebody had said this earlier. Now we are on it. What is the drug of choice for alcohol withdrawal? Drug of choice for alcohol withdrawal. Okay, but first give thiamine before anything else. Then give benzodiazepine like lorazepam, diazepam. Imagine if the patient has liver complications. LFTs are deranged. Which benzodiazepine would you like to give to the patient? Which benzodiazepine would you like to give to the patient if he has liver complications? Imagine if the patient has very poor deranged LFT. Which benzodiazepine would you like to give this patient? Which benzodiazepine would you like to give this patient? LOT drugs, correct. That is lorazepam, oxazepam, temazepam. Perfect. Very nice. What about alcohol dependence to prevent relapse? What kind of drugs can you give them? One are the anti-craving drugs and one is antabuse. What kind of drugs would you give under anti-craving drugs for alcohol dependence? Dr. Jay Jadhav, give me the full form of stole. Diazepam is not an alcohol anti-craving. It is antabuse, right? Diazepam falls under antabuse or aversive therapy. उसको पीने से उसके ऊपर दवा अल्कोहल पीने से क्या होता है? फ्लशिंग हो जाती है. Which is the rate limiting enzyme step in rate limiting enzyme in disulfiram reaction? Tell me the rate limiting enzyme in the disulfiram reaction. Okay, so there's naltrexone, yes, there's acamprosate, which are anti-craving. There is baclofen and topiramate. Alcohol dehydrogenase, alcohol ki aldehyde, alcohol ki aldehyde, alcohol ki aldehyde, alcohol ki aldehyde. That's a big question. नहीं बताऊंगी. I want you guys to find out. अभी तक ये वाला आना चाहिए था. Yeah, exam is just a week away, guys. What is the rate limiting step? Aldehyde. Good. Good. Okay, any questions so far? We've done practically all the major DOCs or the drug of choice. We're now moving on to lithium. We'll then talk about the other various drugs. A lot of psychotherapy I'm covering, after which we're going to start covering one-liners about major disorders. Okay, I hope you all have the booklet. Do you all have the PDF booklet, guys? Even though I will share my version, but do you have the booklet? आप लोग के पास है ना? आप लोग के पास है ना? Okay. Let's talk about lithium. I would like to keep asking you guys some question and I will keep teaching you. Obviously, the indication of lithium is... One second, guys. Bipolar affective disorder, right? Especially in mania. It's a mood stabilizer. But it is also used in schizoaffective affective disorder. It also has anti-suicidal properties, and it can also be used in cluster headache. Right? Now, kidney or the renal system is involved in excretion of lithium. So it bypasses liver, which is a great thing. Therapeutic level, I want you to tell me the acute therapeutic level and maintenance therapeutic level. Acute and maintenance therapeutic level, I want you guys to tell me. Yes, it causes Epstein's anomaly in the child if the mother is given this throughout the pregnancy. The side effect could be okay, acute 0.4 to 1.5. No, acute 0.8 to 1.2. Correct. Milli equivalents per liter. What about maintenance? Can you tell me maintenance as well? 0.8 to 1.2 is acute. Correct. No, Dr. Jay Jadhav, कुछ गड़बड़ कर रहे हो आप. 0.8 to 1.2 is acute. Correct. 0.6 to 1.2 and in some places 1.5 is the maintenance. So notice that we need higher dosage for the acute phase, and for the maintenance lower will also do. Understood? More than 1.5 is toxicity. Correct. Got it? Above 1.5, not 1.6. Correct. All right. Now, when it comes to the side effects, notice L for leukocytosis, I for diabetes insipidus, increased thirst, increased weight, increased appetite, T for tremors, H for hypothyroidism, TH basically, M for malformation, and S for skin issues like acne. Lithiums is a mnemonic for the side effect. Lithiums is a mnemonic for the side effect. When do we check blood? We check the blood always 12 hours after the last dosage. It takes minimum 3 to 5 days for the blood levels to build up actually after the first dose. Long-term effects, hypothyroidism, weight gain, as I said, right? Tremors, very common. And toxicity more than 1.5. And yes, in toxicity, what do we find? We will find tremors worsening. We will find the patient confused. We will find, why does toxicity happen? Toxicity happens typically when there is dehydration. So the patient may be not drinking enough water. When the seasonal change happens, we find toxicity happening often, right? Yes, hemodialysis is required because it is through the kidney. It can be cleared out through the kidney. Correct. All right, guys, we're going to take like a 2-minute break and be back and we'll continue. Okay. 2-minute break only. I'm quickly going to come back. All right, students, I am back. Are you back? Students, are you back? Telegroup link for MedEd. Go to Telegram and type MedEd. You will find it. Is everybody back? Guys, because this is marathon, we're doing everything chatpat. Of course, डिटेल्स के लिए प्लीज जाके सारे लेक्चर्स फिर से देखो या फिर एक काम करो कि रैपिड वाला रिविजन एटलीस्ट देख लो इफ यू फील दैट कोई टॉपिक अच्छे से नहीं आता है. ऑफ कोर्स वी टीचर्स आर ऑलवेज हियर इफ any kind of mentorship is needed about a particular topic. I can send voice notes in the Telegram group. I can discuss with you. I can send you a small PDF, whatever you'd like. But definitely time is less for NICT. We need to get our guns blazing. Yeah. Okay. Let's move on, guys. Now we're talking about varenicline. What is varenicline? Varenicline is a beautiful drug which works at the alpha 4 and beta 2 receptors. And what it does, it causes anti-craving for smoking. सिगरेट पीने की तलब या टोबैको की तलब को कम कर देता है. It is an anti-craving drug. Can someone tell me one more drug for smoking cessation? Imagine that varenicline is not in the option. What is one more drug that you can think of for smoking cessation? One more drug for smoking cessation. Not topiramate. No, topiramate is a drug for either headache, migraine prophylaxis, or it can be used, like we said, for alcohol, reducing the relapse. Bupropion. Perfect. Bupropion. Absolutely right. Correct. Which is an NDRI, norepinephrine dopamine reuptake inhibitor. Let's talk about ketamine. Important topic. Ketamine is a newer advancement drug which is basically a dissociative anesthesia. We used to use for anesthesia. It works on the NMDA receptors, and what it does, it's very nice in severe depression or very suicidal patient. And there's a spray which has been now legalized called Spravato that instantly relieves depression. Okay, so quickly relieves depression, but short-lived action is there. Okay, yes, treatment-resistant depression it can be useful in, or instantly relieving depression it can be useful in. S-ketamine, absolutely. Spravato or S-ketamine. Okay. Next are MAO inhibitors and TCAs. Look, these are older drugs. Still, for MAO inhibitors, you need to remember the cheese reaction. What is cheese reaction? The enzyme tyramine, when gets inhibited because of certain cheeses, wines, certain fermented food, when combined with MAO drugs, causes a lot of flushing. So we don't use them as much. For TCAs, you of course need to know that they are used for chronic pain. They're used in migraine prophylaxis. For example, drug like amitriptyline. One more TCA that you need to know is chromipramine, which is an anti-OCD drug used for OCD, right? Okay. Now we are talking about another important drug, clozapine. Clozapine. What is clozapine? It is a second generation antipsychotic. So it works on the dopamine receptor, but it works a lot more specifically on D2 than D4, and what that leads to is that it is used in treatment-resistant schizophrenia. Treatment-resistant schizophrenia, as I already said, is that when there are at least two first generation antipsychotic or antipsychotics that have been tried for adequate period, then there is no response, is called treatment-resistant schizophrenia. What are the fatal side effects versus what are the other side effects? Tell me fatal side effects versus usual side effects of clozapine. Okay, Dr. Swati Kannan, what I'll get done for you is, one second, I'll give you the Telegram group link. Okay. Fatal agranulocytosis. Yes, agranulocytosis, myocarditis, and even seizures can sometimes be fatal, right? And the regular side effects are wet pillow syndrome, which is also called siluria. Just like any other second generation antipsychotic, it can also cause a lot of sedation, weight gain, metabolic side effects. Okay, so therapeutic level, when do we check it? So we check it first weekly for the first 6 months. Then we check it once in 2 weeks for the next 6 months, and then once a month for the next year. The thing is, if the patient ever develops sore throat, immediately check. Okay. Therapeutic blood level has to be maintained for close-up in, right? It is around 450. It is around 450 mgdl in the patients that we need to maintain. Less than that, therapeutic effect may not happen. Amidst the newer drugs, I think I have a separate section on newer drugs. I'll just discuss that in this thing. If not, we'll come back to this. Please remind me. Now, some one-liners. Okay. What is anorexia nervosa? And what is the therapy of choice? Both I want to know. What, and also, I think for what also I have something separate, right? What is the therapy of choice in anorexia nervosa? Therapy of choice in anorexia nervosa. Therapy of choice in anorexia nervosa. Anorexia, no, we should do anorexia there only. Okay. What is the therapy of choice in anorexia? Therapy of choice in anorexia. What kind of CBT? What kind of CBT? Guys, one tiny second. I'm having a little difficulty here. Yeah. CBT for eating disorder. Okay. So anorexia nervosa, as we know, is a type of eating disorder. There are two types, restrictive and purging kinds. The patient's BMI is less than 17.5 or 18.5. And there is a gross misunderstanding in the perceived fatness. The patient thinks that they are very fat, even though they're not. So when they look in the mirror, they are very skinny in fact, but they perceive themselves to be much more fatter. Yes, cognitive behavioral therapy for eating disorder is the treatment of choice. Bulimia nervosa, on the contrary, means like ox, like an ox. So here the weight is very, very low. They can also be amenorrhea. But how is bulimia different, ma'am? In bulimia, first and foremost, the patient, yes, feels that they are fat, but their BMI is either normal or it could be even a little bit higher. Purging behavior or compensatory behavior are very common. What are compensatory behavior? Vomiting, purging, laxatives. These are very common. Yes, because the patient puts their hand to purge, there could be Russell sign. That is, the knuckles could be basically having a lot of teeth marks. Also, the enamel can be eroded, which is also possible. Also, there could be chipmunk facies, that is, parotiditis can happen. So, let me just write it down for you guys. So, there could be Russell sign, chipmunk facies, parotiditis, and enamel can be chipped off. Okay, there is no amenorrhea and the BMI is protected. What is BED? BED is actually the most common eating disorder out of these three. Here, the person eats large quantity in a short time and has a lot of guilt and shame attached to it. BMI is not disturbed, nor is there any dissatisfaction with their body image. So there is no body image disturbance. There is no body image disturbance. मतलब उनको मोटा हूं कि पतला उससे फर्क नहीं पड़ता है. एनोरेक्सिया और बुलिमिया में बहुत पतले होने का इच्छा होती है. एनोरेक्सिक एक्चुअली पतले होते हैं, पर उनको लगता है कि यार मैं बहुत मोटा या मोटी हूँ. ज़्यादा फीमेल्स में देखा जाता है. बुलिमिया में उनको चाहिए होता है कि वो पतले हों, पर वो ज़्यादातर पतले नहीं होते, वो ऑक्स जैसे लगते हैं. और उनका एक्चुअली बीएमआई नॉर्मल रह सकता है, लो नहीं होता है, ना एमेनोरिया होता है. एंड दे डू ऑल ऑफ दीज कंपनसेटरी बिहेवियर. एनोरेक्सिया में भी बिंज टाइप एंड रिस्ट्रिक्टिव टाइप दोनों टाइप हो सकता है. बिंज टाइप एंड रिस्ट्रिक्टेड टाइप दोनों हो सकता है. ओके, अंडरस्टूड ईडी? Did you understand eating disorders? I have, and the treatment of choice will be, of course, CBT for eating. You can give medication, so you could give things like which increase appetite. You can give SSRIs. Did you understand eating disorders? SCOFF. Oh, good point. SCOFF is the criteria used for, who will tell me the full form of SCOFF? Full form of, batao. Full form of SCOFF, guys. Come on, guys. Give me the full form of SCOFF. What do we use it for? For eating disorder diagnosis, right? Yes. Do you eat till you feel sick? Do you lose control? Have you lost 1 stone, which is typically 6.1 kg of weight? Do you feel fat? And do you feel that food is taking over your entire life? Correct. Good. All right. Thanks. Next, we're talking about body dysmorphic disorder. In this, the person perceives flaw more than actual, meaning they may perceive that their hairline is going back. Even if it is going back a little bit, they may say, "Arey, it's going back so much." They may think that their nose is bigger than what they think it is. They may think that their private parts are bigger or smaller, but in reality they are okay, or they are actually normal for that matter, but it's a perceived flaw. What is the treatment of choice? How do we treat body dysmorphic disorder? Tell me the treatment of choice. We're still on the topic of treatment of choice. थोड़ा detail हर topic पे पढ़ रहे हैं, but we're also doing treatment of choice. One of OCPD. What? No. It's OCD spectrum, yes, but it is not OCPD. That is obsessive compulsive personality disorder. Guys, tell me the treatment of choice for body dysmorphic disorder. Again, CBT will be the treatment. Okay, बहुत सारे answers का CBT देने वाली हूँ. In somatic symptom disorder, the patient feels that they have aches and pains all over, or they have somatic complaints, when in reality there is no underlying feature which has been found as a causative. No underlying cause has been found. Okay. Again, you try to get the patient CBT along with somatic therapy also. conversion disorder, that is functional disorder, a functional neurological, functional neurological. Here is the conversion of your psychological symptoms into physical problems. So the body and mind keep score. There's a book called The Body Keeps Score, right? So the patient can present with sudden onset blindness. They can present with sudden onset seizures, which are also called pseudo seizures. Patient can present with sudden onset anesthesia of the part of the body, sudden onset amnesia, right? Labella indifference is seen, meaning फर्क ही नहीं पड़ता है. Patient is brought with paralysis, but the patient is just indifferent to it. Seen in more young females. There was an MCQ in the past which said that most commonly seen conversion disorder are in young females. Okay, young females, a lot more than males. Somatic and Munchausen, not the same. In Munchausen, it is actually the person is having some emotional gain from it, not monetary gain from it. They are creating it. In somatic, they are not creating it. Good question. In somatic, they are not creating it. It is just getting created because of all the stressors of life. In Munchausen's, they create it. Okay. Next is hypochondriasis or illness anxiety disorder. I also call it doctor shopping. Doctor shopping disorder. So the person is obsessed with usually one fatal or lethal illness. And they are sure that the doctors have missed out on treating them correctly. And they constantly look for doctors and they do doctor shopping, a lot of testing. And the disease is usually like cancer or something major. They are obsessed with one type of illness. Not in somatic, it could be vague, many illnesses. Whereas in hypochondriasis or illness anxiety disorder, specific illness is usually called by the patient. I think I have brain tumor. I think I have glioblastoma. They'll say like that. Okay. Okay. In trichotillomania, there is obsessive hair pulling, and we also find something called trichophagia, in which the patient may eat the hair, leading to a trichobezoar in the stomach, which is a hairball. Hairball, right? Next is kleptomania, which is impulse disorder. Impulse मतलब मेरा मन किया और मैं रोक नहीं पाई खुद के मन को. That is called, is in Munchausen doctor shoppers. Well, they are doctor shoppers in a different way. They are hospital hoppers, essentially. They go from one hospital to another. They usually get admitted because of the severity. Doctor shopping is also used because you keep changing your doctor again and again and keep looking for a better doctor. Okay, can be used in both. It's not a hard terminology, it's a soft terminology. In psychiatry, we in medicine, sometimes we have soft terminology, sometimes we have a hard synonym. It's not a hard synonym. Okay, now kleptomania is stealing. What do people steal? These people are stealing things which they can afford. A pen, a pencil, an eraser. It is not something very expensive. तो मेरे को ये दिखा, मैंने ये ले लिया, मैं इसके पैसे दे सकती हूँ, ये इतना महंगा नहीं है, पर मैंने ये देखा, मेरे को अच्छा लगा, मैंने ले लिया. So that kind of shoplifting it gives them a high is called stealing impulse or kleptomania. Correct. Now about insomnia, what I want you to know is that avoid benzodiazepine because they can be addictive. Longer than 3 weeks. So we prefer Z drugs. What are Z drugs? Zolpidem, Zopiclone, right? You can also give melatonin. And obviously lifestyle changes like sleep hygiene is important. Okay. Alcohol dependence, I think we have covered in the past and we have something around it again. Okay. Nicotine dependence also covered. We covered about both varenicline, bupropion, nicotine replacement treatment can also be added, like chewing gum, lozenges, etc. Okay. Schizophrenia. In the stable phase, you basically give the patient social skills training and put them in milieu therapy. Family also needs a lot of support and education. In delusional disorder, therapy does not work very well. You need to give antipsychotics. In delusional disorder, unlike schizophrenia, there is one delusion, no hallucination. If hallucinations are there, then they support the delusion. So they may have delusion of infidelity, for example. We just discussed what was that, Omkara or Othello syndrome. Okay? In dementia, if there are behavioral symptoms, of course, treat the dementia, which means that you essentially give all the drugs that we discussed about. Sometimes adding things like donepezil, memantine, rivastigmine, etc. can in itself improve the dementia symptoms. But you may also have to add low dose antipsychotics and even SSRIs for behavioral symptoms. Okay. Tics and Tourette syndrome. Who will tell me the treatment for tics? We earlier discussed about tics with ADHD, but I want you to tell me that what is the drug of choice for tics and what is the treatment of choice for tic. Tics treatment. Yes. Clonidine. What else? What else? Yes, clonidine, guanfacine. Yes. What else can we give? We can also give certain second generation antipsychotics, and we can also give VMAT2 inhibitors like tetrabenazine and valbenazine. Okay. We will do behavioral training, help them change the impulse, and do CBT for the patient. What is adjustment disorder? Adjustment disorder. What is adjustment disorder? What is adjustment disorder, guys? What is adjustment disorder? Okay, let me tell you a story about adjustment disorder. Let's make it interesting. मान लो that somebody gives their INI-CET exam and doesn't get a good score. Now they are showing symptoms of depression, meaning they are having low mood, they are having poor sleep, hopelessness, helplessness, they are feeling like they can't eat very well, and all of this happened a week after the result. This is called adjustment disorder. So think of it like mini depression, but after a stressor, which is like it could be a breakup, it could be a loss of job, it could be moving cities, it could be failure in an exam. So that is adjustment disorder, right? So it is quite a normal thing that we consider, which happens to people when there is a stressor. Now, there could be symptoms of depression, there could be symptoms of anxiety, rarely there could be symptoms of psychosis. So, this is always after a stressor, right? Acute mild stressor within 30 days, right? Within 30 days of a stressor. Usually treats on its self-resolving, often self-resolving. Okay. May need a little bit of supportive therapy or CBT. May need low dose medication. Okay, acute mild stress. Okay. Now we'll talk about the difference between these two topics. Important. What is the difference between factitious disorder versus malingering? We'll talk about Mr. A and we'll talk about Mr. B. Mr. A brought his child to you. He says that the child has been peeing blood. You admit the child, you separate from the parent, and you see the child's peeing of blood stops. So you do thorough investigation and you realize that Mr. A was actually putting his own blood in the child's urine sample and saying that, look, the child is passing urine in the blood. Now, he was not doing it to get anything else except for maybe because he's been divorced lately. The gain was very emotional, not anything monetary. And he was doing it unconsciously. He was not doing it consciously to sabotage. That is Munchausen syndrome by proxy. By proxy because it is on others. Versus Mr. B. Mr. B has come back from prison. Okay. And he's been told go to work by his family. So he says, I am passing blood in my urine. And then, we investigate and we find out there is the blood in the urine is actually the blood is not even his, it's that of a dog. So you realize, wait, something is up. His gain is either to avoid work, it could be to avoid going back to jail, could be avoid responsibility. So there is a clear-cut gain that this person has, and it is definitely going to benefit him. This is the difference between factitious and malingering. Understood? Did everybody understand the difference? Did everybody understand the difference? Thumbs up, thumbs up, thumbs up. Give me a thumbs up so that I know that we are all on the same page. Okay, guys, we're almost halfway through and we'll be done in good time by 5:30. I'm happy with our speed so far. Okay. Question? Lie versus pathological lie. Wow, this is not correct. But okay, I'll give it to you. Okay, I'll give it to you. Done. Diya jai. Okay, understood? I want to know if you guys have understood or not. If not, then please ask, please ask, please ask. Happy to answer. Everybody understood? I need everybody to give me a little bit of encouragement that you have understood. Okay, cool. We're on to the next one. Let's move on to the next one. I want the therapy of choice for depression, which is mild to moderate. What would you like to do for mild to moderate depression? Mild to moderate depression. Mild to moderate depression. Please tell me the treatment. Mild to moderate depression, easy peasy. CPT. Severe depression with suicidality. What is the treatment? ट्रीटमेंट ऑफ थेरेपी ऑफ चॉइस की बात चल रही है गाइस, दवाई ऑफ चॉइस की बात नहीं हो रही है. ड्रग ऑफ चॉइस हमने ऑलरेडी पढ़ लिया है ना. अभी हम थेरेपी या ट्रीटमेंट ऑफ चॉइस की बात कर रहे हैं. ट्रीटमेंट और थेरेपी ऑफ चॉइस की बात कर रहे हैं. ट्रीटमेंट फॉर सीवियर suicide dual 90%. No. Severe, give me the therapy first. Okay, fine. SSRIs I'd like to give. Antidepressants I'll give. But वो तो time लगेगा act करने में. Severe depression with suicidality. What should I do? Severe depression. Try. No, CBT will take so long. Yes, ECT. ECT. I also gave you a drug recently. I know we're doing therapy of choice, but ketamine assisted psychotherapy can also help. Okay? ECT is the answer that I'm looking for. Absolutely right. Current law. That's not a nice way of thinking of ECT. Do you know how many ECTs I've given? Countless. किसी को करंट नहीं लगता है, ना उसको भी, पेशेंट को भी, ना मुझको भी. ये मिथ होते हैं, मुझे भी थे करने पहले साइकेट्री, है ना. करंट लिटरली नहीं लगता है, लिटरली नहीं लगता है. एंड ऑल्सो एनेस्थीसिया के अंदर तो आप पेशेंट को काटते भी हैं, तो सर्जरी में क्या काट रहे हो आप, राइट. दैट्स वेरी लिटरलाइजेशन ऑफ इट, राइट. ओके, ECT is the right choice. Postpartum depression with psychosis, again, don't wait for the patient to get worse, please. She may be dangerous to self or to the baby, so you need to give instant results. ECT is the treatment of choice. Okay, all right. What is the therapy of choice for OCD? OCD में कौन सी थेरेपी देते हैं? नहीं, CBT नहीं देते हैं. पहली जगह जहां CBT आंसर नहीं आ रहा. Exposure response prevention, yes, and acceptance, commitment therapy. Right. पैनिक डिसऑर्डर में क्या करेंगे? अच्छा, वेयर डज ERP नॉट वर्क? वेयर डज दिस ERP, एक्सपोजर रिस्पॉन्स प्रिवेंशन, नॉट वर्क? Where does exposure response prevention not work? Any guesses? Where does exposure response prevention not work? Where does ERP not work? Where does ERP not work? The question is not. Not. In which type of OCD? In which type of OCD does ERP not work? Come on, guys. नो, ऑब्सेसिव स्पेक्ट्रम कैसे? ऑब्सेसिव स्पेक्ट्रम तो पूरा का पूरा ओसीडी है. Natural. Have you heard of a term called hoarding disorder? Have you heard of a term called hoarding disorder? Hoarding disorder is a subtype of OCD where ERP does not work. Okay? It's a PYQ. It's a PYQ. What do you do in panic? In panic, disgust-based OCD. I don't understand. In panic, you teach the patient how not to panic through relaxation, deep breathing, JPMR, supportive counseling, and CBT. In GAD, of course, CBT, social anxiety. Is there any specific duration for hoarding? No, there isn't. Social anxiety disorder. I am very scared of meeting new people. I feel embarrassed. I feel flustered. I feel they're judging me. Hence, I avoid any party. I get extremely conscious. Yes, we will try CBT, but we will also gradually sensitize. Gradually, we will expose the patient. Or what if we do flooding? We open all the floodgates to this patient. दवाई की बात नहीं कर रहे हैं, दवाई की बात नहीं कर रहे हैं, दवाई की बात नहीं कर रहे हैं, therapy की बात कर रहे हैं. What if we open all the floodgates for this patient in social anxiety and say, go, speak on the stage? That's called flooding. Okay? Otherwise, we usually do systematic desensitization. Systematic desensitization. Step by step, we gradually escalate. We make a ladder or hierarchy of problems and we gradually go up the ladder. PTSD. Again, we do trauma focused CBT. ADHD, we sometimes do token economy for children. मतलब अच्छा बिहेवियर करो तो तुमको हम कुछ कॉइन्स देंगे, उस कॉइन से तुम अपनी पसंद की चीज खरीद लेना. एंड वी डू बिहेवियरल थेरेपी. But in autism spectrum, there is a specific kind of treatment we do. In autism spectrum, chalo, I'll let you guys tell me. In autism spectrum, we do a particular kind of therapy. What is that kind of therapy in autism? EMDR also, absolutely right. EMDR. So in EMDR, a light is shown to move from one side to another, and it is said that the reprocessing traumatic memories during this movement can help you get and feel better. So correct, EMDR and CBT trauma focus is in PTSD. ABA or applied behavioral analysis is used in children with autism spectrum disorder. Okay. In conduct disorder, you basically try to do behavioral therapy. Borderline personality disorder, who will tell me the treatment or therapy of choice? I will give a virtual chocolate to you. Virtual chocolate. If you tell me the therapy of choice for borderline personality disorder. I will give a virtual chocolate. Virtual chocolate. बीपीडी का ट्रीटमेंट कोई बताएगा तो मैं उसको वर्चुअल चॉकलेट दूंगी। नहीं नहीं, मैं सीबीटी नहीं आंसर। सीबीटी होता आंसर तो मैं अभी तक तो तुमको बता ही चुकी होती। वर्चुअल चॉकलेट इफ यू टेल मी बॉर्डरलाइन पर्सनालिटी डिसऑर्डर का ट्रीटमेंट ऑफ चॉइस, थेरेपी ऑफ चॉइस। मैम का स्किन केयर बता देना, चॉकलेट नहीं चाहिए। चलो ठीक है, वो भी बता देंगे। बताइए। बीपीडी ट्रीटमेंट, थेरेपी ऑफ चॉइस, कम ऑन, यस डीबीटी, फैब गाइस, आता तो है तुमको, ऐसे टाइम पास कर रहे थे। क्या है फुल फॉर्म डीबीटी का? डीबीटी तो बोल दिया, फुल फॉर्म भी बता दो। डायलेक्टिकल behavioral therapy. Perfect. DBT. Great. Postpartum psychosis, of course, give ECT or you start the patient on antipsychotics. Monitor carefully. What is the drug of choice for rapid cycling bipolar, and what is rapid cycling bipolar? What is the drug of choice for rapid cycling bipolar, and what is rapid cycling bipolar? Four-time mood up. Okay. At least 4 times switches. These are called switches. Switches of polarity. मतलब मेनिया से डिप्रेशन, डिप्रेशन से मेनिया, डिप्रेशन से मेनिया, मेनिया से हाइपोमेनिया, हाइपोमेनिया से डिप्रेशन, डिप्रेशन से हाइपोमेनिया. Okay, 4 times switches in 1 year. Correct. What is the drug of choice? Sodium valproate. Fantastic, guys. What is cyclothymia? साइक्लोथाइमिया और रैपिड साइक्लिंग में क्या फर्क है? डिफरेंस बिटवीन साइक्लोथाइमिया, साइक्लोन लिखा हो रहा है, साइक्लो, मैं जब आपको मैसेज कर, साइक्लोथाइमिया एंड रैपिड साइक्लिंग. तो देखो, रैपिड साइक्लिंग इज अ सब टाइप ऑफ बाइपोलर अफेक्टिव डिसऑर्डर, पूरा का पूरा बाइपोलर डिसऑर्डर. साइक्लोथाइमिया इज लाइक मिनी बाइपोलर, जिसमें पूरा का पूरा बाइपोलर नहीं हो रहा है. व्हाट डज दैट मीन? सब थ्रेशोल्ड मैनिक एंड सब थ्रेशोल्ड manic and depressive symptoms for more than 2 years in an adult and for more than 1 year in a child is called. में बंदा all the time रहता है, कुछ स्टेट में फुल ब्लोन नहीं होता है, फुल ब्लोन सब थ्रेशोल्ड बाइपोलर इफेक्टिव रहता है, पूरा नहीं रहता है. whereas रैपिड साइक्लिंग बाइपोलर डिसऑर्डर एक सब टाइप ऑफ बाइपोलर डिसऑर्डर है. ठीक है, माइल्डर फॉर्म ऑफ बाइपोलर डिसऑर्डर. गुड, आप लोगों को पता है. डिस्थाइमिया इज माइल्डर फॉर्म ऑफ डिप्रेशन, फुल क्राइटेरिया नहीं मिलता है. अगेन, मोर देन 2 years इन एन अडल्ट, मोर देन 1 year chronic in a child. Premenstrual dysphoric disorder is in the luteal phase, the patient presents with irritability. So there are physical symptoms and there are emotional symptoms. Now, TMS का ये ज़्यादा severe form है. The drug of choice are SSRIs. Some people also react well to OC pills, and lifestyle changes are to be also recommended. Okay, irritability, bloating, tenderness, mood swing, craving, crying, all of these episodes can be there. Okay, क्लेप्टोमोनिया, आई थिंक हमने ऑलरेडी कर दिया ना. इम्पल्स टू स्टील, सॉरी फॉर द रिपीटिशन. इम्पल्स टू स्टील. ट्राइकोटिलोमेनिया भी हमने पहले कर दिया गाइस. बॉडी डिस्मॉर्फिक डिसऑर्डर भी हमने कर दिया. ओके, व्हाट इज इंटरमिटेंट एक्सप्लोसिव डिसऑर्डर? Intermittent explosive disorder is when there are sudden, extreme outbursts of rage, unprovoked, but no other underlying diagnosis like bipolar, etc. Now, this is important for you to know because the history will be presented that the person has a one-off excessive episode. Okay? All right. एक और चीज थी, एक क्वेश्चन पूछा गया था पीवाईक्यू में, डिसरप्टिव मूड डिसरेगुलेशन सिंड्रोम, डिसरप्टिव मूड डिसरेगुलेशन डिसऑर्डर, जो कि ज्यादा की तर चिल्ड्रन में देखा जाता है. वो और आईडी में ये फर्क है. एक तो आईडी एडल्ट्स में होता है. डिसरप्टिव मूड डिसरेगुलेशन डिसऑर्डर में बच्चा हर समय थोड़ा सा इरिटेबल रहता है एंड आउटबर्स्ट्स देता है, बट इट इज डिफरेंट फ्रॉम कंडक्ट डिसऑर्डर and it is different from ADHD. So you have to rule out ADHD, you have to rule out conduct disorder. That is disruptive mood dysregulation disorder. Disruptive, ये बच्चों में देखा जाता है. मूड डिसरेगुलेशन डिसऑर्डर. ठीक है. ऑलराइट. नेक्स्ट, आई थिंक इंसोम्निया हमने ऑलरेडी कर लिया है. कुछ रेपिटेशन है, सॉरी गाइस. ओके, ये तो आप लोग मुझे बताओगे. व्हाट आर द स्टेजेस ऑफ अल्कोहल विड्रॉल? प्लीज टेल स्टेजेस ऑफ अल्कोहल विड्रॉल एंड ट्रीटमेंट. ऑल्सो डीएमडी बता दो. अच्छा ठीक है. डीएमडीडी का क्वेश्चन ऐसा बना होगा. An 8-year-old child presents to you with sudden outbursts of getting very angry. He is angry most of the time. However, the child does not steal, does not bully, can pay attention, and he has had एक और चीज लिखी थी PYQ में. And there are no underlying organic causes. So let me find the PYQ as well for you. I think that will be helpful for you. Let me just look up the PYQ. Let me just look at my notes and find you the PYQ exactly जो DMDT पे था. It will clear out things. Give me 5 minutes. तब तक आप लोग मुझको ये बताइए, अल्कोहल विड्रॉल के स्टेजेस बताइए, जब तक कि मैं आपके लिए DMDD वाला क्वेश्चन ढूंढ के निकाल रही हूँ. Come on guys, I need this from you. This one I'm not going to answer. I need this one from you. In return, I am giving you the DMDD PYQ. I'm just taking out my notes and giving you DMDD PYQ. Go for it, guys. I want all the stages of alcohol withdrawal along with treatment from you. Alcohol stages along with please answer alcohol withdrawal full. Please answer alcohol withdrawal full, guys, till I'm finding you that question. Yeah, I got the question. Yeah, I have got the question. I will only give you the answer if you give me the answer. एक्सचेंज मॉडल चल रहा है. क्वेश्चन मिल गया मेरे को. प्लीज अल्कोहल आंसर कर दो गाइस. आता तो है तुम लोगों को. प्लीज, ये वाला आप लोगों को आता है, मैं नो वे में बताने वाली हूँ ये आप लोगों को। एंगर, रिबाउंड रैम, एंगर, anger is a symptom of, no, don't say anger, please. How can anger be the symptom for delirium, alcohol withdrawal? Alcohol withdrawal में anger कैसे symptom होने लगा? I'm using it. Tremor, auditory, अरे कौन सी स्टेज बता रहे हो, ये तो बताओ। Mild, moderate, severe, life threatening. एंगर होने लगा ना अगर सिम्टम, मजा ही आ जाएगा। ये सब मैं नहीं लिखने वाली, ये सब आप लोगों को आता है, इसलिए मैं नहीं लिखना चाहती। आई एम प्रीटी श्योर यू गाइज नो दिस। Okay. You will solve this on your own. I'm going back to the question that you all have asked me because I really like that question. कि मैम DMDD, disruptive mood dysregulation disorder का क्या question होगा? Okay, let me just write down that question for you. Skip कर दो, आता है ना सबको? Okay, DMDD. So, DMDD का question ना typically ऐसे बना होगा. Let's say a 7 or a 8-year-old boy presents to you with severe child, it could be a child, with severe anger outbursts out of proportion of the situation. मतलब उसके मम्मी पापा ने उसको हार्डली कुछ कहा पर वो इतना गुस्सा हो गया, and almost every day for the past 1 year. What is the most likely diagnosis? And the options were DMDD, conduct disorder as I told you, ADHD and oppositional defiant disorder. अब इन चारों में कैसे डिफरेंशिएट करना है? सबसे पहली बात, when we speak of DMDD, DMDD by default is in children between 6 to 18 years of age. ठीक है? Second thing, it needs to be nearly every day and it is very severe out of proportion along with persistent irritability. ये चीज आपको ना कंडक्ट डिसऑर्डर में मिलेगी, ना ADHD में मिलेगी, ना ऑपोजिशनल डिफाइंड डिसऑर्डर में मिलेगी। persistent irritability. Duration has to be at least 3 times per week and age of onset has to be less than 10 years of age. तो ये एज ग्रुप बहुत इंपॉर्टेंट है। अब बात करते हैं कंडक्ट डिसऑर्डर वर्सेस ऑपोजिशनल डिफाइंड डिसऑर्डर में। कंडक्ट डिसऑर्डर में एकदम लाइंग, स्टीलिंग, बुलिंग, बहुत कुछ होता है बिलो 18 ईयर्स और ये बच्चे जाके आगे डायग्नोस होते हैं एंटी सोशल पर्सनैलिटी डिसऑर्डर से। ऑपोजिशनल डिफाइंड डिसऑर्डर में किसी भी अथॉरिटी फिगर को बेसिकली नो बोला जाता है। आई डोंट वांट टू डू दिस, दे गेट इनटू फाइट्स, दे गेट इनटू स्मॉल फाइट्स। एज ग्रुप इज अगेन लेस देन 18 years and they are less severe, so they will not do bullying, they will not do stealing. So एज ग्रुप बता दिया मैंने आपको। DMDD में 6 to 18 years of age में देखा जाता है, but they always start before the age of 10 और हर समय इरिटेटेड रहते हैं, डिसप्रोपोर्शनेट अमाउंट ऑफ एंगर होता है। बेसिकली ये नया डायग्नोसिस बनाया गया है टू पिकअप चिल्ड्रन जिनको ओवर डायग्नोसिस हो जा रहा था बाइपोलर डिसऑर्डर का। अ लॉट ऑफ चिल्ड्रन वर गेटिंग डायग्नोसिस ऑफ बाइपोलर डिसऑर्डर व्हिच इज नाउ बीन रिवैम्प्ड इनटू डिसरप्टिव मूड डिसरेगुलेशन डिसऑर्डर। ठीक है, हाँ, एंड कंडक्ट डिसऑर्डर में बुलिंग, स्टीलिंग, चाकू दिखाना, फायर सेटिंग, पायरोमेनिया, ये सारी चीज़ें हो सकती हैं। वो इवन रेप भी कर सकते हैं किसी और का, वो इतने एक्सट्रीम होते हैं कंडक्ट में। बट ऑपोजिशनल डिफाइंड में छोटी मोटी चीज़ें कि गाली बक देना, किसी से गुस्सा कर लेना, झगड़ा कर लेना, लेस सीवियर। और ADHD आपको पता है इंटायरली डिफरेंट कॉम्प्लेक्स है जिसमें इम्पल्सिविटी, हाइपर एक्टिविटी और कॉम्बिनेशन ऑफ 2 होता है। उसके अंदर ये झगड़ा वगैरह ऐसे सीवियर नहीं होता है। ठीक है, तुम्हें लगता है तुम्हें DMDD है, क्राइटेरिया नहीं फुल करते हो तो फिर नहीं है ना। ठीक है, अच्छा गाइज, मैं अल्कोहल डेलिबरेटली छोड़ रही हूँ क्योंकि आप लोग कह रहे हैं आपको आता है, तो एक काम करो ना, सवाल पूछ लेते हैं तुम लोगों से, ये मैच कर दो। मैच द फॉलोइंग, 1 के साथ क्या है, 2 के साथ क्या है, 3 के साथ क्या है, 4 के साथ है। मैं आपके नोट्स बना दूंगी बट मुझे आप लोगों से आंसर चाहिए, बताओ। यस, ओडीडी में अग्रेशन इज मोर वर्बल, वेरी लेस फिजिकल, हार्डली एनी फिजिकल, एंड ऑल्सो विद अथॉरिटी फिगर, कि मेरे को ना टीचर से मैंने बात ही कर ली। गिव मी द आंसर फॉर दिस गाइस। वन बी, टू सी, थ्री डी, फोर ए। ओके, लेट्स सी। कुछ गड़बड़ है स्मूथ स्पेशलिस्ट, एक आंसर गलत किया है। देखो, डिलीरियम ट्रेमेंस में पेशेंट को ऑब्वियसली आप बेंजोडाइजेपिन दोगे, है ना, तो क्या दोगे, 1B, राइट। स्मोकिंग सिजेशन हमने डिस्कस किया, वैनिक्लिन दोगे। ओपियोइड ओवरडोज, नैलोक्सोन दोगे। ओ एक्चुअली आपने सही आंसर किया, सॉरी आई टेक दैट बैक, स्मूथ स्पेशलिस्ट यू आर करेक्ट। एंड अल्कोहल डी एडिक्शन में नैल्ट्रेक्सोन, अकैम्प्रोक्सेट, ये सब देंगे। B, C, D, A करेक्ट। जय यादव आंसर करेक्ट, संजय B, C, D, A आंसर करेक्ट, गुड, आप सबको आता है ये वाला, राइट। What are the differences between hypomania and mania? Mania requires at least 7 days, 4 days, or hospitalization. Degree of distress is mild to moderate in hypomania, severe in mania. In fact, there could be psychosis in mania. Speech is rapid, circumstantiality, tangentiality, clang association, pressure of speech is there, right? Whereas here the patient can be stopped. Also, no insight in mania. Insight may or may not be there in mania, in hypomania. Thought, like I discussed, there could be circumstantiality, there could be derailment, all the possible thought disorders that we discussed. That is, there could be delusion of grandiosity, there could be delusion of grandiose identity, ability, all of them can be there, right? Even delusion of persecution can be there based on various symptoms. Admission may require in mania. Hypomania, not really, can be managed at home. Psychosis is only present in mania, cannot be present in hypomania. Diagnosis, bipolar affective disorder type 2 if there is hypomania plus major depressive disorder or depression, as you say. Bipolar affective disorder type 1 if there is mania plus major depressive disorder. Understood? Differences between mania and hypomania. Now coming to this question. Somebody was asking this na pehle, acute stress, adjustment disorder, post-traumatic stress disorder. Okay. So, adjustment disorder हमने वैसे ही कहा था कि mild to moderate stressors होते हैं रोजमर्रा की जिंदगी जैसे, जैसे कि फॉर एग्जाम्पल दे कुड बी अ ब्रेकअप, दे कुड बी, यू कुड बी फायर्ड, you could have failed. Okay, hypomania will have increased productivity at work, minor will so severe will take chutti. Yes, okay. Post traumatic and acute stress disorder में it is catastrophic nature of the stressor. मतलब क्या है, बहुत बड़ा जो किसी को भी हिला दे, जैसे कि natural disaster, rape, किसी की डेथ देखना अपनी आंखों के सामने, इन फ्रंट ऑफ आइज, Onset. Who will tell me the duration of PTSD? I think somebody already told me. More than 4 weeks. Less than 4 weeks. Right? Next. Duration. It can actually last for more than 6 months also in post-traumatic disorder. And, sorry, ulta likh diya. Less than 4 weeks. सॉरी मैंने ऑनसेट और इसमें उल्टा लिख दिया है. Yeah, onset will be within a few days, whereas here it will be the duration. The onset can be after 4 weeks or 1 month. And it can also be up to 6 months, or prolonged PTSD or chronic PTSD or delayed PTSD can also be seen. Adjustment disorder varies actually. We don't have like a hard cutoff line. Yes, some people say 6 months, some people say a few months. Core symptom. I spoke about it. Hypervigilance, flashbacks, nightmares, hyperarousal, startle reflex, एकदम से चौंक जाना, आवाज हुई, दिल थी अरे फिर से बॉम्ब गिर गया. सो वॉर्स जब होते हैं जैसे जिन एरियाज में, जैसे अभी दुबई में इतने सारे मिसाइल्स गिर रहे थे, तो इट कैन कॉज पीपल टू हैव PTSD एंड ATSD later on, right? And here you can have either depressive features, anxious features, mixed features, and rarely psychotic features. Okay, all right. Ooh, this is important guys. मैंने lately trend देखा है, बहुत ज़्यादा dissociative से question पूछ रहे हैं, correct? Lately dissociative से बहुत ज़्यादा questions पूछ रहे हैं, correct? Lately dissociative से बहुत सारे questions पूछ रहे हैं. So let's do dissociative topic. Okay, I'm gonna answer them later. I'm gonna fill them up later. I'm gonna answer them first. Okay. So dissociative क्या होता है? Dissociative का मतलब होता है disassociate होना. किस चीज का dissociate होना? हमारा जो brain है वो reality से dissociate कर रहा है. क्यों dissociate कर रहा है? ये एक तरीके का protection है. What is it protecting against? There may be a major stressor in the current moment which your brain is trying to kind of cut off from. It's trying to deny the reality. So you could have dissociative amnesia. I don't remember who I am. I don't remember who you are. You're my close person. I don't really remember who you are. When did this happen? Not because of traumatic brain injury. It actually happened because we had a stressor. We had a huge fight. And now I left home and now I'm thinking, I don't remember where my house is or who you are. I am very conscious. My awareness around the surroundings is intact in dissociative amnesia. Okay. The trigger was obviously a fight or a stressor. Then is dissociative fugue. You know what? Our fight was so big that I actually left home and I traveled far, far, far away. I took a train and I took a train, then I took a bus, then I took another train, and I landed in some far-flung area of Tamil Nadu. So when people ask me, what's your name? So instead of saying my name is Dr. Aradatta, I said, my name is Rajni. And they said, what do you do? And I said, I actually don't do anything. I'm looking for a job. A few months later, the police catches me and says, hey, you are Dr. Aradatta. You teach in PW MedEd. So I said, no, my name is Rajni. They said, how did you come here? This is a photo. This is who you are. This is where you used to live. And now I say, wait, maybe you're right. Maybe my memory can snap back. Sometimes yes, sometimes no. And how did I get here? I have no memory how I got here. My brain dissociated so hard that it's caused dissociative fugue. So there is travel plus amnesia. Next is dissociative identity disorder. I don't remember who I am. I have many personalities inside me. Now I am a doctor. Now I'm a child. Now I'm another person. I had one patient who had 3 personalities in her. That's dissociative identity disorder, what people used to call multiple personality, right? DPDR actually happens often. If you are sleep deprived in your ICU posting, after your ICU posting, I remember once I was like sleep deprived after my ICU posting, and I drove back and I just couldn't remember how I drove back, and I was so dissociated with the reality, and I was looking around and I felt like I was only driving and I could see myself here as well because I had pulled off like a very big shift. So that is depersonalization, derealization. Okay. And we already talked about conversion disorder, where you can have a lot of neurological symptoms like amnesia, anesthesia, paralysis, blindness, mutism. Because of some fight, labella indifference happens. Now, the difference is these are all the factors we've already talked about. What is chronic, what is fluctuating, is the memory preserved or not, right? Yes, it can also be seen in rape patients. Absolutely. I will fill that table for you, but if you have any questions about this, please ask me. Ask any questions. I'll fill the table out for you later. I wanted you to understand this better. No questions. Okay, good to know. Okay, cool. Next, postpartum depression and postpartum blue. Which is more common? Postpartum blues. Less common? Actually, postpartum psychosis is least common. When does it happen? Within the first 3 to 5 days, you can start seeing postpartum blues. Within the first few weeks, I'll again fill out the table for you later, we start finding postpartum depression. Now, postpartum blues, untreated, can become postpartum depression. Okay? Treatment for labella indifference. So when a person comes with dissociation, you essentially, first of all, try to understand the stressor, the trigger. You do not provoke them. You start giving them any medication, for example, SSRI, if they're presenting with more depression symptoms or anxiety symptoms. You give them benzodiazepine. You can also have amytal, sodium amytal interview, which is called the truth serum interview. Over a period of time, it seems to improve on its own. You definitely do intensive therapy, trauma-informed therapy. You essentially get them to understand the stressors, and family support is very important. Yes. Now, blues is most common, depression then, and psychosis least. In postpartum blues, the patient will be teary. The patient can get close to the child, feel attached. The patient may sleep well or not. The patient may be reactive and can start to feel better also. However, in postpartum depression, full depression criteria starts to show, including suicidal ideations can also be seen. Postpartum psychosis, psychotic symptoms are seen. For example, they could think that the baby is rotten. Baby is not mine. Somebody's exchanged my baby, right? Yes. Postpartum blue can resolve with just support, care, time, and CBT. Postpartum depression requires CBT and antidepressants, ECT if very severe. Postpartum psychosis, yes, ECT plus antipsychotics. Who will tell me the newer drugs that has been FDA approved for postpartum depression? FDA approved 2 new drugs for postpartum depression. Please tell me. Oh, कितना type हो रहा है. Go for it. 2 new FDA approved drug for postpartum depression I need from y'all. ये तो मैं नहीं बताऊंगी, मैं चाहती हूँ आप लोग बताओ। Yes, brexanolone, very good. And zuranolone, correct, oral. Very good, guys. I'm very impressed. Brexanolone is IV, zuranolone is oral. Very good. Excellent. Now, we're going to talk about personality. Personality is divided into three clusters. Cluster A, Cluster B, Cluster C. Who will tell me the various Cluster A? Cluster A personality मेरे को बताओ, please. They're called odd and eccentric. Schizoid, schizotypal, and paranoid. स्किज़ॉइड एंड स्किज़ोटिपल में ये फर्क होता है, एक दोस्त बनाना चाहता है और एक दोस्त नहीं बनाना चाहता। एक नॉर्मल टाइप होता है पर थोड़ा सा अजीब लगता है, और एक जो है ना वो अजीब और गरीब चीजें करता है। इंटरेस्टिंगली जो दोस्त बनाना चाहता है वो अजीब और गरीब चीज करता है। क्या अजीब और गरीब चीज करता है? दे मे बी वेयरिंग अ हैट in a place where they can't. They may be dressed up very weirdly and strangely. वो फ्रेंडली होना चाहते हैं स्किज़ोटिपल्स, बट लोग उनसे भागते हैं। और स्किज़ॉइड जो है ना वो सुपर इंट्रोवर्टेड है, उनको फर्क ही नहीं पड़ता। दे डोंट वांट फ्रेंड्स, दे डोंट केयर अबाउट यू। Paranoid are the ones that will think that their partner's cheating. They may often have delusional disorder. They may want to sue people continuously. Okay. B, correct. किसी ने सही बोला है. Borderline personality, where there is splitting as a defense mechanism. Yes, there is histrionic, which is dramatic. Narcissistic, I think by now सबको पता है meaning इसका. And antisocial personality disorder. To be diagnosed with antisocial personality disorder, it is mandatory that less than 8 years you have a conduct disorder diagnosis. And in cluster C's, we have anxious, dependent, and obsessive compulsive personality disorder. Obsessive compulsive personality disorder. Correct. Mad, bad, sad. Okay. All right. I think मैंने सारे features यहीं पे लिख दिए. The other thing that you can essentially know is that in cluster A, paranoid do not respond very well, not respond well to group therapy. You may have to medicate them. Okay. Borderline personality disorder, DBT is the treatment of choice, but also splitting is often seen as the defense mechanism. Okay. OCPD versus OCD. This is the personality format. Absolutely, somebody wrote very nicely. It is ego syntonic. मुझको अच्छा लगता है, मैं ऐसा हूं. Whereas OCD thoughts are ego dystonic. मुझे ये thoughts अच्छे नहीं लगते, डॉक्टर साहब बंद करवा दीजिए. Absolutely correct. And I already told you about ASPD. Diagnosis of conduct disorder less than 18 years is mandatory. Okay. With that, we have finished a lot or most of the marathon. Yes, there is parasuicide or there is paradoxical parasuicide में फर्क होता है. I'll tell you. Parasuicide मतलब next to suicide, मतलब almost suicide, मतलब हाथ कट करना, धमकी देना, बोलना कि अपने आप को जला लेना, that is parasuicide, next to suicide. Okay, wait a second guys, that is parasuicide. Whereas yes, my notes are saved, thank God. That is parasuicide. Let me write it down here. Parasuicide, wait. I will write it down for you guys. It's a good question. So, parasuicide means next to suicide, like cutting, burning, shallow cuts, seen in borderline personality disorder. Paradoxical suicide is a black box warning that we see on SSRIs less than 25 years of age, where a person can gain energy to kill themselves on starting antidepressant. Initially, they didn't have the energy to kill themselves, but now they do. Skincare, pani piya karo. Don't smoke, don't drink, exercise regularly, sleep well. Skincare is also genetic. I have good genes. I hope आपको skincare भी अच्छा लगा. Non-suicidal self-injury is same as parasuicide. Non-suicidal self-injury is same as parasuicide. Yes, seen in BPT. Okay. Please ask questions. Always happy to answer any questions. Guys, we covered almost all of it because psychopharmacology is supremely important. What I decided was make everything around psychopharmacology, where we continued to consider cases. कुछ हमने PYQs भी cover कर लिए, कुछ हमने important चीज़ें भी cover कर ली. जो टेबल मैंने छोड़ा है मैं भर के आपको दूंगी ऑफ कोर्स नोट्स. आपको टेलीग्राम चैनल का नाम चाहिए था गाइस. लेट मी जस्ट गिव यू. गाइस मुझे लगता है कि आई विल हैव टू गिव यू द टेलीग्राम चैनल इन द कमेंट्स हियर ओनली. वेट, trying to find out. I will give you the ma'am, is it okay to feel fatigue post active recall? Yes, obviously. It's perfectly fine to feel fatigue, guys. I mean, you all are champions. You all are doing 19 subjects. I did it long back. I'm only teaching you one subject. It is fatiguing. ये जो ब्रेन होता है इस तरह ग्लूकोज खाता है जब हम पढ़ाते हैं. I did have a break and I did drink like a banana shake in between. It's fine to feel fatigued. None of us are superhumans. My mobile also needs charging. So do you. तभी हम थोड़ा सा ब्रेक रखते हैं दो सब्जेक्ट के बीच में. बट आई अंडरस्टैंड इट मे बी डिफिकल्ट, बट द होल आइडिया इज medicine, as you know, we are doctors, we grind really hard, but you know, we need to finish so much syllabus. We have 4-5 days of action packed 19 subjects. The exam is just around the corner. It is okay to feel fatigued. It is important to hydrate. It is important to sleep well, but definitely it's okay. 4A का डेफिनेशन, ऑटिज्म मतलब दुनिया से कनेक्टेड. अफेक्ट फ्लैट मतलब अरे आप तो बहुत अच्छे दिख रहे हैं, अरे आपके यहाँ पे कुछ बुरा हो गया, कोई रिएक्शन नहीं होना, राइट. लूजनिंग ऑफ एसोसिएशन, दो सेंटेंस के बीच में कोई ताल्लुक नहीं रह जाना, राइट. एंड ए सोशल मतलब मैं आपसे बात ही नहीं कर रही हूँ. दोज आर द 4A's. Alright, if we are done, thank you guys for your great participation. I think the cohort was really good. Everybody knew a lot of it. जो थोड़े से नहीं पता थे. हाँ, मैंने एक आंसर नहीं बताया था, आपको बता देती हूँ. I had hidden one answer from you. Wait a second. I just remembered. हाँ. Memantine is also used in add-on, as an add-on for OCD. Okay. Yes, somebody remembered the question. I'm glad. Momentum is also used as an add-on for OCD. Okay. Thank you guys. Have a nice evening. On for surgery in the night. Okay. Bye bye.
Hi guys. Hi guys, good evening, good evening. Can you all see me? Can you all hear me? Can we start? Can we start? All right, so let's start our INI-CET Marathon series. That is for the upcoming INI exam. Now, what I've done is I have now created the list of important surgery topics that you need to go through for your INI-CET exam. We'll break down into important image-based questions, important classifications, important malignancies, important topics, and the tricky topics. And my job is to give you the entire spectrum, right? Now, usually the image-based questions that the INI people concentrate on: drains, cannulas, Foley's catheters, swellings, and instruments. We'll be covering all of them today also. Please do take an important look at the same. Right. Second is important classification. SEEP classification for varicose vein is their inherent love. Forest classification for upper GI bleed. Bile duct injury, your Strasbourg, Bismuth, Hanover classification. Bosniak is for renal cyst. Nice for your hernia. And Fontaine's is for limb ischemia. Right. Again, very, very important. Now, in terms of important cancers, I get a lot of questions on which cancers we need to concentrate before going to the exam. Breast cancer, the entire TNM classification, management, and the stage-wise protocol. Thyroid cancers, you should know the clinical presentation and the management. Oral cancers, TNM classification. Colorectal cancers, TNM classification, presentation, and management. HCC, Barcelona criteria, that is BCLC criteria is important. For gallbladder cancers, remember the TNM. It's very, very important. Newfound love for your INI people. RCC, Robson's classification, Tesla tumors, the entire classification, that is important. Then the list of the important topics, right? Now, usually these are the topics that keep on repeating in your INI exam. If you just take your question paper for last 5 sessions, you will see these questions are the one which are usually asked. From the breast, it is Andy. From the thyroid, is toxic thyroid swellings. Trauma, very important. Primary assessment, thoracic trauma, spleen and liver injuries, damage control surgery. From the GIT part, congenital diaphragmatic hernia, motility disorders of esophagus, esophageal perforation, peptic ulcer disease, inflammatory bowel disease, hereditary cancer syndrome, fistula and NO, aneurysm, thoracic outlet syndrome, varicose vein, total parental nutrition, cholecystitis and safe cholecystectomy, chronic pancreatitis, nephrolithiasis, bladder and urethral injury, hydrocele and inguinal hernia are what are the important topics that they usually ask. Somehow the INI people, when they want to ask you more detailed questions, they usually jump down to these tricky topics, right? So the tricky topics list are burns. They ask you from the burn management to the wound management, everything is important. Surgical site infection, very, very important. Cleft lip and palate repair criteria, parathyroid adenomas, pheochromocytoma, neuroendocrine tumors, mesenteric cyst and neurotrauma, right? These are the important topics that, or the tricky topics that they go in depth whenever they ask you the questions, right? But it's a revision of all the important topics. Yes, it will be helpful for upcoming NEET exam as well as FMGE exam also. The objective is to cover most of these topics so that we have a uniform idea, है ना? ठीक है? चलो. So without wasting any further time, let's kickstart our marathon series, right? So this is going to be our marathon series. I am Dr. Sandeep, your surgery faculty for today. I mean, in MedEd for ever. So we'll be talking about all the important components of whatever we have discussed. We'll start with the drains first, image-based questions. We'll simply label them. That is more than enough. The first drain that you can see, it is what we call it as the corrugated drain. This is what we call it as the corrugated drain. See, whenever they ask you about drains, they'll ask you whether it is an open, closed, active, passive. You can see there is nothing collecting, it's an open drain system, right? So corrugated drain is an example of an open drain. It is an example of an open drain. It is a passive drain. It is a passive drain, right? It's an open drain system and a passive drain system, right? Now, open drain can never be active. It is only going to be passive. The second image that you can see, it is what we call it as the Penrose drain. Now, Penrose drain is also same like a corrugated drain. Corrugated drain is open leaflet. This is like a tube, but again, they work on the same principle, right? What is a Penrose drain? Again, Penrose drain is also going to be same. It is an open drain. It is also an example of a passive drain. Now, this is also a corrugated drain. This is also corrugated drain. Now, because it is transparent, it is made up of silicon material. It is your silicon corrugated drain. What you have to know in this silicon corrugated drain, this green line that is present, this is your radio opaque line. This is your radio opaque line. Then you have, this is what we call it as the Romovac drain. This is what we call it as the Romovac drain. Now, the Romovac drain is an example of, as you can see, the tube is there and this is the collecting system. So, it's a closed system drain, right? So, this is an example of a closed drain. This is an example of a closed drain and this is an active drain. This is an example of a closed drain and this is an example of an active drain system. This is an example of an active drain system. This is an example of an active drain system. Then you have, this is your Foley's catheter. This is your Foley's catheter. Now, when it comes down to Foley's catheter, remember the color coding and the size is important. The mnemonic to remember the color code is gory, very beautiful. Okay. I'm not saying this that all gories are beautiful, but then just the mnemonic sake, you can discuss this. G stands for green in color. So, green colored Foley's catheter is 14 French. O stands for orange. Orange is going to be 16 French. R stands for red color. Red is going to be 18 French. Y stands for yellow. Yellow is going to be 20 French. V stands for violet. Violet is your 22 French. And B stands for blue. And blue is your 24 French. Blue is your 24 French, right? So, these are the color coding of your Foley's catheter. Now, they will ask you what does French stands for. Remember, it is the outer diameter of the tube. This is the outer diameter of tube. This is the outer diameter of the tube. This is the outer diameter of the tube. This is your French, right? These are the standard ones. Do remember this. Okay? Chalo. Now, this is your T-tube. T-tube, as you can see, it is looking like English alphabet T. It is called as T-tube. T-tube catheter is used for bile duct drainage. Now, it can be post bile duct injury or exploration, whatever. Usually, the question asks is T-tube is removed after. Remember, T-tube removal. The T-tube removal is after 10 to 14 days. The T-tube's removal is usually after 10 to 14 days. The T-tube's removal is after 10 to 14 days, right? Next is this. You can see Foley's catheter, but this time there are three components, 1, 2, and 3. So, this is what we call it as the three-way Foley's catheter. It is your three-ways Foley's catheter. So, in a three-ways Foley's catheter, the colored one that is present, this is for balloon inflating channel. This is for balloon inflating channel. The second one, which is the largest one, this is going to be for urine collection. This is for urine collection. And the third one that you can see here, this is basically for irrigation. So 3-way Foley's catheter is used for bladder irrigation. So this is the purpose that you need to remember. The next image that you can see, this is what we call it as the pigtail catheter. Beta, if you're talking about bougie, the bougie will be long and bougie does not have fenestrations, right? So this is a pigtail catheter. If the same catheter is presented and if it is going to be turning both ways like this, if there's a coiling on both ways, this is what we call it as double J stent. This is what we call it as a double J stent, or also commonly referred to as the DJ stent. It is commonly referred to as the DJ stent. This is commonly referred to as the DJ stent, right? A double J stent, or also called as a DJ stent, right? The next one that you have, okay. Right. The next one that you have is this one. This is what we call it as the nasogastric tube. This is what we call it as the nasogastric tube, or also commonly referred to as the Ryle's tube. Also commonly referred to as the Ryle's tube. The usual question that they ask you in Ryle's tube, what is the length of the nasogastric tube? Remember, the length is approximately 100 centimeters. Now, nasogastric tube is used for gastric decompression, and along with that also for feeding purposes. What is the adequate length of the nasogastric tube to be pushed in? We use a rule, as somebody is giving me a right answer. It is what we call it as Neck's rule, right? So what is the Neck's rule? You take a nasogastric tube, you measure from the tip of the nose to the tip of the earlobe, from the tip of the earlobe to the xiphisternum. This is what we use it for, and this is what the Neck's rule basically is. So take the nasogastric tube from the nose to the earlobe, from the earlobe to xiphisternum, whatever is the length, and that's the length that you have to insert it, and that is what we call it as Neck's rule. That is what we call it as the Neck's rule. All right. Somebody is saying that it can be used for gastric lavage. Yes, but the most common uses are these two, that is your gastric decompression as well as feeding. So you can also add the gastric lavage also. For a gastric lavage, you can use nasogastric tube. Now, this is something that they'll ask you to identify again and again. This is what we call it as the Syngaskian-Blakemore tube. It is the Syngaskian. This is the Syngaskian-Blakemore tube. Now, the Syngaskian-Blakemore tube is also commonly referred to as an SBT tube. Now, what is the Syngaskian-Blakemore tube? This is used to control upper GI bleed secondary to your esophageal varices. Secondary to the esophageal varices, right? Now, in a Syngaskian-Blakemore tube, you see there are two balloons. Number one is what we call it as the gastric balloon. This is what we call it as the gastric balloon, and this is your esophageal balloon. This happens to be your esophageal balloon. Now, esophageal balloon will be inflated with 40 millimeters of mercury. Again, we will use air. And the gastric balloon is inflated with 300 ml. Again, here also it is inflated with air, right? So both esophageal balloon and the gastric balloons are inflated with the components that we have already discussed it. 40 millimeters of mercury will be the pressure, and the gastric balloon is 300 ml of air. The one thing that you remember is balloon must be deflated. Both the balloons must be deflated. They must be deflated every 12th hourly. They must be deflated every 12th hourly. देखो मिनेसोटा ट्यूब जो है, अगेन आई डोंट वांट टू गो इनटू ग्रेटर डिटेल्स, बेटा मिनेसोटा ट्यूब में ना there are, यहाँ पे you can see there are 1, 2 and 3 channels. If there are 3 channels, it is going to be Syngaskian-Blakemore tube. In the Minnesota tube, there are 4 channels. So Syngaskian-Blakemore tubes will have 3 channels. So what are these channels? Again, I don't want to go into greater, deeper discussion. One is for your gastric balloon, another one is for esophageal balloon, and one is to aspirate from the stomach. There is no esophageal aspiration, but if you have a 4-channeled, if you have 4 channels, then this is going to be your Minnesota tube. This is your Minnesota tube. This is your Minnesota tube. Okay. Maurya, you are correct. Again, there's another one, Linton one. Okay. Chalo. Somebody's giving me the next answer also. Absolutely correct. This was your previous INI question. They've asked you twice. They've asked you this exact one. I hope you're able to trace it down. This is like the balloon that is present. And there's a tubing that is present on the other end. So this tube which is present, it now becomes a fenestrated end when it goes. There's the entire tube, and at the end you can see a flattened fenestration is there. And this is what we call it as the Jackson-Pratt drain. This is what we call it as the Jackson-Pratt drain. This is what we call it as the Jackson-Pratt drain. Jackson-Pratt drain is a closed active drain. This is a closed active drain. Now this can be used for abdominal surgeries also. Okay? Correct, beta. Okay? So this is a Jackson-Pratt drain. So all these are your important drains, their basic components and their basic use. Clear? Okay? Correct. Chalo. Now you have the cannulas, the color code and their flow rate. You have the first one is your orange colored cannula. Orange is going to be 14 gauge with a flow rate of 240 ml per minute. Then you have gray colored cannula. Gray is going to be 16 gauge at 180 ml per minute. At 180 ml per minute. Then you have the green colored cannula, which is the 18 gauge at a flow rate of 90 ml per minute. At a flow rate of 90 ml per minute. Then you have pink colored cannula. The pink colored cannula is going to be at 20 gauge at a flow rate of 60 to 65 ml per minute. Then you have blue colored cannula. The blue is going to be a 22 gauge with a flow rate of 30 to 35 ml per minute. Then you have yellow colored cannula. It is your 24 gauge at a flow rate of 20 ml per minute. At a flow rate of 20 ml per minute. The last one is your violet colored cannula, which is also purple, which is a 26 gauge at a flow rate of 12 ml per minute. At a flow rate of 12 ml per minute. Yes, you have to remember all of them. It is important. Now, those who have difficulty in remembering them, I have a small mnemonic for you. The core of the earth is made up of lava. The core of the earth is made up of lava. So, lava is going to be orange in color, right? Above the lava, you have the soil. The soil is gray in color. So, this is the soil. On top of soil, you have the green trees. So, these are your beautiful green trees that are present. On top of these green trees, you have the pink flowers. So, this is your pink flower. On top of the pink flower, you have the blue sky. So, this is the beautiful blue sky that you have. Now, in the blue sky, you have the yellow sun. So, there's a blue sky that is present. Then you have the yellow sun. There's the yellow sun. And then you have the universe beyond it, that is going to be purple. This is going to be purple. That is going to be purple, right? So, this is your entire color coding system. Now, those who are not able to comprehend, for them. Orange color is 14 gauge, gray is 16 gauge, green is 18 gauge, pink is 20 gauge, your blue sky is 22 gauge, sun is 24/7, so 24 gauge, and violet is your 26 gauge, right? So this is the entire color coding and a flow rate. Clear? Correct. So this is in terms of the cannulas color code and their flow rate. Then comes your laparoscopic instruments. The hollow part is what we call a sport, and the inner one, which is going to be solid cylinder, which is called a trocar. Trocars are, see, this is like a port, this is a trocar. Trocar is solid, the port is hollow, together they form as one system. You insert it inside the abdomen and then you are going to pull this out, right? So this is how you do a port placement. The problem is, sometimes you can have the trocar which is sharp and it can prick. Do we have that? Okay, yeah. So it can prick and hence cause injuries. To avoid this, you have the other ones, right? What is this for the completion sake? This is what we call it as the lens. The lens gets attached to the camera head, and the lens that we use is at 30 degrees. It's a 30-degree lens that we have. Now, this is what we call it as the Hansen's atraumatic. It is a Hansen's atraumatic port. Now, in a Hansen's atraumatic port, this is, you will have a blunt trocar. This is a blunt trocar. It's an atraumatic, so injury will not occur. This is what we call it as your Veress needle. Now, very, very important. Now, this is your usual exam question, right? So, question number 1, how do you hold the Veress needle? It is held in a dart holding position. A dart holding position. That means like you're going to throw a dart, this is how you're going to hold it. This is what you call as dart holding position. Now, when you're inserting it, you're going to insert through the periumbilical region and you're going to insert it inside the peritoneal space. In which direction will you point it? Towards the pelvis or towards the xiphisternum? Remember, while inserting, it is pointed towards pelvis. It is pointed towards pelvis. It is pointed towards pelvis. Now, the angle between needle and skin, the angle between the needle and the skin, it is going to be 90 degrees. But if I change the question and ask you the angle between needle and body, the angle between the needle and the body is going to be 45 degrees, right? Veress needle is used to create pneumoperitoneum. It is used to create pneumoperitoneum. If I ask you a question, which is the most common gas? The most common gas used to create pneumoperitoneum, it is carbon dioxide. It is a carbon dioxide. How much should be the intra-abdominal pressure? The intra-abdominal pressure should be maintained between 11 or 12 to 15 millimeters of mercury. It is maintained between 12 to 15 millimeters of mercury. Yes, the lens is 30 degrees, correct, right? So dart holding position pointed towards pelvis. The angle between needle and skin is 90. Angle between needle and the body is 45. Used to create pneumoperitoneum. The most common gas is carbon dioxide. Intra-abdominal pressure is maintained at 12 to 15 millimeters of mercury. And when you are flushing the carbon dioxide gas, remember the initial flow rate. The initial flow rate is going to be 1 to 4 liters per minute. A maximum flow rate that you can give is 20 liters per minute. The maximum flow rate is going to be 20 liters per minute. This for Veress needle. Clear? The last one that you have is what we call it as SILS. SILS stands for single incision laparoscopic port surgery. It is called as the single incision. It's a single incision laparoscopic port surgery. It's a single incision laparoscopic port surgery, right? Another question that they've asked you. Another question Another question that they've asked you recently, I'm just, give me a second. Another question that they've asked you recently from the exam perspective is about the ergonomics of the laparoscopy. Now imagine this is our patient. This is the patient lying down. This is the foot end of the patient. And this is the abdomen of the patient, right? Let's say this is the umbilicus. Now you will insert the camera. So when the camera goes in, this is what we call it as the optical axis. Optical axis is basically a camera port. Then you have the working port. This is the working port number 1. So I'll call it as W1. And another one is working port number 2. This is what we call it as the W2, right? So whenever you're operating laparoscopically, one is for camera, that is called the optical axis, and there are 2 instruments for both the hands that you're going to use it. Now the question that they ask you is, what is the angle? What is the angle between any of these instruments and the body? So what is the angle between any of these instruments? So what is the angle between any of these? Like what is this angle? What is this angle? What is this angle? So angle between any of these instruments and the body is what we call it as the elevating angle. This is what we call it as the elevating angle, which is at 60 degrees. Then the question that they asked is, what is the angle between the optical axis and the working port? What is this angle called as? The angle between the working ports and the optical axis. The angle between the working port and the optical axis, this is what we call it as the azimuth angle. This is what we call it as the azimuth angle. The azimuth angle is going to be at 30 degrees, right? 30 here, 30 here, so together it is 60 only, right? Now, between the camera and working port, it is 30 degrees. Now, what is the angle between the 2 working ports? What is the angle between the 2 working ports? The orange one. What is this angle? This is what we call it as the manipulating. This is what we call it as the manipulating angle. Remember, the manipulating angle is going to be at 60 degrees. The manipulating angle is going to be at 60 degrees, right? The manipulating angle is at 60 degrees, and this is our important exam question. These are important exam question. Clear? Okay. So this is with respect to your minimal axis, that is MIS important points. Clear? So let's move on to the energy devices. We have 4 energy devices. All 4 of them you have to identify: monopolar, single pole, bipolar, 2 poles, harmonic, no button, thunderbeat, or we say combined energy devices. How to differentiate harmonic and thunderbeat? Harmonic no buttons, thunderbeat will have 2 different buttons. That's the easy way to remember it. Now, how do they work? Monopolar, bipolar works on electrical energy, harmonic works on the vibrating frequency, whereas your thunderbeat is going to be combined electric and vibrating energy. It's a combined energy source, right? Now, the ability to cut and coagulate is there in the monopolar, it cannot seal. The bipolar can only coagulate, it cannot cut. So I can just small, this thing is there, we'll just change this so that we don't have a problem. So their ability, so here it is also used on electrical energy. Bipolar works on electrical energy. We will see its ability to cut, its ability to coagulate, its ability to coagulate, and its ability to seal. Its ability to seal, right? Now remember, it cannot cut, but it can coagulate and it cannot seal. So bipolar is only for coagulating effects. Harmonic is considered to be as the safest energy device. It is safest energy device for the patients with pacemaker because it works only on the vibrating energy, and the vibrating frequency is going to be 20 to 50,000 hertz. It vibrates at a frequency of 20 to 50,000 hertz. It has the ability to cut, coagulate as well as seal, right? So it can cut, it can coagulate, it can seal. Remember, it can only seal approximately until 7 millimeter of diameter of the vessel. If the vessel's diameter is around 7 millimeters, more than that it cannot, less than the 7 millimeters, right? So less than or equal to 7 millimeters. So give it this way. It can seal a vessel of less than or equal to 7 millimeters. Beyond that, it cannot, right? So this is with respect to your harmonic. Thunderbeat is an example of a combined energy device. It works on both electrical and vibrating energy. It has the ability to cut. It has the ability to coagulate, and it can also seal a blood vessel. Again, less than or equal to 7 millimeters. More than that, it is also ineffective. It is a combined energy device. So whenever they ask you energy devices, see, their famous question is this: which is the safest energy device in a patient with pacemaker? Obviously, when there's a pacemaker, if you use an electrical energy device, that electrical energy device is going to interfere with that of, I would say, the pacemaker setting, and henceforth causing problems. So the ideal way to go about it is use harmonic scalpel. ठीक है? So this is about your energy devices. Right now, how do you differentiate? Now, this is your favorite question in your INI-CET. How do you differentiate between the cut and the coagulating current? Now, in a cut current, you see I've plotted a graph between the voltage and the frequency. You will notice in a cut current, there will be low voltage but very high frequency. There will be very high frequency. But when it comes to coagulating current, you see there is high voltage but there is low frequency, right? So in a cut current, you see the current is running like this. The current is running like this. So voltage is not very high, but the frequency is very high. On the other hand, coagulating current, you see there is a very high voltage, but the frequency is very low, right? So if you have low voltage, with high frequency, it is going to be cut current. For coagulating current, they have high voltage but low frequency. Clear? This is your exam question. So far, so good. ठीक है? चलो. Next comes is your suturing rule. Now, what should be the length of the suture material that we are going to use? Remember, the length of the suture material should be 4 times the length of the wound. It should be 4 times the length of wound. It should be 4 times the length of the. It should be 4 times the length of the wound. That means if the length of the wound is 10 centimeters, the minimum length of the suture material required to close that particular wound is going to be 40 centimeters. Why do you need to know the depth of the wound? It determines the entry and the exit of the wound, right? So this is X is considered to be the depth of the wound. Now this determines entry and exit of needle. This determines the entry and the exit of needle from the edge of the wound. Right? So what is this was your previous INI question. The angle between the needle and the skin at the entry point. This is going to be your 90 degrees. This is your previous exam question. Distance between the two suture materials should be twice the depth of the wound. It is equal to the twice the depth of wound. It is twice the depth of wound. How much should be the length of the suture ear? It is the, after putting the knot, no, whatever the suture thread is left behind, that is called a suture ear. It is approximately 1 to 2 millimeters. The length of the suture ear is around 1 to 2 millimeters. Okay? So these are your previous exam questions according to your suturing rule. What are your suturing techniques? Let's quickly run through them also. The first one is what we call it as a simple continuous running suture. It is your simple continuous running suture. This is your simple interrupted suture. This is your simple interrupted suture. This is your vertical mattress sutures. It is a vertical mattress sutures. This is your horizontal mattress. This is your horizontal mattress sutures. This is your horizontal mattress sutures, and last one is your subcuticular suture. This is a subcuticular suture. The most difficult one to differentiate is vertical mattress versus horizontal mattress. How do you know it? Now, see, this is the line of the wound and this is how the suture is oriented. If the line of the wound and the suture's orientation are perpendicular to each other, this is a vertical mattress. If the line of the wound and the line of the suture, they are running parallel to each other. They are running, see, this is how the suture line looks like and this is how the wound line looks like. If they run parallel to each other, they are horizontal mattress sutures. They are horizontal mattress sutures, right? They are horizontal mattress sutures. Clear? Subcuticular, this is going to have the best cosmetic outcome. This is going to have the best cosmetic outcome. This is going to have the best cosmetic outcome. Then you have the knotting techniques. Now, the first knotting technique that you can see, this is what we call it as half hitch. Half hitch is a single loop. This is what we call it as the granny's knot. This is your reef knot, or also called as the square knot. And the last one that you have is your surgeon's knot, also referred to as the surgeon's knot. Now, remember, if you talk about the stability of all knots, right? Which of the following knots are considered to be stable? Remember, half hitch granny is not stable. This is stable. And in fact, the most stable knot is going to be your surgeon's knot. The most stable knot is going to be your surgeon's knot. Usually in the exam, they will always ask you the difference between granny's knot and the reef or a square knot. Now, because both of them look very confusing, it is very easy. Look at this red thread. It is going under the green loop. Look at this red thread. It is going over the green loop. One thread is under, one thread is over. Come back this side. You can see this is the red loop. Green thread is going over. Here, green thread is going under. So, if one thread is going under and one thread is going over, it is your granny's knot. You come back to the reef or the square knot. You see, this is the green loop. Both the red threads are going under the green loop. Here, let's say this is a red loop. Both the green threads are going over the red loop. So, either both the threads are going under or over. They're going under or over. If both of them are going under or if both of them are over, this is what we call it as the reef or the square knot. This is what we call it as the reef or the square knot. For surgeon's knot, you have two loops on bottom, one loop on top. Again, the same squaring will occur, and this is going to be the most stable knot. This is going to be the most stable knot. Clear? Clear, guys? So far, any questions? Quick feedback. So far, any questions? Quick feedback. कोई सवाल, कोई शक? Any questions? Quick feedback. ठीक है, can we move on? चलो. So the next one that you have is your suture removal period. Now, if you put the sutures on the face, the suture removal period is between 3 to 5 days. 3 to 5 days. If you put it to arms, that is scalp and the arms. For scalp and arms. For scalp and arms, it is your 7 to 10 days. It is your 7 to 10 days. It is your 7 to 10 days. Between your trunks, legs, hands and feet. Your trunk, legs, hand and feet. This is going to be 10 to 14 days. These are 10 to 14 days. The last one is going to be the palms and sole. It is going to be the palms and sole. For the palms and sole, it is 14 to 21 days. It is your 14 to 21 days. Okay? So these are suture removal period. Again, your favorite INI question. Okay? Clear? Sure. Next comes is your pressure sore, bed sore, or also called as decubitus ulcers, right? So what is the criteria? The criteria is very simple. If the pressure exerted is more than the capillary occlusive pressure, if it is more than the capillary occlusive pressure, if it is more than the capillary occlusive pressure, then we say the patient will develop pressure ulcer. How much is the capillary occlusive pressure? We all know the capillary occlusive pressure is 30 millimeters of mercury. So if a pressure exerted over a certain area for a sustained period of time, and that period of time exceeds more than 30 millimeters of mercury, then the patient will develop a bed sore. What is the risk factor? It is your prolonged immobilization. It is prolonged immobilization as well as any bedridden status. A bedridden status or a wheelchair bound status. Right? If any of them is present, it is a risk for development of pressure ulcer. When we talk about what is the most common site, the most common site for the pressure ulcer, it is going to be ischium. It is going to be ischium, followed by greater trochanter, followed by sacrum. So ischium, greater trochanter, and sacrum. Clear? चलो, स्मूथ स्पेशलिस्ट क्या हो गया? कोई प्रॉब्लम? व्हाई आर यू क्राइंग? बेटा मोस्ट कॉमन इश्कियम है, देन ग्रेटर ट्रोकैंटर, देन सेक्रम है. The other sides, occiput is another side that you have. Then you have the heel is another side. Lateral malleus is more common compared to medial malleus. All these are the other sides. ठीक है? चलो. Now, when you look at the grades of the pressure ulcer, the grade 1, there's a non-blanching erythema. Grade 2, partial thickness skin loss. Grade 3, subcutaneous fat is exposed, a full thickness skin loss. Grade 4, there's an underlying structure is involved. It could be a muscle, a vessel, a tendon, a nerve. Any of the following can be involved, right? Now, how do you manage? For grade 1, grade 2, for grade 1 and grade 2, the management is going to be conservative management. The management is going to be your conservative management. The management is going to be the conservative management. Now, in the conservative management, what do you have? Number one, you put a water on an airbed, do a frequent change in position. And if a patient is on a wheelchair, then every 10 minutes, the patient has to be changed, right? So there has to be change in position. So if you say frequent change of patient, if the patient is bedridden, it is every second hourly. It is every second hourly. So the frequency of change in position, if the patient is bedridden, it is going to be every second hourly. It is every second hourly. But if a patient is wheelchair bound, then it is going to be every 10 minutes, right? Skin care to keep it adequately freshened. If it is grade 3 or grade 4, for both grade 3 and grade 4, the first thing that you have to do is cleaning and debridement. The first thing that you have to do is going to be cleaning and debridement, and then apply your negative pressure wound closure system. The old name was VAC, that is vacuum assisted closure. Nowadays, we don't call it as VAC. Now we call it as negative pressure wound closure system. Your previous exam question is how much is the pressure that you're going to apply? It is going to be minus 125 millimeters of mercury. It is going to be of an intermittent pressure. How does it help? It promotes the granulation tissue formation. It clears the secretion. And the greatest advantage of VAC is you don't need to change the dressing daily. You need to change it after 5 days. So once in 5 days is what you are going to change the dressing for, right? Another new addition according to the National Pressure Wound Advisory System is what we call it as something called as US. So US stands for unstageable. Unstageable is where when the ulcer is covered with slough or necrosis. If the ulcer is covered with slough or necrosis, we call it as unstageable. We call it as unstageable. Now for all unstageable, we follow the grade 3, grade 4 protocol. Okay? But if the subcutaneous fat is visualized and nothing else, it is grade 3. If you see underlying muscle or a bone, right, or a vessel is shown, then it is grade 4. As simple as that. Okay? Now, negative pressure wound closure system, WAC is your previous exam question. They have asked you what is the pressure, how much, or like how do you apply it, is it continuous or intermittent, how does it help? All these have been your previous exam question, right? So do remember your negative pressure wound closure system is very, 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 very important. ठीक है? चलो. Now, next going into burns. Now, in the burns, they'll ask you what is the most common rule that we follow. We call it as Wallace rule. Wallace rule is also called as the rule of 9. It is also called as rule of 9. So what I'll do is, rather than trying to remember it together, I will see the difference between the child and the adult, right? So what we'll do is, we'll write on one hand, that is the head and neck in an adult versus child, right? So where we say head and neck, how much it comprises of. Then anterior trunk, posterior trunk, upper limb, perineum, and the lower limb. So this is what we have to remember, right? So the difference between the adult and the child is going to be for these parameters. Okay? Chalo. So we'll see the difference between adult and a child. So on one side you have the adult, on other side we have a child. In adult, the head and neck is going to be 9%, child it is double, that is 18%. Your anterior trunk is 18% here, child is also 18%, the posterior trunk is also 18%. The upper limb is going to be 9% each, there is 1% for perineum, no perineum here. Whereas the lower limb is going to be 18% in adult and 14% in children. Then going to be 14% in children. That is the difference that you should remember in terms of Wallace rule. That's it. Again, if they ask you what does the trunk basically means, now the definition of a trunk is chest plus abdomen. It is chest plus abdomen. The definition is going to be with chest plus abdomen. ठीक है? Chalo. Now, another very important your INI based question is based upon the clinical scenario. How do you know the depth of the burn? How do you know the depth of the burn? And that is on the basis of this classification. Now, when I say a first degree burn, only the epidermis of the skin is involved. Only the epidermis of the skin. Secondary superficial is papillary dermis. Secondary deep is going to be your reticular dermis. It is your reticular dermis. Third degree is the full thickness of the skin. It is the full thickness of skin. And the fourth degree burn is going to be underlying structure. Involvement of an underlying structure. Involvement of an underlying structure is a fourth degree burn. How do you differentiate? Pain is an integral property of a skin. Now, obviously, first degree burn will be immensely painful. Second degree superficial will also be painful. Second degree deep onwards, there will be no pain. But one thing that you'll see in secondary deep is presence of pin prick sensation. There is a pin prick sensation, right? So what do you mean by pin prick sensation? Is if you touch, there is no pain. If you touch, there is no pain. But if you take a pin and prick it, the patient will feel the stinge. That is called pin prick sensation. Blisters are also a property of skin. In first degree, the blisters may or may not be present. Secondary superficial, characteristic of blister. Secondary deep, may or may not have blisters. Third degree, fourth degree, there is no skin, there will be no blisters at all. When it comes down to color, for a first degree burn, there will be presence of erythema alone. Secondary superficial, it is going to be bright red. Here it is going to be, secondary deep is mottled pink or pale waxy white. Mottled pink or waxy white. Here it is leathery in appearance. Here it is leathery in appearance, and this is your charred appearance. Charred is like a charcoal. Now, the first degree, second degree superficial, second degree deep will heal, third and fourth will not heal. The first degree and the second degree superficial will not have a scar. Rest all of them will leave a scar behind. Eschar is again a fibrotic element that is developed, usually seen from secondary deep onwards. So based upon these properties, you can now predict the depth of the burns that you're going to see. When it comes down to resuscitation, we all know crystalloids, the fluid of choice for burn resuscitation. The fluid of choice for the burn resuscitation is going to be ringer lactate. It is going to be ringer lactate, right? Now, according to the ATLS formula, how do you calculate it for adult and the children above 14 years? We'll calculate as 2 ml per kg per percentage of total body surface area burnt. For children, we say age less than 14 years. This is going to be 3 ml per kg per percentage of body surface area burnt. Now, if there is, this is that we follow for your second degree and a third degree burn. For electrical burns and the fourth degree burn. The electrical burn and the fourth degree burn for all ages. For all ages, we considered at 4 ml per kg per percentage of total body surface area burnt. Right? Now, these are the important ones to remember. Adult is 2 ml, child is 3 ml for second degree, third degree. For 4 degree, adult, child, all of them is going to be 4 ml per kg per percentage of body surface area burnt. Now, if they ask you what is the most common colloid used in burn resuscitation, it is your human albumin solution. This is your human albumin solution. Ideal time to administer colloids is after 24 hours of burn, once you've finished the crystalloid resuscitation. How do you calculate? The most commonly used is Muir and Barclay formula. It is 0.5 into weight in kilograms into percentage of total body surface area burnt. Protocol for administration, we start after the 24-hour period. So we divide them into 12 hourly differentiation. So for the first 12 hours that we are going to administer, the colloid will administer every 4th hourly. So you can administer 3 times. In the second 12 hours, I can administer every 6th hourly. From there onwards, I'll be administering every 12th hourly. So this is the frequency or the protocol for administration of colloids. Your Muir and Barclay formula was your previous exam question. Muir and Barclay is a previous exam question. They have asked you that how do you calculate the required amount of colloids. The required amount of colloids is calculated by your Muir and Barclay formula. It is calculated by Muir and Barclay formula, right? Now, how do you manage the burns with the topical agents? The topical agents will see their effectiveness against Pseudomonas, gram-negative, penetration ability in eschar. Okay, then you have side effects. Now, your silver sulfadiazine, it is extremely effective against Pseudomonas and gram-negative. But the problem is it cannot penetrate the eschar. There is no particular side effect. So this is considered to be as the most common topical agent. This is the most common topical agent. Silver nitrate has good effects against Pseudomonas, decent effect against gram-negative, cannot penetrate eschar, and it results in blackening of skin. It results in blackening of skin. Now, because it results in blackening of skin, it is not usually preferred. Then you have mefenide acetate. The mefenide acetate has little action against gram-negative and pseudomonas, but it can penetrate eschar, but it causes two problems. Number one, it causes metabolic acidosis, and number two, it aggravates pain. So hence it is not preferred. Now the latest one that we have is your silver sulfadiazine with cerium nitrate, right? Just strike this off, it is misprinted here. It is silver sulfadiazine with cerium nitrate, with cerium, your silver sulfadiazine with cerium nitrate. It is again effective against pseudomonas, gram-negative, can penetrate eschar, no side effect. So this is now considered to be as the best topical agent. This is now considered to be as a best topical agent. This is now considered to be as the best topical agent. This is also an important table to remember. Clear? Okay. So this is with respect to all the topical agents that you should know with respect to burns. So for any questions? Okay. Can we move on? Okay. Chalo. So talk about the next one, that is going to be your thyroid swellings. In this optimum cytology criteria is your previous exam question. Again, important from our exam perspective. Now, according to optimum cytology criteria, what is the size of the needle? It can be anywhere between 22 to 26 gauge needle. Single best answer is going to be a 23 gauge needle. How many aspirates should be there? Minimum there should be 2. There should be 6 follicles per aspirator, and there should be around 10 to 15 cells per follicle. If these are satisfied, we call it as optimum cytology criteria. Now, there are two classifications that you should know with respect to optimum cytology criteria. Number one is your Thai classification, and number two, it is going to be your Bethesda classification. I want you to revise both of them. Now, Thai classification is for generalized thyroid swellings, and the Bethesda is for your your localized thyroid swellings. Okay? Thai for diffuse and Bethesda for localized thyroid swellings. Now, when you talk about the inflammatory thyroid swellings, again, we will be talking about 3 important inflammatory thyroid swellings. Number 1 is your Hashimoto's thyroiditis. Number 2 is your de Quervain's thyroiditis, and the third one is going to be your Riedel's thyroiditis. Now, the first question that they'll ask you, what is the type of the inflammation? Remember, Hashimoto's and Riedel's are the example of chronic. Hashimoto's and Riedel's, they are the example of chronic inflammatory lesions, whereas de Quervain's is an example of subacute. De Quervain's is an example of subacute. It is an example of subacute. So, small mistake here. This is a subacute. This is a subacute. Right, so Hashimoto's and Riedel's is chronic. De Quervain's is an example of subacute. What is the etiology behind them? Now, we all know that Hashimoto's is autoimmune, right? Your de Quervain's is post-viral upper respiratory tract infection resulting in cross-reacting antibodies. Riedel's is usually idiopathic, but it can be secondary to an autoimmune disorder also. It can be secondary to an autoimmune disorder as well. Now, what is the pathophysiology? Hashimoto's is antibody mediated, where you have an anti-TPO antibody. Now, this anti-TPO antibody will not be able to destroy the follicles. So it goes and activates the CD4 and CD8 cells, which is resulting in T cell dependent damage of the follicles. Whereas when you talk about your decurvins, it is a cross-reacting antibodies, and these cross-reacting antibodies, they will misperceive the thyroid follicles as foreign attack. Whereas your Riedel thyroiditis, it is of unknown etiology, but if it is an autoimmune, it is because of IgG4 class of antibodies. The HLA which are important to remember for Hashimoto's is B8, DR3 and DR5. This is your DR5. HLA, DR3 and DR5. Whereas your Hashimoto's is HLA B35, there is no specific HLA for your Riedel thyroiditis. So the usual age of presentation for Hashimoto's, it is 30 to 40 years. Decurvin can be seen at any age group. Riedel's is usually seen in age about 50 years. All these disorders are more common in females, so needless to tell you that all thyroid disorders are more common in females when compared to males. How will they present to you? Hashimoto's will have thyroid swelling with hypothyroidism. They will have thyroid swellings with hypothyroidism. With hypothyroidism. With hypothyroidism. Your decurvins will be a midline neck fullness with pain on swallowing, whereas your Riedel's is going to be massive midline neck swelling. It is going to be a massive midline neck swelling and associated pressure symptoms with hypothyroid status. It's a midline neck swelling. It's a midline neck swelling. This is a midline neck swelling and pressure symptoms, right? That is for Riedel's thyroiditis. Now, when you talk about the thyroid status initially, for Hashimoto's thyroiditis, initially you will be seeing hyper. There is no intermediate, but eventually you will see hypothyroid. For decurvins, initially hyper, intermediate hypo, eventually normal. Riedel's will remain hypo throughout its presentation. It will remain hypo throughout its presentation. When we talk about investigation for all inflammatory thyroid swellings, it is going to be ultrasound, thyroid function test and FNSE. And if it is anticipated to have the autoimmune, then anti-TPO antibodies. It is your anti-TPO antibodies. Here also you would do an ultrasound with the thyroid function test. There is no role of biopsy in an acute inflammatory disorder, so there is no FNSE here. Whereas here we will do an ultrasound with the thyroid function test. Along with that, we will also do an FNSE. You can also do an IgG4 class of antibody. You can also look for an IgG4 class of antibodies in Riedel's thyroiditis. Now, inflammatory thyroid swellings will not operate because surgeries are very difficult. They have surrounding adherence. There's a lot of plastering, and if you try to operate, you cause more damage. So when talk about Hashimoto's, I will give thyroxine, whereas for Riedel's also it is thyroxine. You don't need to do anything for decurvins because it's a self-limiting condition. It will resolve by itself. The only condition where you will try to operate if there's a severe pressure symptoms, and the surgery of choice for a severe pressure symptoms in an inoperable thyroid swellings, the answer is going to be hysterectomy, and that is what you have to remember. Now, when we talk about the thyroid cancers, now in thyroid cancer, we'll compare papillary cancers with follicular, anaplastic and medullary carcinoma, right? Now, when you talk about the origin, of each individual, papillary, it is going to be follicular origin. Follicular carcinoma is also going to be your follicular origin. Anaplastic is also going to be your follicular origin. Your medullary cancer is going to arise from parafollicular C cells. The most common thyroid cancer is papillary cancer thyroid. The most common in ectopic thyroid gland. In an ectopic thyroid gland. In an ectopic thyroid gland is going to be follicular cancer. The one which is associated with the worst prognosis is going to be anaplastic. And the medullary cancer, it is associated with Men syndrome. It is associated with Men syndrome. It is associated with the Men syndrome. Now, what is the age of presentation for each individual? When we talk about the age of presentation, this is going to be around 30 to 40 years. Papillary, follicular is going to be 40 to 50 years. Anaplastic is going to be age about 50 years. Medullary cancer, if it is sporadic, it is sporadic more than 50 years. If it is associated with Men syndrome, then under 20 years, under the age of 20 years. All these disorders are more common in females when compared to males. The most common gene mutation to be remembered. The most common gene mutation to remember is BRAF mutation for papillary, PTEN gene mutations for your follicular cancer, and RET gene mutation for your medullary cancer thyroid. And RET gene mutation has been your previous exam question. It's a previous exam question. Now, when we talk about risk factors, there are two risk factors. Number one, history of thyroglossal duct cyst and radiation exposure. And radiation exposure. And radiation exposure, right? Whereas for follicular cancer thyroid, it is long-standing goiter. It is your long-standing goiter. Now, anaplastic and your follicular medullary cancer thyroid does not have any specific risk factors. Clinical features, I'll tell you easy way to remember. If there is a solitary thyroid nodule-like presentation with cervical lymph node enlargement, that is a papillary cancer thyroid. If there is goiter-like presentation with a forehead bony swelling, with a forehead bony swelling. If a forehead bony swelling, it's a follicular cancer thyroid. Anaplastic cancer would be a massive midline neck swelling. A massive midline neck swelling with pressure symptoms. With pressure symptoms. With pressure symptoms, right? And the last one that you have is your medullary cancer thyroid. It will have solitary thyroid nodule-like presentation with diarrhea. The reason why there is a diarrhea, because medullary cancer thyroid produces excessive amount of 5-HT3, that is serotonin, and the effect of serotonin on GI mucosa is going to stimulate the GI mucosa and cause diarrhea-like presentation. The mode of spread for papillary, it is going to be via lymphatics. Your follicular is hematogenous, anaplastic is direct, and this is going to be both lymphatics as well as hematogenous. The most common site for metastasis, it is lungs for papillary cancer thyroid. Bones is going to be for your follicular. Again, this is going to be your, for direct route, it is going to be lungs, whereas medullary, it is liver, more common when compared to lungs. Okay. Now, when you talk about bones, follicular cancer thyroid will have osteolytic secondaries, and medullary cancer will have osteoblastic secondaries. They will have osteoblastic secondaries. They will have osteoblastic secondaries. They will have osteoblastic secondaries. है ना? चलो. Now, the investigation for all of them is ultrasound, TFT, FNSE, and thyroglobulin as the tumor marker. Remember, FNSE cannot differentiate. They cannot differentiate between follicular adenoma and follicular carcinoma. So, here we do lobectomy with frozen section. Here we will do lobectomy with frozen section. The tumor marker, see, everywhere else it is the same. The ultrasound will be there, TFT will be there, FNSE will be performed, and thyroglobulin here. Here we'll have everything same. So, medullary cancer thyroid also, there will be ultrasound, there will be thyroid function test, there will be FNSE, but the tumor marker here is going to be CEA and calcitonin. There are two tumor markers, the CEA and calcitonin for medullary cancer thyroid. Now, when you talk about papillary cancer thyroid on an HP, what are the findings that you see? The first one that you see is an orphan ANI nuclei. The orphan ANI nuclei is here. And then you have samoma bodies, which are the dystrophic calcification. The samoma bodies are dystrophic calcification that you'll see. What are the other conditions where you have samoma bodies? Remember PSM. What are the PSM that you have? Papillary variant of RCC. S stands for serous adenoma of ovaries, and M stands for meningioma. Are the three conditions where you'll have samoma bodies. Now, this is your oxyphilic cells, or also called as Ashkenazi cells, which are seen in follicular cancer thyroid, or also it's another aggressive variant. Presence of Ashkenazi cells tells you that it is a Hurthal cell carcinoma. Hurthal cell carcinoma is nothing but an aggressive variant of follicular cancer thyroid. Now, the last one that you can see, these are the amyloid strands which are present. Amyloid in stroma is our previous exam question, and this is seen in medullary cancer thyroid. Amyloid in stroma is a characteristic feature. Amyloid in stroma is a characteristic feature of your medullary cancer thyroid, and this is a very, very important characteristic feature. Okay? Now, as we spoke about MEN syndrome, we have MEN1 syndrome, which is also called as the Wermer syndrome. Then you have MEN2A, now it is called as MEN2, it is called as the Sippel syndrome. Now, MEN2B is no longer called as MEN2B, now we call it as MEN3, and then you have MEN4, right? So, you now have MEN1, MEN2, MEN3, and MEN4 disease, right? So, what is MEN1? Everything starts with P, pituitary adenoma, parathyroid adenoma, and pancreatic adenoma. It is pancreatic adenoma. Then you have pancreatic adenoma. Then you have the pancreatic adenoma. So, you have the pituitary adenoma, you have the parathyroid adenoma, and the pancreatic adenoma. Whereas for Sippel syndrome, you have parathyroid adenoma, medullary cancer thyroid, and pheochromocytoma, For MEN2B, which is called as MEN3, you have again the following ones, the mucosal neuromas, right? Then you have medullary cancer thyroid, then you have pheochromocytoma, right? There's another one called as marfanoid habitus also. There is marfanoid habitus. MEN4 is reproductive organ tumors with MEN1. So, features of MEN1 with reproductive organ tumors is what we call it as MEN4. So, reproductive organ tumors with MEN1 disease. With MEN1 disease is what we call it as MEN4. Right? So, this is all that you should know in the context of thyroid and associated ones. Clear? Okay. Chalo. So, what we'll do is we'll take a short break here. We'll take it for 15 minutes and then we'll resume back with the next session. Just give me one. Chalo. Right. So, we start with the BI-RADS scoring system. When I say BI-RADS, it is your breast imaging reporting and data system. See, you don't need to remember the entire BI-RADS. If you're able to remember, good, fair enough. But the exam perspective is BI-RADS 3 that I want you to remember, right? Now, what is BI-RADS 3? BI-RADS 3 is probably benign, right? Now, when it's probably benign, the probability of it being malignant is less than or equal to 2%. The question that they ask you is, after how many days would you ask the patient to come back for follow-up? Remember, the follow-up in BI-RADS 3 should be taken after 6 months, right? Call the patient for repeat imaging after 6 months, and that is the management that you will do for BI-RADS 3, and that's your exam question. Okay? So, BI-RADS 3 is your exam question. It is probably benign. Ask the patient to come back for follow-up after 6 months. Okay? Now, breast cancer is something they'll ask you again and again. So, we'll do a quick recap on the breast cancer. Now, the T staging of the breast cancer, if you take this a representation of the breast, this happens to be the pectoralis fascia. Let's say this happens to be the muscle. This is the pectoralis major muscle, and let's say this happens to be serratus anterior group of muscle. This is your serratus anterior group of muscle. This happens to be your serratus anterior group of muscle. Okay. Now, if the size of the tumor is less than 2 centimeters, limited to the size less than or equal to 2 centimeters, limited to the breast, it is what we call it as a T1 disease, right? If it is 2 to 5 centimeters, if it is 2 to 5 centimeters, again limited to breast. If it is 2 to 5 centimeters, limited to breast, it is your T2 disease. This is your T2 disease, right? If it is more than 5 centimeters and still limited to breast, if it is more than 5 centimeters and still limited to breast, more than 5 centimeters limited to breast is your T3 disease. It is your T3 disease, right? Now, any size of the tumor, if it is involving chest wall, this is called as T4A disease. This is your T4A. Any size, if it is involving the breast skin, it is called as T4B disease. This is what we call as T4B disease. Now, when I say T4B disease, it is the involvement of the skin. How do you know the skin is getting involved? If there is presence of ulceration of skin, if there is peyote orange, if there is presence of peyote orange, and the last but not the least, if there is presence of satellite nodules. If there is presence of satellite nodules, it is your T4B disease. Now, T4C is involvement of both chest wall and the underlying skin. If both chest wall and the underlying skin is involved, this is your T4C. This is your T4C. If it is an inflammatory breast cancer, if it is the inflammation, and if that inflammation of the breast skin is exceeding more than 1/3 of the breast skin, if more than 1/3 of the breast skin, if more than 1/3 of the breast skin is getting involved, if more than 1/3 of the breast skin is getting involved, this is your T4D. This is your T4D. So T4D is inflammatory breast cancer. T4D is an inflammatory breast cancer. T4D is an inflammatory breast cancer. It is an inflammatory breast cancer involving more than 1/3 of the breast skin. Involving more than 1/3 of the breast skin. Involving more than 1/3 of the breast skin. Now, this is what your exam question is that you need to remember. Now, in the entire TNM staging, the prospect that I want you to remember is stage 3A, 3B and 3C. You have stage 3A, 3B and 3C. Now, 3A, 3B, 3C is what we call it as the locally advanced breast cancer. This is your locally advanced breast cancer. Now, how do you remember locally advanced breast cancer? For 3A, remember as N2 disease. For 3B, remember as T4 disease. And 3C, remember as N3 disease. Now, if you remember this, this is more than enough. This is more than enough. This is more than enough to remember. This is more than enough to remember your TNM classification of breast cancer. Majority of the questions comes from 3A, 3B, 3C. This is how they usually ask you in the context of it. If you remember this, that is more than enough. Nothing more, nothing less in terms of breast cancer. Okay? Now, in terms of breast surgery, they'll ask you what is simple mastectomy, Whenever I say a simple mastectomy, I'll remove the stroma of the breast. I will remove the glandular component of the breast. I will remove the nipple and the areolar complex. I will remove the nipple and the areolar complex along with pectoralis fascia. Along with pectoralis fascia. Along with pectoralis fascia. This is a simple mastectomy. Radical mastectomy is also called as the Halsted's mastectomy. It is a Halsted's mastectomy, right? Now, when I say Halsted's mastectomy, what do you remove? Here, we will do simple mastectomy. We will perform a simple mastectomy. Along with simple mastectomy, what are the other structures that we are going to remove? I am going to remove both pectoralis major as well as pectoralis minor muscle. Plus, I will remove level 1, level 2, level 3 group of lymph nodes. I'll remove level 1, level 2, level 3 group of lymph nodes. This is called as radical mastectomy. In modified radical mastectomy, we will perform simple mastectomy. We will perform simple mastectomy with level 1, level 2 and level 3 group of lymph nodes. Now, based upon how you're going to do this modified radical mastectomy, you have 3 different varieties. The first one is what we call it as patties. Then you have Scanlens. And the third one is Auchincloss. If they ask you what is the most common modified radical mastectomy as of today, it is your Auchincloss modified radical mastectomy. It is your Auchincloss modified radical mastectomy. Okay? It's an Auchincloss modified radical mastectomy. So these are with respect to breast surgeries. Now, structures that should be preserved in a modified radical mastectomy can be remembered by mnemonic ABCDE. A stands for axillary vein. A stands for axillary vein. B stands for Bell's nerve, which is also called as the long thoracic nerve. C stands for cephalic vein. And D stands for nerve to latissimus dorsi. Nerve to latissimus dorsi. So, axillary vein, Bell's nerve, cephalic vein and nerve to latissimus dorsi. What are the complications associated with modified radical mastectomy? That can be remembered by a mnemonic called as SWAB. S stands for seroma formation, which is the most common post-operative complication. W stands for winging of scapula. W stands for winging of scapula, which is because of long thoracic nerve injury. A stands for arm edema. See, upper limb edema, if they ask you what is the most common cause for secondary lymphedema of the upper limb, the answer is post-modified radical mastectomy. B stands for black, and black indicates flap necrosis. Black indicates flap necrosis. Right? Black indicates flap necrosis. Now, there's another condition which is they're going to ask you what is your Stewart-Travis syndrome. What is your Stewart-Travis syndrome? Now, remember, Stewart-Travis syndrome will occur after 10 to 15 years post-modified radical mastectomy. If patient develops lymphangiosarcoma of the same side. So, ipsilateral lymphangiosarcoma of upper limb. Ipsilateral lymphangiosarcoma of the upper limb. This is what we call it as the Stewart-Travis syndrome. This is what we call it as the Stewart-Travis syndrome. The most important is your upper limb edema post-MRM will occur within 1 month of the surgery, whereas if it occurs after 10 to 15 years of surgery, then it is going to be your Stewart-Travis syndrome. It is Stewart-Travis syndrome. Okay? Sure. In the vascular surgery, 2 commonly asked questions would be comparison between the Berger's and atherosclerosis. Both of them are going to be your chronic arterial occlusions, right? So comparison between the two chronic arterial occlusion, one is your Burgess, another one is your atherosclerosis. Now, when you talk about Burgess, will be seen in age less than 40, athero is age above 50 years. Most important risk factor for Burgess is smoking, athero is obesity. Burgess, all four limbs are equally involved, whereas atherosclerosis is more common lower limb. Upper limb is almost unheard of. The size of the vessels, Burgess is usually small vessels, whereas athero is usually large vessels. They will have skip lesions, athero will have continuous lesions. The progression of Burgess is always towards the heart, that is distal to proximal, and atherosclerosis is usually away from the heart, that is going to be proximal to distal. Remember the structures which are involved in your Burgess, your artery, vein and nerve. It is the artery, vein and nerve. All these three structures will be involved, whereas in atherosclerosis, it is only the artery which is going to get involved. Only the artery which is going to get involved, right? So that's the difference between Burgess and atherosclerosis. Both of them are equally important. What is an ABPI index? It is an ankle brachial pressure index. How do you measure it? It has systolic blood pressure at the level of ankle with respect to systolic blood pressure at the level of brachial artery. So the systolic blood pressure at ankle, let's say it's 120, which is the basic one. Systolic blood pressure at brachial artery is also 120. So normal ratio would be 1. So it's a normal ratio of an ABPI index is 1 to 1.3. For a calcified blood vessel, it will be more than 1.3. For intermittent claudication, it is 0.5 to 0.9. We rather say, just remember it less than 0.9. Rest pain is less than 0.5 and critical limb ischemia is less than 0.3. It is a less than 0.3. So this is your ABPI index, which tells you about the severity of the disease. Now, whenever there's an atherosclerosis, now one table that I would like you to remember, that the site of occlusion, let's say the site of occlusion is iotoiliac. You have the iotoiliac occlusion, we have the iliac occlusion and the femoropopliteal occlusion. The femoropopliteal occlusion. Now, what they will usually ask you is, what is the status of intermittent claudication? What are the muscles which are involved? And what is the management that you can perform for all of them? So let's try to decode them. So we'll talk about the intermittent claudication. When we talk about the intermittent claudication. Now the intermittent claudication for iotoiliac is bilateral. For other two, it is unilateral. Now usually when you look at this, what are the muscles? Number one is gluteus muscle. Number two is thigh muscle. And number three is your calf muscle. Now, when you look at these representation, right? So the first one is gluteus muscle. So gluteus muscle is involved in iotoiliac. Gluteal muscle is spared. Thigh muscle is involved in these two. It is spared in femoropopliteal. The calf muscle is involved in iotoiliac, iliac as well as femoropopliteal, right? If they ask you in terms of management, it has to be a bypass. For iotoiliac, we do an ioto bifemoral bypass and ioto bifemoral bypass. An ioto bifemoral bypass. Here it is an iotofemoral bypass. It is an iotofemoral bypass. And the last one is your iliopopliteal bypass. It is an iliopopliteal bypass. And if they ask you what is the graft that we are going to use, what is the graft that we are going to use? The graft that we use for iotoiliac, it is going to be Dacron. For iotofemoral also, it is going to be Dacron. For femoropopliteal, it is the autologous reversed. It is an autologous reversed great Saphenous swing. It is the autologous reversed great Saphenous swing. ठीक है? Correct. Right. So this is with respect to atherosclerosis that you should be aware of. Clear? Chalo. Now, the SEEP classification in varicose vein, as we have discussed it, is very, very important. C0, where there is no evidence of venous ulcer or venous disorder. C1 is present of telangiectasia and reticular veins. Telangiectasia is the diameter of the vessel is less than 1 millimeter. Reticular is 1 to 3 millimeters. Full-blown varicose vein is what we call as C2, that is going to be 3 millimeters. Now, there was a small bouncer here. They said what is C2A, that is, and C2S. C2A is asymptomatic and C2S is symptomatic. Symptomatic varicose vein. And then there's something called as C2R, which is a recurrent varicose vein. So do not forget about this. So I've already given you the C2R is nothing but your recurrent varicose vein. Now from here onwards there will be complications. C3 is edema, C4A is pigmentation, that is because of hemosiderosis. It is hemosiderosis. There's an R. It's an hemosiderosis. Hemosiderosis is hemosiderin plus melanin. C4B is going to be lipodermatosclerosis. C4B is your lipodermatosclerosis. Now, the lipodermatosclerosis will result in woody limb. They will result in woody limb, or also referred to as the inverted champagne bottle appearance. Inverted champagne bottle appearance. Inverted champagne bottle appearance. C4C is your coronophlebectatica. Now, this coronophlebectatica is what we call as the malleolar flare. It is what we call as the malleolar flare. Now, you have the C5, which is your healed venous ulcer, not heated. It is your healed venous ulcer. Then you have C6 is your active venous ulcer and C6R is your recurrent venous ulcer. So C classification is very, very important, right? So this is with respect to varicose vein. Now again, E is your etiology, P is your pathophysiology. So EP stands for if it is a primary etiology. If it is secondary to some cause, we call it as ES, which is called as the secondary etiology. And EN indicates no etiology identified. Now, based upon the pathophysiology, is it because of reflux of blood flow, which is called as PR? Is it because of obstruction due to blood flow, which is called as PO? Is it because of both obstruction and reflux, which is called as PRO? And PN stands for no pathophysiology identified. There is no pathophysiology identified, right? Based upon the anatomical location, we have AS involvement of superficial venous system, AD is involvement of deep venous system, AP is involvement of perforator system, and AN indicates no anatomical site identified. AN stands for no anatomical site identified. There is no anatomical site identified. So this is your SEEP classification. Now, on a varicose vein, if there is a cephalofemoral junction incompetency, and if you perform an ultrasound, the sign that you see is what we call it as the Mickey Mouse appearance. This is your Mickey Mouse appearance. So when I say a Mickey Mouse appearance, you have a big face and two big ears. So the big face is your common femoral vein. This is your great saphenous vein and the common femoral artery. So one ear is a common femoral artery. One is going to be your great saphenous vein, and the face is going to be your common femoral vein. It's a common femoral vein, and this is what we call it as the Mickey Mouse appearance, right? This is what we call it as EC stands for congenital beta. EPES, primary and secondary you have. See, if it's a congenital will be all primary causes, no? ठीक है, चलो. Talking about plastic surgery, few important topics. Grafting is something that they'll ask you again and again. They never get tired. So the comparison will always be between a partial thickness and a full thickness skin grafting. The comparison is going to be between a partial thickness and a full thickness skin grafting. Between a partial thickness and a full thickness skin grafting. Now, when I say the composition of a partial thickness skin graft, it is going to be your epidermis. It's only the epidermis that you're going to take, and this epidermis, when you take it, is called what we call it as the Thierch graft. This is what we call as Thierch graft. This is also called as SSG, which is a split thickness skin grafting. So there is a partial thickness skin grafting, right? So in a partial thickness skin graft, you say the epidermis and a part of a dermis is taken. Okay? So it is an epidermis along with the part of dermis. This is what we call it as the Thierch graft, or also commonly called as the SSG, which is split thickness skin grafting. For a full thickness, we call it as the Wolfie's graft, right? So Wolfie's graft is a full thickness skin graft where we take the epidermis and the entire dermis. We take the epidermis and the entire dermis put together is what we call it as full thickness or a Wolfie's graft. Now the device that we take is either a Hembe's knife or an electric dermatome. Either an electric dermatome, both are going to be for the same, right? So here also, you're going to take both Hembe's knife or an electric dermatome. Now, donor side defect is important. Whenever you take a partial thickness skin graft, wherever you take the graft from a donor side, that will heal automatically. So hence the defect will remain temporary, whereas a full thickness, it will leave a scar behind. It's a permanent defect. The most common site from where you take the partial thickness is thigh, whereas the full thickness is retroauricular, that is behind the ear. There is no scar after a partial thickness skin grafting, but a full thickness skin grafting will be there a scar. I'm talking about the donor site scar. We're talking about the donor site. We're talking about the donor site scar. For a partial thickness, there is no donor site scar, but a full thickness, there will be a donor site scar. Now, because the donor site is getting affected in a full thickness, for a partial thickness, no, when it comes down to size, you can take any size, but full thickness, we prefer small. The graft survival is good for partial, poor for full thickness. The graft contracture is more with secondary contracture in your partial thickness, and a full thickness primary is dominant. What is primary contracture? What is the secondary contracture? Now, when you imagine that this is the donor site and from here I'm taking the graft out. Now, as soon as you take the graft from the donor side, it will immediately contract. This immediate contraction is called as primary contraction. And after you put the graft to a recipient side and slowly when it contracts, it is called as secondary contraction. Whenever you have more of secondary contraction, there will be poor cosmesis. Whereas whenever you have more of primary, less of secondary, that means the graft will sit as you have put. So the cosmetic outcome will always be good, right? But for full thickness and partial thickness, the only thing you have to adjust is the thickness of the knife. So it is going to be both Hembe's knife. You can take full thickness as well as partial thickness skin grafting. Okay? Now the graft, when you talk about cosmetic outcome, as I just told you, wherever you have dominant primary contraction, you will have good cosmetic result. So hence full thickness will have a good cosmetic result. A full thickness is going to have a good cosmetic outcome or the result. Now, what are the causes for graft failure? The causes for graft failure is seroma formation and hematoma. It is seroma and hematoma which causes graft failure. How do you prevent their collection? To prevent the collection of hematoma and seroma, you can actually do something called as pie crusting. Now, pie crusting, it prevents the seroma and hematoma collection, and on top of it, pie crusting also increases the surface area of the graft. Also increases the surface area of the graft anywhere between 1.5 to 6 times. anywhere between 1.5 to 6 times. That means a 10 centimeter skin graft can be stretched anywhere between 15 to 60 centimeters. That is a hematoma and seroma formation. Second, it can be because of repeated movement. It can be because of repeated movement at graft site, at the grafting site. How do you prevent this, right? So in order to prevent movement, you now apply slab one joint above. You apply a slab one joint above, right? That is your for repeated movement. If there is secondary to infection, now how do you prevent this? So we do a pre-operative wound site culture. We do a pre-operative wound site culture. Now when you do a pre-operative wound site culture and if there is presence of beta hemolytic streptococci, presence of beta hemolytic streptococci is an absolute contraindication. This is an absolute contraindication for skin grafting. This is an absolute contraindication for skin grafting. Okay? So, this is in terms of infections, right? Another reason for graft failure, if there's a poor vascularity at the your grafting site. If there is poor vascularity. One such example is if there is absence of periosteum on the bone. If there is absence of periosteum on bone. If there is absence of periosteum on bone, that also causes graft failure, right? Seroma hematoma formation, repeated movement at grafting site, infection and poor vascularity are the important causes for graft failure. Now, this is again your famous and the favorite exam question. It is between the cleft lip and the cleft palate repair timings. Okay? Now, for a unilateral cleft lip, I would like to repair between 5 to 6 months of age. For bilateral cleft lip, it is 4 to 5 months of age. Soft palate at 6 months, hard palate is between 15 to 18 months. It is between 15 to 18 months. If it has both soft and hard palate, then we will require 2 surgeries. The first surgery is going to be for soft palate and that is at 6 months. The second surgery is going to be for the hard palate and that is between 15 to 18 months. 15 to 18 months. If it is both cleft lip and palate and it is unilateral, again it will require 2 surgeries. The first surgery we will do for the cleft lip and the soft palate. This will be done at 5 to 6 months of age. The second surgery will be done for hard palate between 15 to 18 months. If it is a bilateral cleft lip, there will be again 2 surgeries with palate. The first surgery will be for lip and the soft palate between 4 to 5 months of age and the second surgery will be done for the hard palate and that is will be between 15 to 18 months. Between 15 to 18 months. Between 15 to 18 months. Okay. Clear? बेटा meshing will have more area. देखो pie crusting और meshing में जो फर्क है ना, what is the difference is when you look at the meshing, you will see it's a machine where it will create. If you look at this, a meshing will have a uniform distribution. This is how the meshing would look like. So when you mesh the skin would look like this. So there's a proper area that we create. So right, this is how the meshing would actually look like. a uniform, it's like a net that creates, this is called as meshing. Whereas in pike rusting, you see there are only stab wounds. Now, just to tell you what is the difference between pike rusting. Now, this is, let's say, the entire skin. Let's say this is the entire skin that you have. In pike rusting, you will have small stab incisions. So what we'll do is, we'll put stab incisions like this. This is your pike rusting. This is your meshing. That's the difference between pike rusting and meshing. ठीक है? ठीक है, चले. चलो. Can you move on? Now we'll talk about nutrition again. Favorite topic for your INI people. Now, the current indication for nutrition that you have is short bowel syndrome, where the length of the small intestine, is less than 200 centimeters. High output enterocutaneous fistula, where the output is more than 500 ml in 24 hours. If the output is more than 500 ml in 24 hours, presence of acute active inflammatory bowel disease, initial phase of your acute pancreatitis, and if there is a prolonged ILS which is beyond 72 hours, a prolonged ILS of more than 72 hours, now that is an indication for total parenteral nutrition. Now, when you talk about TPN, we usually get 1 to 2 liters of TPN in 24 hours. The carbohydrates. So, when you see, again, a very important aspect is you should know the composition and their ratios. Both of them are equally important. 1 second, guys. So far, any doubts? I got a message. All clear? ठीक है? All clear? ठीक है, चलो. So in terms of composition, when you talk about carbohydrates, the carbohydrate consists of 40 to 50% of the total volume of the total parenteral nutrition, and the energy released by carbohydrate is 3.5 kilocalories per gram. Okay. Fat consists of 30 to 40% of the total volume, and they generate 9 kilocalories per gram. Protein consists of 10 to 20% of the total volume, and they generate around 4 kilocalories per gram. This energy is important. They've asked you in the exam, they've given you 100 grams of carbohydrate, 50 grams of fat, 200 grams of protein. What is the total energy that is released? So you should be able to calculate in the same context, right? So when we say that vitamins as well as your trace elements, they are negligible. They are negligible. They are present, but they are not quantified, and the energy contribution is next to nil, right? So, it's the composition of TPN and the energy that is going to be released via the total parenteral nutritions. Now comes the trauma, again a very, very important topic. So, in the trauma, the first thing that they'll ask you is with respect to triage. Now, triage is a color coding system, we all know it. There are two ways that you can do a triage. Number one, based upon the resources that is required for the treatment versus resources that are actually available. Resources required versus resources actually available. Another way of classifying the triage is it is categorize the patient on the basis of outcome when compared to severity. So, outcome is weighed when compared to severity. So outcome is preferred when compared to severity. Black is brought dead patient. Red indicates emergency. This requires immediate attention. Yellow indicates urgent. Green indicates delayed orientation. Green indicates delayed orientation. Okay. The most important is red. The most important is red, and black is considered to be least important. Black is your least important and red is considered to be most important. ठीक है? चलो. Okay. One new update in the triage, in your ATLS protocols is now we don't follow ABCD, we now follow XABCDE protocol. This is the new update from ATLS, that is your 11th edition. What is this XABCD stands for? X stands for controlling exsanguinating hemorrhage is given priority. This is according to the 11th edition of ATLS. This is on the basis of 11th edition of ATLS. The priority is given for X, that is your controlling exsanguinating hemorrhage. That is of highest priority. Okay. Now, we have the hemorrhagic shock divided into various classes based upon their volume loss. We have to categorize them. Let's quickly look at that as well. Now, if the percentage of blood loss is less than or equal to 15, it is your class 1. If it is 15 to 30%, it is class 2. If it is 30 to 40% of volume loss, if it is class 3. More than 40% of volume loss, it is class 4. Okay. Now, what happens to these parameters is heart rate, blood pressure, pulse pressure, respiratory rate, urine output, GCS, and blood transfusion requirement. In class 1 hemorrhagic shock, you see all of them remains normal. Heart rate is normal, blood pressure is going to be normal, your pulse pressure is going to be normal, your respiratory rate is normal, your urine output is normal, your GCS is normal, and there is no requirement for blood transfusion. There is no requirement for blood transfusion. In class 2 hemorrhagic shock, you see the heart rate picks up, the blood pressure remains normal, the pulse pressure remains normal, the respiratory rate remains normal, urine output starts to reduce, GCS remains normal. There is no need for blood transfusion here also. In class 3 hemorrhagic shock, the heart rate picks up more. The systolic blood pressure may remain normal or drop down. Pulse pressure will start to decrease. Respiratory rate will start to increase. Urine output will become oliguria, that is less than 0.5 ml per kg per hour. GCS will start to decrease. Blood transfusion will be required here. Class 4 hemorrhagic shock, heart rate is already picked up. The systolic blood pressure drops down. The pulse pressure decreases further. Respiratory rate goes higher up. Here it becomes anuria, complete absence of urine. Patient is unconscious. So GCS is poor and requires massive blood transfusion. Will require massive blood transfusion. But all these are going to be while the body is trying to compensate. This is all compensation. Decompensate means everything is going to be falling. Everything is heart rate will dip down, blood pressure will dip down, pulse pressure will dip down, respiratory rate will dip down. In a decompensation, body will not show any signs of revert, right? There is no sign of fighting. So all these are in compensated status. Clear? Okay. Chalo. When we talk about the head injury, again based upon the GCS score, they are important. When we talk about the minor head injury, the categorization of minor head injury is the GCS of the patient will remain 15/15 with no loss of consciousness. Mild head injury, the GCS can be 15 or 14 with history of loss of consciousness post-trauma. For moderate head injury, GCS is going to be 9 to 13. For severe head injury, the GCS is going to be less than or equal to 8. Now, this severe head injury is an indication for prophylactic intubation. This is an indication. This is an indication for prophylactic intubation. This is an indication for prophylactic intubation. This is an indication for prophylactic intubation. For prophylactic intubation. Okay. Now, another commonly asked question is the difference between EDH versus SDH, that is your extradural hemorrhage. EDH, that is your extradural hemorrhage, versus SDH, that is your subdural hemorrhage. Now, if I have to do a comparison between EDH and SDH, we say EDH is collection of blood between dura and the skull bone. SDH is between dura and the arachnoid membrane. Now, you will see it is more common in younger patient EDH, whereas SDH is more common in your elderly patients. Now, EDH is associated temporal fracture, and the most common bony part is going to be pterion, whereas here it is going to be because of hit or blow onto the elderly patients. And usually when you talk about the most common source, the middle meningeal artery is the most common source for EDH, whereas cortical bridging veins is for SDH. See, either of them, let it be EDH or SDH, they will have the blood clotted into the brain, or that is in the skull, or I can say the CNS cavity. It's a very confined space. Both of them will have space occupying component. They will have raised intracranial pressure. So what is the difference? How will they come on a variable state? Now the concept is very simple. If the signs and symptoms of raised ICT occurs suddenly and they are rapidly progressing, it is your EDH. If they occur gradually and they're slowly progressive, it is SDH. That is the only difference that you need to know. Remember, if the signs and symptoms of raised ICT is going to be present, so sudden increase in intracranial pressure with lucid interval is EDH. Gradual increase with a fixed dilated pupil is going to be your SDH. Investigational choice for both of them is going to be an NCCT. Here you will see a biconvex opacity or a lenticular opacity, whereas here you will see a concavo-convex opacity or a crescent opacity. The management or a definitive management. The definitive management for EDH is going to be craniotomy, whereas for SDH, if it is small, it is conservative. If it is large, then it is going to be craniotomy. And if it is a chronic SDH, then it is going to be burr-hole surgery. Definition of chronic SDH is an SDH which is lasting for more than 21 days with symptoms. Then you will do a burr-hole surgery. There is no indication of burr-hole in EDH, beta. Please do not mark it. That was a previous exam question also. Now you can see the opacity that you can see here. This is a biconvex opacity, or also called as lenticular opacity. Here you can see one is your concave, another one is your convex surface. It's a concavo-convex opacity. It is a concavo-convex opacity, or also called as lenticular opacity, which is seen in SDH. Now, diffuse axonal injury is again repeatedly asked exam question. The question will start: a patient having a traumatic head injury comes to you into the casualty with coma. When you do a CT, it is normal. Post-traumatic coma with CT normal, the most common likely answer is going to be your diffuse axonal injury, where we say there is a complete disruption of axons between the white and the gray matter due to a traumatic injury, right? Now, post-trauma, the patient will now present to you with coma. The patient will now present to you with coma. When you do an NCCT, the NCCT will come out to be normal. So hence, I will now go with MRI. The investigational choice is MRI, and there's presence of punctate hemorrhage. When you do an MRI, you will see there's presence of punctate hemorrhage, and that punctate hemorrhage is going to be between the white and the gray matter. And remember, it is associated with very poor prognosis. It is associated with very poor prognosis. So diffuse axonal injury is associated with very poor prognosis. Okay. Beta, this session is intended until 9 o'clock, right? We'll try to finish as much as we can, and whatever is left out, we'll do another session. Okay, so don't worry about it. So you can see in MRI, these dots, white dots, these are your punctate hemorrhages between the white and the gray matter. Okay, chalo. Now, what is a Cushing's triad? Cushing's triad I've given you here. So Cushing's triad is going to be hypertension, bradycardia, and irregular respiratory rate. And Cushing's triad is seen in raised intracranial pressure. It is seen in raised intracranial pressure. Remember, the normal intracranial pressure is going to be 5 to 15 millimeters of mercury. Just 5 to 15 millimeters of mercury. How do you manage your raised ICT? The management will be number one, intubate and ventilate the patient. Start the patient on oxygen. Give mannitol and make sure that your target intracranial pressure should be less than 20 and your target cerebral perfusion pressure should be more than 60 millimeters of mercury. It is a 60 millimeters of mercury. It is a 60, that is target cerebral. CPP is CPP stands for cerebral perfusion pressure. How do you calculate CPP? The cerebral perfusion pressure is calculated as mean arterial pressure minus intracranial pressure. So this is the pressure required to perfuse the brain. This is the pressure required to perfuse the brain. The normal CPP should be around, when you calculate it, you'll see 90 to 110 is the normal CPP. The minimum CPP required to perfuse the brain is about 60 millimeters of mercury. Okay? Clear? Chalo. Now, what is the lethal triad of trauma? The lethal triad of trauma, I have given you the three components of lethal triad of trauma. It is metabolic acidosis. It is metabolic acidosis with coagulopathy. And hypothermia. With coagulopathy and hypothermia. So metabolic acidosis with coagulopathy and hypothermia is what we call as lethal triad of trauma. How do you prevent metabolic acidosis? To prevent metabolic acidosis, the fluid of choice for resuscitation is ringer lactate. How do you prevent coagulopathy? Whenever you're doing a transfusion, we will do PRBCs, FFP and platelets in a ratio of 1:1:1 to prevent coagulopathy. And in order to prevent hypothermia, we will be giving warm crystalloids. We'll be giving warm crystalloids infusion. We will be giving warm crystalloid infusion. We'll be giving a warm crystalloid infusion. So to prevent lethal triad of trauma, this is how we are going to take care of it, right? So this is with respect to lethal triad of trauma. Then you have something called as damage control surgery. DCS stands for damage control surgery. Stages of damage control surgery. Now, in the damage control surgery, what is the stage 1? The stage 1 of the damage control surgery is your patient selection. You should know which patient will require a damage control surgery and which can be taken care by ETC, that is your early total care. Stage 2 is going to be your primary exploration. It is your primary exploration. Now remember, the goal for primary exploration, it is to control the hemorrhage and prevent any further contamination, right? So it is basically to control hemorrhage and prevent any further contamination. It is to prevent any further contamination. Prevent any further contamination. And control hemorrhage. That is your stage 2. Stage 3 is basically shift the patient to ICU and stabilize it, right? So goal for stage 3, it is to treat hypothermia and coagulopathy and then take for stage 4. Stage 4 is your secondary exploration and goal here is to correct the anatomy. And the last one is your stage 5, which is your definitive abdominal closure. So in all the other stages, it will all be a temporary abdominal closure, but stage 5 will be a definitive abdominal closure. And this was your last year's INI question. That is your damage control surgery. Clear? So this is with respect to stages of damage control surgery. Stages of damage control surgery. Okay. Now, for all abdominal traumas, we do something called as FAST, which is focus assessment sonography and trauma, where we start with 4P evaluation, where it starts with perihepatic. It is perihepatic, followed by pericardial, then perisplenic, it is your perisplenic and pelvic. Perisplenic and pelvic. Now, in order to overcome, we started with E-fast, what is an extended fast. Now, in an extended fast, we added the thorax also. So here we evaluate the right thorax, the left thorax, the right upper abdomen and the right lower abdomen, with the left upper abdomen and the left lower abdomen. So this is your extended fast. This is your extended fast. The minimum fluid required for the fast to be positive is going to be 100 cc, right? So minimum fluid required, the minimum fluid required for the fast to be positive is going to be 100 cc. It is going to be 100 cc. Okay? Sure. Now, this is in pneumothorax. So, what are the USG findings of pneumothorax is again your exam question. The USG findings of pneumothorax. The USG finding of pneumothorax, number 1, absence of seashore sign. Absence of seashore sign. Number 2, presence of stratosphere sign. And third one is barcode sign. Third one is a barcode sign. So absence of seashore sign, stratosphere sign and the barcode sign. So these are the USG findings of pneumothorax. These are the USG findings of your pneumothorax. Clear? Now we'll start with the solid organ trauma, which is again a very important one. We have the splenic injury, but before that we'll just quickly run through a few of the important exam questions. Which is the most common organ injury in abdominal trauma? The answer is going to be liver. See, I did not specify as blunt or penetrating. If they ask you overall most common abdominal organ to be injured, the answer is going to be liver. If they ask you specifically in blunt trauma, then you can answer spleen. And for penetrating trauma, you can again go ahead and answer liver, right? Now, for a car seatbelt injury, it is going to be mesenteric tear. And for your blast injuries, it is going to be small intestine. See, for blast, overall most common is tympanic. In a blast injury, overall most common organ injury is a tympanic membrane. And if they ask you the most severe is going to be lungs. The most severe is going to be lungs. The most severe, it is going to be lungs. Okay. So this is with respect to splenic trauma. I mean, like overall abdominal trauma. Specifically in spleen injury, we'll quickly talk about the grades of the injury. This is on the CECT. We talk about the CECT grading. This is the CCT grading of splenic injury. Beta, अगर underwater है ना, somebody is asking sir underwater blast injury. Now underwater में भी ना एक small scenario है. क्या है? If you're talking about underwater, there are two scenarios where the head is outside the water and other one's head inside the water. So we call it as head out and head inside. If head is out, then the most common. If head is out, then the most common is going to be bowel. If head is in, the most common is still the tympanic membrane. The most severe is still going to be lungs here. Here also the most severe is still going to be lungs. So do not goof up with these. Okay? Clear? So please do remember this. So when I say head out and head in, what do you mean by head out and head in? Imagine that this is the lake. Imagine that this is the lake that is present. What is the head A out and head in? Okay. If there is the water that is present, okay, there is also the water that is present here. I imagine this is the depth of the lake. When I say head is out, here the patient is sticking the head out and watching what's happening. This is your head out. The head in is where he is diving deep into the water and he is swimming. This is the head in and head out. Okay? So this is the head out guy, this is the head in guy. Clear hai? Chalo. Now let's go with the CCT of your splenic injuries, where the grading that we have. Now when you talk about the solid organ injuries, we'll talk about the hematoma, which occupies the surface area and it goes into parenchyma, and also the laceration, what is the depth of that particular one. Now if the hematoma is going to be less than 10% of the total surface area, if it is less than 10% of the surface area, depth of the laceration is less than 1 centimeter, is grade 1. If the hematoma is 10 to 50% of the total surface area and the depth of the laceration is between 1 to 3 centimeters, is grade 2. If it is more than 50% of the total surface area and the laceration is more than 3 centimeters, it is grade 3. For grade 4, it is intraparenchymal hemorrhage. It is your intraparenchymal hemorrhage. This is your intraparenchymal hemorrhage where more than 25% of spleen is devascularized. Where more than 25% of spleen is devascularized. Grade 5, it is completely shattered spleen. It is a completely shattered spleen, but the spleen is broken down into smaller pieces. Okay. Now it is very simple for us to remember. For all grade 1 and grade 2, it is conservative management. So we say conservative. And grade 4 and grade 5, it is emergency splenectomy. This is going to be emergency splenectomy. We do an emergency splenectomy, right? Now, usually the confusion is what to be done with grade 3. Okay. Now what we do is in grade 3, we see whether the patient is stable or unstable. We'll see whether the patient is stable or whether the patient is unstable. If the patient is stable, it is conservative. So we all know conservative management is done in grade 1, grade 2 and grade 3 stable. For all conservative managements, I am going to repeat the CECT after 24 hours. And after repeating, I'll see if there's increase in grade. If there is increase in the grade of injury after 24 hours, if there's increase in the grade of injury, I will do a CT angio. In the CT angiography, I will look for contrast blush. If there is presence of contrast blush, that means leak, then I would go with angioembolization. If the angioembolization fails, if the angioembolization fails, if the angioembolization fails, then I will do surgery. For an unstable patient, I will also do surgery. Surgery here is going to be splenography. It is your spleen preserving surgery for low grade injuries. We'll do splenography. Now this is what you have to remember. This is what you have to remember for your grade 3 or the all stable injuries per se. Grade 4, grade 5 emergency splenectomy for an unstable patient. That's it. Clear? Okay. Now, post splenectomy vaccination is very important. So you will give pneumococcal, meningococcal and H influenza B. Give pneumococcal, meningococcal. Pneumococcal, meningococcal and H influenza B. And the H influenza B. Now, all these are given if you're doing an emergency splenectomy or elective splenectomy. All three vaccines should be given 2 weeks prior to surgery. 2 weeks prior to surgery in elective splenectomy. In elective splenectomy. In emergency splenectomy, one that you should give an immediate post-op and one within 2 weeks of surgery. One that you have to give an immediate post-op. Another one within 2 weeks of surgery. Immediate post-op is pneumococcal. And within 2 weeks period of time, we give meningococcal and H influenza B. We give meningococcal and H influenza B. And the H influenza B. So this is your post splenectomy vaccinations. 2 days आफ्टर इमरजेंसी सर्जरी सर कॉन्ट्रास्ट ब्लश का मीनिंग है बेटा कि जब आप एंजियोग्राफी करते हो और जो कॉन्ट्रास्ट है अगर वेसल से लीक कर रहा है उसको आप कॉन्ट्रास्ट ब्लश बोलते हो. कॉन्ट्रास्ट ब्लश का जो बेसिक ऑब्जेक्टिव है ना, इफ आई हैव टू शो यू व्हाट अ कॉन्ट्रास्ट ब्लश बेसिकली मींस, इफ दिस इज अ ब्लड वेसल, ठीक है, व्हेन यू गिव अ कॉन्ट्रास्ट टू द ब्लड वेसल द कॉन्ट्रास्ट शुड फ्लो. ठीक है, अब मान लो कि ये आपने कॉन्ट्रास्ट दिया तो कॉन्ट्रास्ट विल गो इनटू द ब्लड वेसल, दिस इज द नॉर्मल वन. लेकिन अगर इस ब्लड वेसल में इंजरी है, इमेजिन इफ देयर इज अ स्मॉल इंजरी इन द ब्लड वेसल, अगर मान लो कि छोटी सी इंजरी इस ब्लड वेसल में, तो व्हाट विल हैपन टू दिस कॉन्ट्रास्ट विल लीक फ्रॉम हियर and then it will get accumulated at this area, and this accumulation of contrast outside the vessel इसको आप contrast blush बोलते हो. It is like a blush. This is what we call it as contrast blush. ठीक है, clear? So this concludes your entire discussion on general surgery. ठीक है, so far clear? So far any questions? कोई सवाल, anything that you want to ask, quick feedback? Clear guys? Quick feedback. Anything that you want to ask? कोई सवाल, कोई शक? Quick feedback. बेटा इमीडिएट पोस्ट ऑप मतलब सेम डे ऑफ द सर्जरी. सर्जरी कर दिया, पोस्ट ऑप में आप पहला वैक्सीन दे दोगे नीमोकोकल का. एक और क्वेश्चन दैट दे कैन आस्क इज व्हाट इज द वैलेंसी ऑफ वैक्सीनेशन दैट यू गिव. देखो नीमोकोकल वैक्सीन, नो, योर माइक्रोबायोलॉजिस्ट विल टेल यू दैट व्हेनेवर यू गिविंग अ नीमोकोकल वैक्सीन, you will see whether the age of the presenting patient is it less than 2 years or more than 2 years. If it is less than 2 years, then you have to give a P7 valent vaccine, and if it is more than 2 years, then you give PPV 23. That's one thing that you need to understand. बेटा ओवरऑल ब्लंट ट्रॉमा स्प्लीन पुराना आंसर है. there's an update I've been telling you from a very long time. Even the Washington Manual of Surgery is also updated that it is liver overall, क्योंकि when I say blunt, I mean trauma to the abdomen, it includes both blunt and penetrating, right? So दोनों मिला के अगर देखोगे सबसे ज्यादा आपका लिवर है, ब्लंट में स्पेसिफिकली स्प्लीन है, पेनिट्रेटिंग में फिर अगेन लिवर है. ठीक है, ठीक है, चलो. So this is all for today. We'll have one more session for systemic surgery. So we finished the entire general surgery. Now in the systemic surgery, you will have GIT, you have urology, right? There are 2 parts that you have for systemic surgery that will catch up for the next session. Thank you so much for joining. Take care. Bye bye. And if you have any questions, do reach us out. You can ask the questions on PW MedEd Telegram channel. We have our Instagram channel. You can reach out to me personally also on my Telegram, my Instagram channel. That is going to be the Surgery Guy with Dr. Sandeep Seeram Reddy, right? Thank you so much. We will meet you for another session of general surgery soon. Bye bye. Yeah, we'll try to squeeze in the next class within this weekend, beta. Ciao.